Can I get the intro slides up? Wow, quieted down fast. Well, good morning. Those of you I haven't met, I'm Fred Lublin, and I'm delighted that you're here for the 10th advanced course in multiple sclerosis. And in a moment, I'm going to show you some introductory stuff. Nope, this is Joe's talk. So, in any event, what we have for you today is a spectacular faculty, about 10 hours of intensive learning in multiple sclerosis with 15 lectures, 3 symposia, and 1 debate, which should be very interesting. So we hope to keep you engaged for all that time. Let me show you some of the, no, still Joe. So one more time, guys. Okay. What's over on my left is not coming up on here. I just want to show you a few of the things we're going to do when we do this. We like very much, now we're in business, for this to be interactive. So this is CME for the most part, and the event is supported very kindly by educational grants from EMD Serono, Novartis, Sanofi, and TG Therapeutics, and the presentations for the CME is academic CME, and the good folks from there are in the back. If you need any help, please grab one of them, and they will assist you with this. I'm still not going here. The agenda, but I didn't think I wanted the agenda. Anyway, as I told you, it's a busy agenda, lots of lectures from a very distinguished faculty. Busy day. If you were sent the pretest, if you've not completed it online, please visit this code and take the pretest. That's important for maintaining the CME. And so we see what you've learned over the course of the day. So there's that code. You can get it as well from the academic CME folks. This is really important and hopefully won't leave. This code is for submitting questions. So I have a little iPad up here where I will triage the questions to the faculty. And while we will have a mic that circulates in the room, it's probably easier for us to deal with questions through the iPad. So send them in or raise your hand as we go along. We want to make sure that all questions get answered. This is academic CME's credit designation statement, which you can read somewhere, probably online, but is not of importance right now. Financial disclosures are available online. None interfere with their ability to give these CME lectures. What's next? Okay, so that's enough of the introductory stuff. So as I say, busy day, but again, very important that we keep this interactive. So don't be afraid to ask the questions. And of course, when they come in through the app and the iPad, you can be anonymous if you wish. Also, the faculty will be around during the breaks and such for you to interact with them as well. So we're going to get started, and our first speaker is Dr. Berger, Joe Berger, Emeritus Professor from the University of Pennsylvania, who is going to take on the challenging topic of McDonald 2024, which is presented a few times in the past, not nearly as successfully as you'll hear from Joe. And I will tell you that the paper, which will then become McDonald 2025, is practically finished and ready for submission. So Joe, welcome.
Good morning, and I want to thank the organizers for inviting me. I thought before I talk about McDonald 2024 or 2025, whatever you call it, it would be helpful to understand how we got to where we are currently. So I'm going to actually start with Charcot. Charcot framed this illness multiple sclerosis, or what he called sclerosis en plaques, in a series of lectures that he gave in the Salpêtrière in 1868. And his first patient was actually his servant, a person named Luke, who had intention tremors, and that distinguished it from paralysis agitans, or Parkinson's disease, which is what they initially thought it was. And he ended up autopsying his servant, and he saw these plaques in the brain and in the spinal cord, and he said, wait a minute, this had been described previously, and it had been without clinical correlates. It had been described by Cuvelier in France and by Carswell in England, but Charcot put it all together clinico-pathologically. And he was initially convinced that this was a psychological illness, but he saw other people and he changed his mind. And he said, these are the criteria that I have for diagnosing multiple sclerosis. This, by the way, is the Salpêtrière, where he did all his work. And that's scanning speech, intention tremor, and nystagmus. Those were the things somebody needed to have in order to have multiple sclerosis. Obviously, there'd be very few people that we'd be diagnosing where we'd rely on those criteria. The next iteration came with Marburg, Otto Marburg, who said there are 4 criteria that I employ in order to make the diagnosis of multiple sclerosis. One is Uthoff's phenomenon, and for those of you who don't know, Uthoff was an ophthalmologist who described worsening vision in people who got overheated. And so Marburg incorporated that, temporal disc pallor, absent abdominal reflexes. I will tell you that when I test for abdominal reflexes with a resident in the room, they go, what the hell are you doing? Because, you know, it's not something that they ordinarily do. And pyramidal signs. That was his criteria. And then there were criteria about 20 years later or 25 years later that were developed by Allison and Millar, in which they divided it into an early disseminated form, a probable disseminated form, a possible disseminated form. And I'm not going to go into the details of what they said about these, but I will tell you that the diagnostic accuracy was terrible. It was no better than 65%. Where we really started understanding the disease better and defining it better came in the early 60s, and in fact, these are the criteria that Dr. Miller and Dr. Lublin and and myself, that we learned when we were in medical school. These were the criteria that we used to diagnose multiple sclerosis. It came about because people at this point in time were beginning to use treatments in controlled trials and said, well, listen, we have to know what the disease is. We have to have a great definition of the disease. And these are the criteria that they came up with. They're called the Shoemaker criteria. It was an NIH panel. You had to have objective abnormalities on examination. You had to have involvement of 2 or more areas of the central nervous system. You had to have predominantly white matter disease. You had to have 2 or more episodes of worsening separated by greater than a month and lasting greater than 24 hours. You had to be between the ages of 10 and 50. If you were too young or too old, they didn't think you could put them in an MS category, and you had to have no better explanation by another disease. And by the way, all the criteria include that, including the McDonald criteria, and we'll talk more about that in a second. The next iteration of criteria came with Charlie Poser, who in 1981 proposed using paraclinical evidence for diagnosing the disease. Mind you, the Shoemaker criteria was all clinical. It was stuff you could do at the bedside. And he suggested incorporating oligoclonal bands and evoked potentials. Mind you, this is in the era before MRIs, that you can put those into the diagnostic criteria. And then in 2001, we have the initial McDonald criteria, and it's gone through a number of iterations. So you've had 2001, 2005, 2010, 2017, and 2024. And it incorporates the clinical evaluation with MRI evidence. It required evidence of dissemination in time until 2024. It required evidence of, and still does, evidence of dissemination in space. The 2010 criteria addressed the possibility that MS could be diagnosed after one attack, provided other criteria were met. And the 2024 criteria allowed the diagnosis of MS in the absence of any clinical symptoms. So the most recently published, since we don't have the 2024/25 criteria, revised McDonald criteria are listed here. And I will tell you that if you are practicing, as I did recently in Arusha, Tanzania, and you do not have access to an MRI, you can still make the diagnosis of multiple sclerosis. And you don't need oligoclonal bands, you don't need MRIs, you could still do it based on the clinical features. So you had to have 2 or more clinical attacks and 2 or more clinically documented lesions, and you don't need any other criteria for establishing the diagnosis. You can do that with 2 or more clinical attacks and 1 clinically documented lesion, provided you have a definite historical attack of a lesion in another location. And then, as you see here, and I'm sure most, if not all of you, are familiar with these criteria, that you will then, depending on how many clinical attacks you have, it depends on whether you need dissemination in space or dissemination in time. So if you have 2 or more attacks, you need to demonstrate dissemination in space, and you have to do that either clinically or by MRI. And if you have only 1 clinical attack, you have to demonstrate dissemination in time, and you do that with the subsequent clinical attacks, MRIs, or the presence of CSF oligoclonal bands, which are taken as evidence of dissemination in time. The 2017 criteria differed from the 2010 criteria in that the 4 areas of the central nervous system that were thought to be specific or relatively specific for MS, periventricular, juxtacortical, infratentorial, and spinal cord, were expanded so that cortical lesions were added to the list. And the 2017 criteria also differed from the 2010 criteria in that patients with typical CIS meeting dissemination in space criteria by clinical and MRI criteria, and no better explanation, and the presence of oligoclonal bands could be substituted for dissemination in time, as I mentioned previously. And then it also, they also changed the nature of progressive MS, the way that was being defined. So you could have both symptomatic and asymptomatic lesions in the spinal cord to count towards progressive MS. So that's how it changed. Now we have this latest iteration, and how did it come about? So it came about, there were 55 international experts, some in the room, who were identified who had expertise in the clinical features of MS, the radiology of MS, methodology, epidemiology, and patient perspective. And they reviewed various topics between 2022 and 2023. They met in Barcelona in late 2023. It was sort of engineered by Javier Montalban. And then there were these consensus recommendations. And in order to accept these recommendations, 90% of the meeting participants needed to vote. 80% or more needed to vote in favor of something that would be adopted. And if it was in that range between 70 and 80%, they would reconsider it with an additional round of voting. So what is this telling you? This is telling you that this is an opinion. It's opinion of many people, but it's an opinion. So the criteria that we're employing are based, not saying that it's not based on literature, but what's the real world experience with this? And I'm going to talk about that in a second. So what did they come up with? So these are the revisions. One is that there is such a thing as radiologically isolated syndrome, or MS, without any clinical manifestations. We knew that, but now it's defined. The optic nerve could be taken as a fifth topography It's very surprising that in former iterations of the McDonald criteria, they excluded the optic nerve. I think that was a topic very highly debated. That dissemination in time was no longer needed. They updated the dissemination in space criteria. They recommended paraclinical evidence to diagnose multiple sclerosis. They added the central vein sign and paramagnetic rim lesions as optional tools for diagnosing in certain situations. They employed, in addition to oligoclonal bands in the spinal fluid, kappa-free light chains. Now, I've never ordered kappa-free light chains. I don't know how many of you have. I don't even know how available it is, so I'm not sure how that got into the criteria, but maybe somebody in the room can tell me. They said, let's coalesce our diagnostic criteria for progressive MS and relapsing remitting MS. So they put them all together. They require stricter features in confirming a diagnosis in individuals over 50, those with headache disorders or with vascular disorders, and they strongly recommend that laboratory tests, particularly MOG antibody, be used when you're confronting a child or adolescent that you suspect has multiple sclerosis. So that's sort of the overview. Well, let's talk about some of these things. So radiographically isolated MS, by definition, is the incidental discovery of CNS white matter T2 lesions on MRI, characteristic of MS, but in the absence of any clinical symptoms. And there's good reason for including this in MS, because if you look at the data that has been derived on individuals that have radiologically isolated MS, they frequently go on to develop clinically definite MS, as depicted on the right hand of this slide, where an aggregate shows that at 2 years, about 20% of individuals with RIS have clinically definite MS. At 5 years, 35% do. At 10 years, 50% or more do. And at 15 years, it's nearly 3/4. So the recommendations for patients with radiographically isolated syndrome were DIS, that is dissemination in space, and dissemination in time, was sufficient for diagnosing multiple sclerosis. That dissemination in space and the presence of oligoclonal bands in your spinal fluid is sufficient for diagnosing MS. Or with dissemination in space, if you have greater than or equal to 6 central vein signs on the MRI, it's sufficient for diagnosing multiple sclerosis. With respect to the optic nerve as the 5th topography, so as you all are aware, many people present with optic neuritis as the initial manifestation of multiple sclerosis, and that's as many as 1/4 to 1/3 of all patients. Optic nerve involvement is common in established MS, and if you take individuals who have had a history of optic neuritis and you look at their, do orbital MRIs and look at their optic nerves, as many as 70% or more will have evidence of that. And even in the asymptomatic eyes, you can frequently see abnormalities on imaging or by other modalities. So the belief was that optic nerve may serve as a 5th anatomical location to demonstrate dissemination in space, provided you had no better explanation for the optic nerve pathology. And you can use any of the following for demonstrating that there's an abnormality in the optic nerve: MRI, visual evoked potential, or optical coherence tomography. All right, dissemination in space. So looking at CNS topographies, you need 2 out of 5 areas to be involved. And those areas, as I mentioned earlier, were optic nerve, juxtacortical or intracortical, periventricular, infratentorial, or spinal cord. And you have to have typical lesions in those areas, regardless of whether they're symptomatic or not. Fulfilling dissemination in space and dissemination in time is sufficient by the 2017 criteria, so that doesn't change. But you can have dissemination in space and the presence of not only oligoclonal bands, as was accepted in the 2017 criteria, but now these kappa-free light chains in the spinal fluid in order to diagnose MS. No dissemination in time is needed. In patients with typical symptoms, the presence of typical lesions in at least 4 topographies is sufficient to diagnose multiple sclerosis. Now, there's a caveat here, and it's the second time I'm going to tell you. Just ensure that you've ruled out other possibilities, because with these criteria, you still have to be certain that it's not another disease. It really does, it tells you that it can be multiple sclerosis, but I have many examples that I show in a different conference of individuals that would fulfill these criteria but don't have multiple sclerosis. In patients with typical symptoms and typical lesions in one topography, MS can be diagnosed with either of the following: the presence of 6 central vein signs or paramagnetic rim lesions plus dissemination in time, or CSF positive for oligoclonal bands and kappa-free light chains. And in patients with progressive disease, 2 spinal cord lesions are enough to demonstrate it. Now, I'm sure you're going to see this later on today, but these are representations of the central vein sign and the paramagnetic rim lesion. The criteria for the central vein sign is this thin, hypointense line or small dot visualized on at least 2 perpendicular planes where there's a small apparent vein, usually less than 2 millimeters in size, and it runs partially or entirely through the lesion. And this is not uncommonly seen in individuals with multiple sclerosis. The paramagnetic rim lesions are the consequence of macrophages that have taken up iron, and it provides this interesting lesion as seen in the bottom of the slide on the right. And these are the locations that one sees that can be involved or accepted as involvement with multiple sclerosis. So what about the kappa-free light chains? They are believed to be the equivalent of oligoclonal bands, at least for purposes of diagnosing multiple sclerosis using these criteria. And it's similar with respect to sensitivity, specificity, and negative and positive predictive values. Both the free light chains and the oligoclonal bands have low specificity. We certainly see oligoclonal bands in lots of conditions. So just because you see oligoclonal bands doesn't mean that it's even an autoimmune disease. I recently saw a patient with what we used to call gliomatosis cerebri, or intracerebral multifocal glioma, who had oligoclonal bands in their spinal fluid. CSF kappa-free light chains can substitute, as I said, for oligoclonal bands. So how do we, what's the algorithm for diagnosing the disease? So you have to have signs and symptoms suggestive of MS. You do your initial workup, which includes your history, your imaging, your laboratory studies, and you say, all right, this isn't anything else. This isn't Bajet's disease or Sjogren's or whatever. It looks like it might be MS. And then if there are lesions present in 2 or more topographies, or the patient has progressive disease of greater than 12 months duration and greater than 2 spinal cord lesions, or 2 spinal cord lesions, you can diagnose MS with the following. The CSF is positive, the oligoclonal bands and kappa-free light chains. You have central vein signs, you have dissemination in time, or there are more than 4 topographies evident on your imaging studies. If the lesions are present in only 1 CNS topography, including patients with greater than 12 months of disease progression, then you have to have positive CSF and central vein signs, positive CSF and paramagnetic rim lesions, a dissemination in time and central vein signs, or dissemination in time and paramagnetic rim lesions. If it's an incidental finding, okay, somebody comes in and has a migraine headache, and again, you do your initial workup and say, all right, this doesn't look like anything else. You have to have lesions present in 2 or more topographies, and you can diagnose MS provided the spinal fluid shows either the kappa-free light chains or oligoclonal bands, there are central vein signs present, or there's dissemination in time. That is, maybe the patient has something develop. With respect to pediatric multiple sclerosis, the big concern is that you're dealing with myelin oligodendrocyte disease. So you have to look for MOG, and it's best done with a cell-based assay. The other thing that is recommended is if you see 6 or more, if you see 50% of the T2 lesions that have central vein signs, that too is indicative of multiple sclerosis. With respect to progressive multiple sclerosis, it requires evidence of clinical progression over 12 months. They tried to make a single unified framework, as I mentioned, so that there aren't 2 separate criteria for diagnosing progressive and relapsing disease. And if you have 2 or more spinal cord lesions, it's evidence for dissemination in space in order to diagnose progressive multiple sclerosis. So here's the rub, and the rub is this. What's the real-world data that these criteria actually work? So in a literature search, I could only find 2 papers that actually looked at that. There may be others that I missed. One is a paper that was published in 2019 looking at the real-world validation of the 2017 McDonald criteria for pediatric multiple sclerosis. And what they said in this paper, I mean, the bottom line was the following, that the McDonald 2017 criteria, they were comparing it, by the way, to the McDonald 2010 criteria. It appeared to be more sensitive, but perhaps was not quite as specific. So they found that the specificity for the 2017 criteria for pediatrics wasn't as high. Now, with the incorporation of MOG antibody, maybe that will change. But I strongly suggest that for those of you that are so inclined, this might be a very nice project, that is, to look at the sensitivity and specificity and the predictive values of these criteria in a real-world setting. The other paper that I found was one that was published in 2022 and looked at using these criteria to diagnose primary progressive multiple sclerosis. And they had 322 people with primary progressive MS. 28 of the 322, they were uncertain had multiple sclerosis because they had other illnesses that could explain their disease. So, and when comparing the 2010 and 2017 criteria, they felt they both worked equally well for primary progressive multiple sclerosis. So, again, I caution that you have to be certain that there's no other illness that might explain the manifestations that you're seeing. And I take you back to what Charcot said. In the last analysis, we see only what we are ready to see, what we've been taught to see, and we eliminate and ignore everything that is not part of our prejudices. So if the patient comes in and you think it's MS, you may go down that primrose path without realizing that it's indeed something else. And with that, I'll conclude. I'd be happy to take any questions. I had nothing to do with creating the criteria, so maybe if there are questions about that, I'd probably defer to people in the audience. Thank you.
compiling the questions, and we'll take them at the end of this group. Before the break, that was one of the clearest explanations of a very complicated topic. And just to reiterate, that McDonald criteria for diagnosing multiple sclerosis, not for differentially diagnosing multiple sclerosis. And I think Dr. Berger kind of stressed that. As you saw, MRI was extremely important in terms of McDonald. Almost so important that we've been arguing on the paper whether MRI was an absolute necessity. And we've got them to modulate that. And Joe kind of presented the fact that if you're in Antarctica, you could still diagnose multiple sclerosis based on clinical grounds. But the MRI is becoming more important, and as you'll hear from Dr. Reich in a moment, it's kind of key, but it's also kind of complicated. And so throw in your questions, because there's much to be done here. But part of what you're going to hear about in terms of the diagnostic criteria was aspirational, in the sense of moving the field forward, even though there's some sequences you may not be getting now. And the idea is to sort of set up the expectation and some pressure on your neuroradiologist to kind of modify the sequences so you can get to these new techniques that have been very useful. So Dr. Reich is a senior investigator in translational neuroradiology section at the Division of Neuroimmunology and Neurology at the National Institutes of Health, neurologic branch, and he is an expert on MRI and especially advanced techniques for studying the brain. So Danny, welcome.
Thanks, Fred, for the invitation, and good morning to everybody. So some of what I'm going to talk about overlaps with a little bit of what Joe talked about, and hopefully amplifies on it with some pictures, and hopefully will be useful. Okay. So I think the disclosures are important, and I think also important is that I'm giving this talk as what the NIH calls an outside activity. That's what the ethics people tell me I have to do. And because it's an outside activity, I could say I don't even know what that means anymore. But anyway, you're supposed to laugh at that. Okay, thanks. So this is where we've come in imaging of multiple sclerosis. On one side, you see the first MS MRI that was published in 1981. The arrows were added because it's a little bit tough to see the lesions present, but you can see them. This is a T1 weighted scan at 150 millitesla. And just as an aside, it's interesting that we now have actually reached the era of good ultra-low field imaging. I'm not talking about that today, but I'm happy to discuss with anybody. Portable MRI scanners actually exist now that can plug in to the wall and go to the ICU and potentially go out into the clinic and maybe even be used as a screening tool someday. And the images they make are much better than this one on, that you see here. And then on the other side is where we've now kind of state-of-the-art imaging in MS at 7 Tesla. This is from a scan at the NIH. And I think we've even improved on these images since this one was done. And through all of this imaging, we have recapitulated more or less what was known in the 50 years after Charcot first described the disease, in particular from the work of Dawson in Scotland. If you ever get your hands on his 1916 monograph, it's absolutely exquisite. And everything that you see here on these MRI scans, he prefigured in absolutely beautiful drawings. And so you can see the, let me just figure out the, are there arrows? No. No problem. Oh, there they go. Okay. So you can see lesions, periventricular lesions. You can see here by the temporal horns, here on the sagittal flare scan at the clososeptal interface. Sometimes you can see subpial cortical lesions, even on a flare scan, as is shown here. Thalamic lesions are relatively typical, although, as you know, not specific. These lesions here in the pons and medulla at the floor of the fourth ventricle, at the root of the fifth nerve here in the medulla. On T1-weighted scans, especially heavily T1-weighted scans that are commonly done now, although often post-contrast lesions, as this is, by the way, a post-contrast scan, contrast here in the sagittal sinus, you can see that lesions are often quite hypointense. This is not as much the case in small vessel disease, so that's an important and sometimes helpful thing. And then after gadolinium, a new lesion will enhance either, if on scans done at least 5 minutes later, either solidly or this very characteristic open ring enhancement pattern with the open side of the ring up against the cortex or alternatively up against the ventricles. And this recognition of these typical kinds of lesions led to the iterations of the McDonald criteria, as Joe talked about, from 2001 to 2005 to 2010, and then to 2017, where you have this concept of dissemination in space demonstrated by lesions in 2 or more of these areas, as well as dissemination of time. And the problem, and so here again illustrating these cardinal lesion topographies, and I put this up just to point out that these are neither specific for MS, nor are they fully diagnostic, but they are very, very typical. And other lesions, in fact, many of the lesions, maybe even most of the lesions, are in deep white matter in the brain. And just because lesions are in the deep white matter doesn't mean that it's not multiple sclerosis. So you often hear people talking in terms of MS has a predilection for these cardinal lesion topographies. That may be true, but the lesions, as you know, can occur anywhere in the CNS. And the problem is that we still have this high misdiagnosis rate, and that's what we've been trying to deal with, the balance between sensitivity and specificity to try to bring this down, especially in the era of immunosuppressive therapies for MS, which can be associated with morbidity. So one way to do that is to try to develop standardized MRI protocols, and there's been a sort of multi-decade effort now to do this jointly between the Magnum's group, which is the European MRI experts, the CMSC Consortium of MS Centers, and NAMES, the North American Imaging in Multiple Sclerosis group, which is associated with ACTRIMS. And so this was the paper we wrote a few years ago after the 2017 criteria came out, and recommended a relatively simple MRI protocol that included T1 and T2 weighted images. Diffusion weighted imaging, not so much because it's helpful in MS diagnosis, but it is helpful in differential diagnosis occasionally, and even optional contrast enhanced imaging, although we do it routinely. And at that time, we did discuss additional or advanced MRI approaches, and based on the existing criteria, said that optic nerve MRI was not recommended in the workup. That's changed, as you heard already. And we also said there's insufficient current evidence or widespread technology availability to do imaging that we could use to see central vein sign and paramagnetic rims. And now fast forward to the 2024 criteria, which actually have nothing to do with 2024. The meeting was in 2023, and they'll be published in 2025. But anyway, that's how they're come to be known. We now have got to the point, as you heard, that there are 5 topographies. So here you can see the optic nerve. It's not advancing for me. Okay, the optic nerve has been added. Here on the bottom left, this is an hyperintense lesion in the left optic nerve, as well as the ability to use central vein sign and paramagnetic rim lesions, which I will discuss in more detail. And in fact, that's what I'll do in the next few minutes. And the basis of this is to use gradient echo MRI sequences. Most of the sequences that we've used in MS historically have been spin echo sequences where you refocus the MRI signal in order to try to generate high signal-noise ratio images. So typical T2 weighted images, T2 flare, spin echo T1 weighted images, use this spin echo technique. gradient echo technique allows a different kind of relaxation. It can lead sometimes to lower signal, but it gives you additional information. And this is a 7 Tesla gradient echo scan using T2 weighting. Because of the signal loss, it's actually called T2 star weighting. And instead of getting one single image out of this, we actually have information both in the magnitude of the image and also in the phase of the image that needs to be reconstructed. And these 2 images are actually acquired at exactly the same time and can be output on the scanner. Often scanners will output a processed image that does not look exactly like this, but this is what the images look like if you select the right boxes. And on the magnitude images, it's sort of similar to a typical T2 weighted scan. Fluid is bright. But you also have the ability to see dark things on the image that generally correspond to signal loss due to a number of features. In this case, it's deoxyhemoglobin inside veins. Here, it's probably calcium in the choroid plexus, and iron is an important one. And on the phase image, you can determine whether the substance is paramagnetic or diamagnetic. That is, how does it shift? Which direction does it shift the magnetic field? And so there's a whole bunch of biologically relevant processes that shift the magnetic field in one direction or the other and result in signal that is bright or dark on the phase image, depending on how you do that reconstruction. And the most important ones for the purposes of MS are non-heme iron, which is paramagnetic, and this allows us to see the paramagnetic rim lesions that I'll discuss, and deoxyhemoglobin, which is also paramagnetic, and this is inside veins, and that gives us nice contrast for veins. And here's a good example of that. So this is central vein sign imaging with a different kind of gradient echo sequence called the T2 star weighted EPI or echoplanar imaging sequence. We use EPI imaging most commonly in standard diffusion weighted images that you might use for acute stroke. But that's a spin echo EPI, so it doesn't have this kind of signal loss that we need for the gradient echo imaging. And it also has a lot of distortions, right? You're used to looking at high signal in the temporal lobes near the air-bone interfaces. We can adjust that by doing something called segmenting the readout, and it gives us these beautiful undistorted images that we can reformat in multiple planes. So typically it's acquired in the sagittal plane, but it's just reformatted. We have very high resolution, sub-millimeter resolution, and this is all done on a 3 Tesla. And you can immediately see on these images all of that dark stuff that I was talking about before. So here you have in the globus pallidus and in the dentate nucleus of the cerebellum, you have, those are areas where metals like to go, so that you have this dark signal loss. And you also see all the veins, including these beautiful examples of veins inside, right in the middle of MS lesions. And we can do whole brain coverage in 6 minutes. So just blowing up those 2. And this is really the characteristic image of a central vein sign, and it recapitulates what Charcot showed in his initial pathology of MS, that lesions tend to form around these veins, and we can now do that without taking the brain out of the patient. So here recapitulates the histology of a central vein. This is an inflamed vein inside an MS lesion in an active MS patient. We've taken this one step further by combining that beautiful T2 star-weighted image with a standard FLAIR image. And the advantage here is that by registering and multiplying these images offline, we can suppress the signal in the CSF. That's what FLAIR does. It makes fluid dark, while maintaining the high signal that you see inside of lesions. So this really boosts the contrast of the lesions and the ability to detect the central vein sign. And again, you can see the very characteristic appearance. If you cut that vein transversely, it looks like a dot. If you cut it longitudinally, it looks like a line. And I'm happy to say that this, it's taken a long time, but both the 3D EPI and the FLAIR star images are making their way into product sequences that will be available on scanners over the next few years. So I'm aware that on one manufacturer, Philips, it already exists. One can purchase this. On Siemens, it's somewhere in the product pipeline. I'm not quite sure about where it is on GE currently. So the manufacturers finally are listening to this. I will point out that the conventional susceptibility-weighted imaging that has been available on scanners for a long time is not ideal. This sequence was, at least for central vein detection, this sequence was designed to find blood products in the brain as well as blood vessels. So here is a central vein sign within an MS lesion on the 3D EPI, and here's the standard SWI. And while you can see the vein very nicely, you lose contrast in the lesion, and the reason for that is because this sequence also, in addition to having T2 weighting, also has a lot of T1 weighting, and that counteracts the bright of the T2 and the dark of the T1, means that you can't see the lesion very well. You can actually fix this if you don't have the 3D EPI available to you by going in or talking to the techs who know how to go into the scanner and reduce the flip angle. So a higher flip angle tends to give you T1 weighting, a lower flip angle in gradient echo imaging will give you T2 weighting, and so this is exactly the same sequence, but with a low flip angle that gives you very much the same contrast, although the vein does appear larger on the 3D EPI. So this is available, and there's actually a companion paper to the diagnostic criteria that is also in submission, or almost in submission now, that will have details on how to do this. And I should just point out that the central vein sign is visible not just at 3 Tesla or 7 Tesla, but at 1.5 Tesla as well. And one way to enhance that visualization is to acquire the images immediately after or even during the push of gadolinium that you do. And the reason for that is gadolinium itself, gadolinium contrast agents are paramagnetic, so they will enhance the dark signal that you see due to deoxyhemoglobin inside veins. Enhance in the sense of making it dark, not bright, as we normally talk about enhancement. And so here you can see the same patient at 3 field strengths, 1.5 Tesla, the central vein sign still remains nicely visible, but gadolinium there really, really helps. And in work collaboratively with Dan Antoneda's group, this was a medical student at the Cleveland Clinic who did this and spent a year in our group at NIH. We showed very clearly that in MS, adding gadolinium substantially increases the contrast to noise ratio of the veins inside lesions, but doesn't really harm you in non-MS cases in terms of seeing the central vein sign. So how do we do this? Joe already put up a slide, so I'll just show additional examples. What are we looking for? We're looking for a thin hypointense line or a small dot, depending on how you cut the vein. It needs to be visualized in 2 perpendicular planes and appears as a thin line in at least one. This is one of the reasons why we want a 3D sequence that we can manipulate and reformat in multiple planes. The vein diameter has to be small. It has to run partially or entirely through the lesion and be positioned centrally. This is very important. We're not looking for a central vein sign with a little vein right at the corner of a lesion. That doesn't count. It has to be central, and that's because that's how lesions develop. In the original exclusion criteria, these are 10-year-old criteria that we developed that are in need of update, but anyway, at that time we excluded small lesions, lesions that were confluent or had multiple veins and that were hard to see. So if you're spending a lot of time trying to decide, is this a central vein sign lesion, probably look at the next lesion. So then the next question is, how do you decide if a scan is central vein sign positive, right? Because I've talked about individual lesions, but you want to know if the whole scan is if you're diagnosing the patient. So one way to do this, and most of the work has been on counting every lesion. That's pretty awful to do, and asking if 40% or more are central vein sign positive. Lots of evidence, time-consuming. There are automated methods, but these are even further out in the pipeline, and they're not available outside of research applications. So a very highly simplified approach has been developed, and this is what has been adopted into the new criteria. And it asks the question, are there at least 6 central vein sign positive lesions on this kind of imaging? If there are fewer, is it at least the majority? So, if there are 5, do you have at least 3? I think I did that right, yeah. And this is also fast and evidence-based. This is work, again, collaboratively with Dan's group, a multi-center study, a pilot study that we did, and here you can see that the Select 6 method has an excellent specificity for MS, not the ideal sensitivity, but certainly it can give you a lot of confidence if you see this to be the case. And Dan is leading a large multi-center trial along with Pascal Satie and Nancy Sykott to do this prospectively in patients presenting for the first time with possible MS. So lots of data forthcoming from this study. The next thing is to talk about paramagnetic rim lesions. This was also introduced. What is this? This is the ability to use that same kind of imaging to detect iron at the edge of MS lesions. That iron is present inside myeloid cells, a fraction of the myeloid cells at the edges of what are called chronic active white matter lesions. This tells us that there is compartmentalized inflammation within the brain, and in many cases, it's associated with lesion enlargement over time. Here, over 7 years in one patient, here on a postmortem MRI. So this is a very useful thing to look at because this is, again, a very characteristic pathology of multiple sclerosis. Again, you can use gradient echo techniques to see this at multiple field strengths. At 7 Tesla, it's best because the signal loss effect is the largest, but you can see them at 3T with that same sequence that I mentioned before for the central veins, but here you're looking primarily at the phase image rather than the magnitude image. Here on a standard SWI from work of Chris Hemond, at 3T and 1.5T, the same patient, you can actually see both the central vein sign and the paramagnetic rim in all of these lesions as well. And the clinical SWI without the low flip angle detects these lesions fine, but you also see them equally well with the low flip angle. You don't lose much. So how do there are criteria for this as well. The rim needs to be hypointense. This is a little subtle point here that's important because unfortunately, some manufacturers make paramagnetic things dark and other manufacturers make paramagnetic things bright, and you have to know what your scanner does. It's fairly easy to tell because white matter, myelin, is diamagnetic, so if that's bright, then iron is dark. Anyway, we'll have to get used to this. So hypointense here, dark or paramagnetic. The rim has to be clear. The core ought to be isointense or slightly hypointense to extralesional white matter. The rim should co-localize with the sharp edge of the lesion on flare. And it needs, again, similar to the central vein sign, it needs to be visible on at least 2 consecutive slices because there are a lot of artifacts on these kinds of imaging. There's a learning curve here, or in 2 planes. So again, helpful to be able to reformat. And here you can see the same paramagnetic rim lesions in axial, sagittal, and coronal. The rim should continuously cover at least 2/3 of the edge of the white matter lesions, or 2/3 of the white matter portion of leukocortical lesions. Here I can point out that in the cortex, you don't get the same characteristic iron accumulation inside myeloid cells. So we're really talking about white matter lesions here, including deep white matter lesions. So what are these? These are important diagnostically. They're also important prognostically. So this is a summary of data collected across multiple centers from about 500 patients compared to 83 MS mimics. You can see specificities. About half of patients have one of these. Across multiple studies, depends a little on how you acquire the data, depends on the characteristics of the population, maybe 50 to 60% of patients with good sequences, but specificity extremely high, especially with the central vein sign. And importantly, these are important prognostic markers because they tell you that on average, patients who have such lesions, especially if they have 4 or more, tend to progress faster. And we now are beginning to get data from this CAV study that I mentioned before at the time of first presentation. And in this particular study, the sensitivity was surprisingly high compared to the existing cross-sectional study, so about 80% with, again, very high specificity. And this data, I think, is what led to incorporation of the PRL into the new criteria. Importantly, you can see PRL in radiologically isolated syndrome, which will be one of the MS course descriptors that we have, and this is work mostly from Jiwon Oh's group in Toronto. And just to point out that the prognostic significance is not just phenomenological, but also biological. So you can see at the edge of these iron-rich lesions, you can see axonal transections as detected here on immunohistochemistry for APP. And if you look in the serum, those patients who have 4 or more paramagnetic rim lesions have about a 30 percentile point increase in neurofilaments on average. So it's associated with neuronal loss. This is a large cohort study from Christina Grancera in Switzerland who showed that paramagnetic rim lesion counts are higher on average in patients who have PIRA, progression independence of relapse activity, so additional orthogonal data showing the prognostic relevance. And then I'll just close very quickly, if I might, I know I'm a little bit over time, with optic nerve imaging, which is not really advanced imaging, but nonetheless we're revisiting this. So again, there are standardized recommendations. Typically what one does is a STIR sequence or a FATSAT T2 coronal sequence. This allows you to suppress fat in the orbital, in the orbit. It's very important. You can see bright optic nerves when there's inflammation, and you can have enhancement after gadolinium. This is really useful sometimes for differential diagnosis in optic neuritis presentations, because in MS you typically get these short segment lesions, intracanalicular lesions, or whereas in aquaporin 4 it often involves the chiasm, maybe bilateral, and in MOGAD very long intraorbital segments. So really useful to do this for differential diagnosis as well. I will point out that, and this is a slide that Alex Rovira from Barcelona gave me, that you can use a 3D double inversion recovery imaging sequence. We've started doing this recently at the NIH. It covers the brain down pretty far into the cervical spine. This must have been a very small person, but anyway, often we can get down to about C5 or so, and it really is great because it shows you all of these topographies at once. You can see the cord lesions, you can see brain lesions, brainstem lesions, and even old optic nerve lesions much better than on our FLAIR. So, well, I think we should do a lot more research with this kind of approach. So Joe's already gone over this. This is a table that's in our paper that I think is a little bit easier to read than the one that's in the main diagnostic paper, but we've already discussed this. These are in your slides, standardized MRI protocol parameters that are being recommended as adjunct for the new criteria, so I'll just flip through them because I'm over time. I do want to briefly mention kind of a couple of things that may be helpful going forward. So we do all of our imaging of the spinal cord using heavily T1-weighted 3D images. We can reformat them in straightened projections. And just to show you that it really, here the lesions are dark, obviously, and it really beautifully recapitulates the old drawings, this one, for example, from Carswell from 1838, really showing you very nicely the topography of MS lesions in the spinal cord. I find this very helpful. I never ever see it in other protocols, but maybe something you can bring back to your institutions. There are emerging approaches to look at cortical lesions, which are highly characteristic as well, but very, very hard to image and haven't made it into the diagnostic criteria. This is something we invented at the NIH called IR Suite. Aaron Beck, who's now at Mount Sinai, led this work along with Govind Nair, and here you can see really nice subpial cortical lesions using this approach. And then finally, post-processing techniques that I use all the time. So here's 2 sequential scans in a patient with lots and lots of lesions. Most of them are small, pretty awful to try to find a new lesion in a patient like this. One thing that's very helpful, but really mostly has been in the research realm, is subtraction imaging. Here you can see if you take 2 images, register, normalize, and subtract them, you can see bright spots that show you where new lesions occur. You can also use fusion approaches, which are available on many systems. But we've implemented this in the PACS. And so here's those same 2 images, and here's the subtraction image. And you can see, on-plaque images along the edge of the ventricles, small lesions in the frontal lobe, for example, another one here along the atrium of the lateral ventricle that I never would have seen. This was when we started doing this, it was one of the more humbling days in my career. All these people I thought were stable turned out not to be stable. So something to bring back, and thank you very much for your attention.
Thanks, Danny. So the questions are rolling in, and I appreciate that. We'll get to them at the end of this section, no matter what the time. So learning more about the McDonald 2024, including averaging the 2 years, 2023 when the meeting was held and 2025 when the paper will come out. Next, you're going to hear about the optic nerve and diagnosing MS from Dr. Fiona Costello, who's professor at departments of clinical neuroscience and surgery. She's an associate dean, we'll forgive her that, at the Cummings School of Medicine at the University of Calgary, and a recognized expert in neuroimmunology and neuroophthalmology.
Thank you, Fred, and thank you to the academic CME group for this very kind invitation. It's an honor to be here, and I'll try and figure out the ergonomics of advancing my slides. So over the next, these are my disclosures. Over the next sort of 20 minutes or so, I'll talk a little bit about one of my favorite parts of the anatomy, and yours, the optic nerve, and the relevance of the optic nerve in the upcoming 23, 24, 25 version of the McDonald criteria. And just broadly, you've heard from Joe, you've heard from Danny. We know MS to be, an acquired, host-generated, immune-modulated CNS injury, which is the largest cause of neurologic disability of non-traumatic type in young adults. We also know that we don't have a cure for the disease and that our medications target the inflammatory components. And we believe that a lot of the injury that affects the optic nerve, the spinal cord, the cerebellum, and other facets of the CNS are largely due to neuroaxonal loss, probably precipitated by demyelinating injury. And so these are our truths. What's interesting, and Danny made reference to, is we know also that disability in MS, including the optic nerve, can be relapse generated, but also that there's this insidious component of sort of subclinical neuroaxonal injury that governs disability over time. And so we refer to that as progression independent of relapse activity in what's called smoldering MS, kind of below the radar injury within the central nervous system. And so it's probably fair to say that MS is a disease governed by inflammatory and degenerative processes. And I'll talk about that a little bit as it pertains to the optic nerve. So my objectives really are to convince you, I hope, that the optic nerve has been highly relevant to the diagnostic criteria. It's just only found its day now. So it's finally getting some love in 2025. I'll talk about clinical, neurophysiological, and OCT measures of optic nerve involvement that I hope that you'll find helpful, and highlight a few things on the horizon that may be of interest over time in terms of how we better understand how to incorporate measures of visual disability as we look at patients being evaluated for multiple sclerosis. So why the eye? Well, the eye's always been relevant. So 1 in every 5 MS patients to 4 MS patients presents with an overt clinical optic neuritis event as the first manifestation of their disease. And if you follow patients closely enough, you'll see that anywhere from 70 to close to 99% of patients will declare evidence of optic nerve involvement. It just really depends on how hard you look. We have ocular imaging techniques that are now very sensitive to detecting optic nerve involvement, but I will say one ongoing challenge in the field of MS, it's not unique to MS, is that our structural measures, and you've seen Danny's beautiful kind of array of images, far surpass our functional measures, thus I think causing this bedrock of discordance between structural and functional relationships in MS. Joe's talked about the McDonald criteria, and I'll not dwell on this further, just to say that how can we really reliably look at the optic nerve as a 5th anatomical compartment? And I'm going to see if you kind of buy this or believe me at the end of my talk. So let's focus on the clinical. Now, optic neuritis, I used to say for years, was the easiest diagnosis to render in the emergency room department if you've got the right patient, who's generally a young person, particularly if you look at the optic neuritis treatment trial, which was published in '92, before many of you in the audience were born. We know that 77% of patients in that study were women, 85% were Caucasian, the average age was 32 years, and 92% of them presented with pain and subacute onset worsening over time. And we also know that whether you treated them or left them alone, the vast majority of these patients achieved very good visual recovery a year after entry into the study. And so I used to say it was easy. You would just look for a visual field defect, you would look for acuity loss, check an RAPD and the right history, boom, mic drop, you have the diagnosis. But that's not exactly true, because studies have shown that fundoscopy, so eyeballing the back of the eye, seeing that there isn't retinal pathology, that the optic nerve looks generally normal in what is typically a retrobulbar insult in adults, it's actually not that easy here. So who here, raise your hand now, feels comfortable with their fundus examination? And you know, when I was a trainee, I think I would lie. I mean, I just lied all the time because I thought it was just me. But I think half the time I was looking at the earlobe and not seeing the optic nerve whatsoever. So I can honestly say that it probably took me till the better part of the end of my fellowship to feel really comfortable with this. And so we need tools that kind of fill in this care gap, because it's real, it's not a shameful thing. I have lots of difficulty seeing the back of the eye, and I do a lot of fundus exams, in particular patients with mediopacity who are fighting me as I'm wrestling them to look in the back, you know, when they're in the emergency room. It's not easy. And recent work by Stunkel and colleagues has borne this out, because for every 100 for every 100 patients sent by very good doctors with the presumed diagnosis of optic neuritis, 60% of these are overdiagnosed. And what this means is that patients are overdiagnosed because there's an over-reliance on pain and underappreciation of whether or not they truly have vision loss. And so the diagnostic entities that were mislabeled optic neuritis included functional vision loss, ischemic optic neuropathy, retinal mimics, and particularly primary headache disorders, because people would glean a history of pain with vision loss but not necessarily realize that the patient had the same pattern of pain every month. And so one little clue that I would kind of impart to all of you is that there's a lot of weight that can be placed on the presence or absence of an RAPD. And so you see here the swinging flashlight test and evidence of dilation on the left relative to the right. But the real world experience is a little bit more like this gentleman on top, where he's not opening his eyes, he's blinking, he's swearing at you, but you can still, if you kind of take your time, appreciate that both pupils dilate when the left eye is illuminated relative to the right. And my little, I think, kind of in the pocket pearls for you are this. Firstly, control the lighting. And if you can't, just say it. Like, you're not going to actually reliably check an RAPD in the blistering luminance of the emergency room, because often you can't control the general lighting. Also, swing the light several times, because subtle asymmetries, be it in patients with bilateral optic nerve involvement or patients with a mild optic neuritis, may be missed if you just swing it 2 or 3 times. And count. 1, 2, 1, 2. 1, 2, and then finally ask the patient. There's beautiful concordance between an objective RAPD and the patient's perception of a subjective RAPD. So just practice this. The reason I say this is Stunkel showed that if an RAPD was documented in a patient with optic neuritis sent in for referral, 68% of the time, these patients actually had optic neuritis. If it was documented to be missing, the patient only had optic neuritis in about 1/5 of cases. And if it wasn't documented, which we all do when we're not sure, at least I do, it was a coin toss, and it was kind of literally like 50-50. But because the clinical examination is a little bit tough, we do have biomarkers that we need to help us render the diagnosis. And we know that good biomarkers should be a good indicator of pathologic and normal processes, should be cost efficient, and should correlate with disease activity. And there are biomarkers that we can use for prediction, disease monitoring, and determining benefits of therapies. And so if we focus on the myriad of mechanisms that may drive disability in MS, what I'll talk about now is how we could focus, or how we'll kind of measure a neuroaxonal loss in the context of the optic nerve with ocular testing and optical coherence tomography. So OCT is readily available all over West Palm Beach, and generally I just came back from India. They do tons of work with OCT. This is to ophthalmic practice, I would say, what an ophthalmoscope would be to neuro, or what a reflex hammer would be. So it's not an esoteric test only found in a few centers. It's non-invasive. It's very reproducible. So if you're in Delhi, India, or you're in West Palm Beach, Florida, you're getting the same measures if you follow the same protocols, and it's objective. And what OCT allows us to do is to kind of wrap metrics around something that's been observed from the 70s. So Friesen and Hoyt looked at MS patients just with ophthalmoscopy and showed that you could see wedge defects or slit defects within the retinal nerve fiber layer of these patients, indicative of axonal injury with or without a history of optic neuritis. And so what we know is that lesions from the retina or optic nerve cause anterior grade changes all along the visual system through the chiasm, the tract, the lateral nuclei, the radiations, and the cortex. And you can see microstructural alterations in the cortex from a lesion affecting the optic nerve, and they've done this in glaucoma work. But similarly, lesions in the cortex, the radiations themselves, can cause transsynaptic degeneration, and lesions pregeniculately cause direct retrograde axonal loss, which is measurable in the retina as either an axonal injury, a neuronal injury, or both. And so the visual system provides us a really great mirror or window, if you will, of what's happening along a very delicate, highly myelinated pathway that literally goes from the eye to the cortex and tells us a lot about clinically overt and subclinical manifestations of MS. So the OCT measures of interest I'll sort of show you here are the retinal nerve fiber layer carries the ganglion layer, sort of the axons within, I should say. The retinal nerve fiber layer carries the axons from the lower lying ganglion cells in the retina, and beneath this is the internuclear layer. And these are going to be, I think, in the MS realm, the measures you're going to be most familiar with in terms of what you're reading and what you're using. And so if you want to look at what a snapshot of typical optic neuritis is, it's shown here. So this is a patient who presents with pain, vision loss in the left eye, a normal appearing optic nerve initially, and lo and behold, has actually subclinical thickening or axoplasmic flow stasis. So the peripapillary measurement around the optic nerve, which is our axonal measure, is 144 in the left eye relative to about 107, 108 in the right. And at day 0, the thickness through the macula, or a neuronal measure, is normal because there hasn't been enough time for pallor, nor has there been enough time for retrograde neuronal loss to ensue or be measurable. And then you see 6 months later quite a different story where the inter-eye differences are substantial, exceeding 20 microns between the affected left eye with optic neuritis and the presumed normal right eye in this patient. And so when you're looking for what is evident of in a patient of a clinically overt optic neuritis event, it's a lot like this. So you're looking for much lower peripapillary RNFL measurements and ganglion layer measurements in the so-called optic neuritis eye, if you didn't get the opportunity to see them at baseline. And this will be evident at 3, but certainly at 6 months. We know, I'm trying to just briefly going through this, that the extent of neuroaxonal injury sustained predicts whether or not visual recovery will be full or incomplete. So back in 2006, Mark and I showed that a year out, there was a threshold at 75 microns that predicted who would have a visual hit that did not recover. And so for every 10 microns below 75 microns, patients lost about 6 decibels of visual field sensitivity. Shown here are Peter and Shiv, and we, along with them, showed that the timeline of thinning after optic neuritis is largely evident at 3 months, but plateaus after 6 months. So you can start to see changes in the ganglion layer and the retinal nerve fiber layer immediately, and then they're done and dusted by 6 months. So it's a nice timeline to follow a patient and determine that what they had, in fact, was an optic neuritis event. In 2017, this sort of a systematic review and meta-analysis really confirmed a lot of the work of earlier studies, showing that after optic neuritis, there's about a 20 micron thinning of the ganglion layer, there's about a 21 micron thinning of the retinal nerve fiber layer measurement, and about 16 of the ganglion layer measurement in optic neuritis eyes in MS patients relative to controls. But the so-called normal eyes of those patients are in fact not normal and are about 6 to 7 microns thinner, both with respect to the retinal nerve fiber layer and ganglion layer each. And so this work formed the substrate of the inter-eye differences that you will see emerge in the upcoming McDonald criteria. So proof of a prior subclinical optic neuritis hit is now going to be an inter-eye difference with a lower measure in the so-called affected eye of 4 microns for the ganglion layer and 5 microns or more for the retinal nerve fiber layer. And this has been proven in a pediatric cohort by Waldman and colleagues and shown by Nolan Kenny in this recent study in Annals about 5 years ago. And these classifications of optic neuritis using inter-eye differences with OCT as well as MRI findings kind of gave birth, if you will, to the paper by Petzold and colleagues in 2020 that provided us with basically a toolbox of how to diagnose optic neuritis on clinical as well as structural terms. What's missing from this paper, however, is electrophysiology. This Austrian group looked at whether adding the optic nerve as a fifth compartment using OCT criteria improved diagnostic sensitivity and maintained specificity, and in fact it did. So in this cohort, no specificity was lost when they used OCT as a measure of optic nerve involvement and added it to current criteria for DIS. And so what they showed is that you can maintain the sensitivity of the current McDonald criteria and not sacrifice specificity and achieve better accuracy if you use these OCT measures. So that's just briefly visual evoked potentials. They measure something else different mechanistically in terms of determining what is driving disability in patients and have relevance in terms of detecting what has affected the optic nerve. And VEPs have been around a long time. We know that demyelination causes prolongation of P100 latencies in the visual evoked potential, and subsequent shortening of that latency is evident of remyelination. And we also know that they're very sensitive to optic neuritis acutely, but become a little bit less so after about 6 months. Similarly to what was done with the Austrian group, in 2018, Brownlee and colleagues used prolongation of P100 latencies as a measure of optic nerve involvement, added it to existing criteria, and showed again that if this is your metric of showing previous optic nerve injury, you again maintain sensitivity, don't sacrifice specificity, and increase the yield of patients presenting with optic nerve involvement who not only would be diagnosed with MS, but would actually qualify for disease-modifying therapies. But there are problems, and I kind of made reference to this at the beginning, with our demyelination strategies. And a lot of the times studies looking at how to measure myelination, demyelination effects in optic neuritis patients make a few critical pitfalls. So firstly, they try to apply measures gleaned from acute models to a chronic demyelinating injury effect in an MS patient. The timeline of remyelination is too short, and our actual measurable outcomes of functional demyelination are off focus. By that I mean, myelin governs something different in the visual system than static perception of form. And so Net 11 and others have shown way back in 2010 that prolongation of latencies in the VEP correlates not with how well you read a chart or your color vision or how well you do a visual field. Those are static perceptions of form. But instead, how you perceive a moving object. And I think if you can see this similarly stippled object moving across a background, this is a motion perception test. So prolonged latencies actually correlate better with disturbed motion perception on optic neuritis eyes, and not on the standard things we typically do to patients in an eye clinic assessment. So we may be using the wrong measure, actually, to understand how demyelination affects folks, and patients have been telling us this for years, where they'll simply say, I have difficulty following my kid play soccer at the end of the day when I'm good and tired, especially if I'm a bit overheated. And so that is trying to perceive objects in motion, which relies likely on more dorsal visual pathway processes and thickly myelinated fibers. So if we're looking at ways to detect functional measures of optic nerve involvement, be it relapse-driven or be it due to PIRA, we need to come up with better tools. And one old tool I trained with, and I won't go over time, I'll just sum up quickly, is called critical flicker fusion frequency. You gotta be careful with that one. And what this measures is how high a blinking target is before you perceive it as fused. And most of us will kind of get to 30 hertz before we see that. This is an in-the-pocket test that can differentiate demyelination and optic nerve involvement. It's very cheap. And so patients with optic neuritis will perceive a fused signal at, 8 hertz. And so they're unable to actually appreciate the flickering dysregulation between the signal. And this is a far better test of demyelination and remyelination than having them read off a chart, be it high or low contrast visual acuity. I'll say with respect to AI, we're also learning to fill that gap in terms of what people are unable to see in terms of the fundus exam in the emergency room. So we have, in artificial intelligence in the ophthalmology world, we can tell someone's biologic sex, whether they have hypertension, and where they're from with a simple fundus photo. And one thing we've recently done in Calgary is we've taken all comers with optic neuritis, not just MS, but looked at those who had MS optic neuritis versus those who had an inflammatory optic neuritis from something else. And we are actually able, just on the fundus examination alone, using an AI technique, determine with some degree of accuracy, like 3/4 of the time, we're able to say this was not an MS optic neuritis, it was something else, with just that information. And so I'll finish by saying the visual system provides a very good model, and it's clinically relevant in an area of the central nervous system that's highly prevalent in being affected in MS. And you can detect through clinical, OCT, and electrophysiological means whether there's been a prior clinically overt event or a subclinical event of optic nerve injury. The tools are emerging, old and new, that will help you do this in ways I think that were not available for the 2017 McDonald criteria, but will become increasingly available over time. And research focused, I think, on portable apps, AI, and machine learning models, these are really going to change the accuracy and the ease with which we can determine whether someone's had an optic nerve insult. And so I thank you for your attention.
Thank you, Fiona. So moving along now, we'll do biomarkers and immune profiling by Dr. Peter Calabrese, Professor of Neurology and Neuroscience and Ophthalmology at Johns Hopkins. Welcome, Peter.
Okay, good morning. Thank you, Fred, for organizing this great symposium, and thanks to the wonderful folks at Academic CME for doing all the work behind the scenes. It's really my pleasure to be here again. So I'm going to talk about biomarkers. Here are my disclosures. So we've already heard about imaging and its application to the diagnosis of MS and its utility in monitoring folks with MS, and we just heard about OCT. So we're going to shift gears a little bit and now talk about the fluid biomarkers that we can use. And many of you are, of course, very aware of neurofilament, and I'm going to spend much of my time giving you an update on the status of neurofilament, talk a little bit about GFAP, and then at the end mention some of the other approaches that people are using. So this is the outline of the talk. We're going to talk about these fluid biomarkers in the context of prognosis in relapsing MS for monitoring efficacy of anti-inflammatory therapies that we have available to us right now, and then shift to the potential applications for looking at the biology of progressive MS, the compartmentalized inflammation where there may be less overt MRI activity and relapses and more of the so-called smoldering chronic compartmentalized inflammation. And these fluid biomarkers behave differently in the two different types, so I think this is important. I think many of you probably have seen this slide before. Neurofilaments are released from axons. They're not specific to the CNS. If you have diabetic peripheral neuropathy, neurofilaments are released. It's been known for decades that we can measure elevated neurofilaments in the spinal fluid, but in the last 7 years, I'd say, the very high sensitivity assays have allowed us to measure neurofilaments in the serum and plasma. So the state of the art right now is that there are 4 commercial assays that everyone here can order tests from, depending on where you are in the world and perhaps who your insurance company will approve the payment for these tests. But here they are. There's the Simoa Quanterix, which is the first one, the single molecule assay that sort of really opened up this world. And then Alexis, which is a Roche assay, is now also commercially available. This is what, if you order through LabCorp, this is what you'll get. The Atelica Siemens is poised to come on the market. It's actually received European agencies' approval and is being, I think, fairly widely used in Europe. And then there's a 4th one called Lumipulse from Fujiri Bio. Now, any CLIA-certified lab can do this kind of testing. They can develop an assay, and as long as they report normative data and how to interpret the data, that's allowed to happen. So that's called a LDT, or laboratory-developed test. And some companies have thought about going for what's called an IVD, or an in vitro diagnostic. It's a bit of a misnomer, but it's a higher level bar that the FDA has, where one can receive a more rigorous kind of approval process. And I think the initial notion was that this might force insurance companies to cover these tests. And at least where I am, we can order a neurofilament from LabCorp, but about half the time they won't pay for it, and the patient then doesn't really want to have the test done. So we're still in a little bit of a frustrating period, but I think with more validation, as we're seeing, and I'll go through today, hopefully these will become more standardized. The important part, as you can see here, is that the tests are not, they're highly correlated, 3 of them, but the one that stands out the most is the one that we're using the most. It's the LabCorp Roche test, the Alexis test, which is about 82% or 85% lower absolute values. But if you compare the utility of these tests in picking up folks with abnormal values, they're really about the same. It's just psychologically, for me, having grown up with Simoa and more recently the Siemens test in my research, looking at the Roche values, I always have to think twice to how to interpret those. And as I will show you, I think one of the paths forward is to, rather than use an absolute value, is convert these to z-scores, which is something that there have been several publications about, and this might help to homogenize the data a little bit. Okay, so what's the first variable in determining what's normal and what's not normal? Well, we all know now that age is a major driver of neurofilament. Sadly, sometime after age 40 or 50, our brains start atrophying. It happens to everyone, and neurofilaments get released as part of the aging process. And so we know if you're older, your neurofilament levels will be higher. It was also reported that body mass index, or BMI, has a paradoxical result. We always think about carrying extra weight as being an epidemiologic risk factor for disease progression, but it turns out that people with higher BMI have higher blood volumes, and so there may be a dilutional effect. So neurofilaments actually decrease with increasing BMI. Kate Fitzgerald at our center has looked at all the variables that could be affecting neurofilament levels, using a cohort from NHANES, which is a CDC repository where they sample across America, and so this is highly representative, maybe of a particular region in the world. We're looking at neurofilament levels, and of course the major driver in the model was age, as I previously mentioned. But if you look at what's driving this afterward, it's comorbidities that are then associated with end organ damage, not only to the central nervous system, but perhaps to the kidneys, because creatinine came out as number 2, hemoglobin A1C, and having propensity for prediabetes or diabetes, which occurs in about 30% of the U.S. reference population, is also a major driver. And interestingly, I'm just going to draw your attention to BMI's contribution here was relatively modest as compared to some of these more classical vascular risk factors, as well as other comorbidities such as head trauma. So there have been a number of publications looking at normative reference values, and as I mentioned, the NHANES one actually turns out that it stands out as being the most abnormal. So if you have very abnormal healthy controls, then you're less likely to see elevated neurofilament in your folks with multiple sclerosis. And that's what happened with our NHANES cohort. Fortunately, we were collecting samples from healthy controls who were coming into our center, as many other people do, and we're able to show differences just from our MS PASS cohort. This is a 10-center study, 7 in North America and 3 in Europe, where the controls are collected as part of the study and age and sex matched. And those looked very much like the Swiss cohort and other publications. So why is that? When we looked at the annotation from the NHANES cohort, there were remarkably high levels of people engaging in activities that were high-risk behavior. About 15% of the NHANES cohort endorsed using cocaine or methamphetamine, and there's a high prevalence of prediabetes and hypertension. And so I think we need to think about this because some of the healthy control cohorts in tertiary referral academic centers are excessively healthy. For example, the incidence of diabetes in our reference cohort was 3%, whereas even in MS PASS it was 6%, and in the general population in the U.S. it's 10% for diagnosed diabetes. Okay, so what's the utility of neurofilament? I'm going to go over this briefly because there are many publications, and I apologize to anyone who's there's no way I can include all of these in a 20-minute talk. So the summary here is that neurofilament's elevated in a large proportion of MS. If you use 2 standard deviations as your cutoff, it comes out to about 17% of people who are elevated. But I'll show you that if you use z-scores that are less than a z-score of 2, then you start to call out more people who are at risk and probably have meaningfully elevated neurofilament levels. But for the purposes of this study, what I'm showing you on the right here is normal or elevated is defined by greater than 2 standard deviations off the mean of healthy controls. And you can see that people in the with NFL elevated levels have higher risk for new T2 lesions and gadolinium enhancing lesions. And if you look at annualized percent brain parenchymal fraction changes, The normal folks are still having brain atrophy greater than healthy controls, but the ones with elevated neurofilament have significantly more atrophy. What I think is interesting here is I'm starting to allude to the value of the Z-scores, as I've mentioned now several times, but as your Z-score goes up above 2, the annualized rate of brain atrophy really seems to accelerate. But I'll just focus your attention here on the 1.5 or this range. That curve does start to drop in this range, and in fact, there are useful data showing that the Z-scores may add value in this range, which I'll show you in a few slides. But to continue on our longitudinal cohort, we looked at, basically this is sort of a digital version of the MSFCs, except for walking speed was done separately. So if you have a greater than 20% worsening in walking speed, this is looking at neurofilament levels that were elevated on follow-up versus persistently elevated. So these would be folks who were normal and then increased later. Manual dexterity test, you see also elevated neurofilament. I think with the most striking part of this was the processing speed test. So this is something that we know is highly affected in early MS and is representative of lesion load in the brain, not necessarily driven by some of the traditional spinal cord and brainstem involvement that we associate with EDSS worsening. And processing speed here, again, was markedly abnormal in the folks with elevated neurofilament or persistently elevated neurofilament. Same with brain atrophy, as I've mentioned. You do have some brain atrophy in people with baseline normal neurofilament, so a one-time value may not be enough, but with persistently, this is baseline normal and then baseline elevated, and then if you look at consistently normal versus persistently elevated, there's quite a bit of a difference. So I think what we're starting to see is here a pattern that looking at neurofilament several times may add value, although certainly there is value to one time at baseline. So again, re-emphasizing the value of the Z-scores. I think this study from the Swiss cohort was very compelling. That what they did was they looked at patients who seemed to be achieving NIDA-3, no evidence of disease activity, and then looked over the next year for how many people exhibited disease activity or EDA. And what you can see here is that the folks with high Z-scores, of course, had the highest odds ratios of achieving EDA-3, but there was also quite a bit of value with the people with a Z-score greater than 1.5 or even greater than 1.25 in this cohort. And I will mention that just in the last month, the LabCorp Roche assay has added Z values to their output. It's actually, you have to have quite a few samples to be confident enough to do this, and we're trying to increase our normative data, but again, the caveat I would say is that you have to make sure that the sample that you're sending to LabCorp is representative of the normative cohort that they're using to calculate Z-scores. So what is the value of all this in making treatment decisions? Or I think that there's quite a bit of data now already that one can obtain neurofilament and then initiate treatment and use the neurofilament change over time to decide whether the treatment is effective. Just remember, although we initially thought this might be of highest value in progressive MS, really the neurofilaments are being released as part of the inflammatory axonopathy, right? It's correlating with relapse, gadolinium enhancement, new T2, and so these are all things that we know that the treatments should affect, and so in this, you can see that there's a modest reduction with a modestly effective treatment like pegylated interferon, but there's a very much more substantial reduction with a high-efficacy monoclonal antibody therapy like natalizumab. And in fact, the same is true with ocrelizumab and all the other high-efficacy monoclonal antibody therapies. Okay, so now we're going to switch over to progressive disease, because this is the real need. And of course, in the clinic, we don't know when people are progressive. There's sort of a joke that we all talk about who have been doing this for 20 plus years, is that every 6-month increment, the patient basically looks the same, no substantial change, and then 20 years later, they're using a cane or a walker, and it's like, how did that happen? And so we know that progression is happening with aging over time, but can we cull out people who might be amenable to intervention with either anti-inflammatory therapies or next-generation therapies that target the biology of smoldering CNS progression? And so in this study, and I'm really cut off I will say that ocrelizumab had a very dramatic effect in normalizing the markedly elevated neurofilament levels, as would be expected. But I think what was very clever here is that Amit and colleagues they rebaselined people after they had achieved the ocrelizumab effect on the relapsing biology, and then looked at non-relapsing progression in all the studies that were available. And so this is a really large cohort, as you can see, and that there was added value to looking at neurofilament in non-relapsing progression, so that the folks who had persistently elevated neurofilament levels, despite being sort of maximally treated, had higher chances of progression. So we all know and have had that clinical experience that people will sometimes continue to progress on ocrelizumab, and neurofilament might add some value for patients in this cohort. Now, these are clinical trial patients, so they're going to be in their 40s and 50s and not necessarily the same as some of our patients who are in their 60s and 70s. But I think this was really important, and it's something that we need to keep in mind with clinical practice. We've also been looking at this in a cohort of progressive patients, about 258 people, and this is a poster here. I will for you to Ting-Yi Lin's poster here, and in our cohort, we basically also found the same thing. So if you look at either the raw values or the Z-scores, that there is separation in purely progressive MS, where they are not exhibiting signs of disease activity by relapse, or, in my mind, very importantly, also MRI, because we know MRI is a predictor of if you're seeing new T2 lesions, that's a biology that we associate with new inflammation. But in this cohort where there was more pure progression, you still see some value of looking at just high values here. The median was, we used a cutoff of 14 picograms per milliliter in this cohort. But if you calculate the Z-scores, you can see separation of the curves with even a Z-score equal to 1, 1.5, or 2. And in fact, there were so few people achieving 2 that we lost a little bit of power here. Okay, so what about looking in the spinal fluid? Makes sense. We think this is where the smoldering inflammation is happening. And of course, this is a panel of looking at many different biomarkers that are commonly reported in the literature. And some of them have some occasional correlations here, like CXCL13 we know is associated with B-cell chemoattraction and is associated with greater gadolinium-enhancing lesions. But the ones that really stand out, in my mind, are the neurofilament, again, being associated with GAD and T2, as we've talked about, and a greater slowly expanding lesion count. But GFAP, which we're going to shift to, glial fibrillary acidic protein, interestingly, not only associates with higher EDSS score, whereas neurofilament doesn't, because neurofilament's reporting on the biology of relapsing patients who are going to become disabled, but whereas here it's really correlating with the people who are disabled more so. And that makes sense because reactive gliosis, neurotoxic astrocytes are part of the biology of progressive MS. You can see also that there's a better correlation with these SCLs, the slowly expanding lesions, with GFAP. So GFAP, it's thought to be a marker of astrocytes. It's associated with higher EDSS. I'm skipping over the whole literature here because it's a little bit less evolved, and I think the real value of GFAP seems to be in looking at the progressive disease. I'll mention just very briefly that there are other astrocyte markers like chitinase 3, like protein 1, which are also showing kind of similar associations with progressive disease biology. I think, again, another study from Ann Cross and Amit Bar-Or was very compelling, looking at the association of spinal fluid GFAP levels with long-term disability progression. And in this study, first they showed that serum and CSF GFAP have a modest correlation with an R value of 0.43, but you can see that they're really not the same. And in fact, if you look at the cumulative risk of disease progression with CSF GFAP versus serum GFAP, you can see that there's much more added value with the CSF. It seems to be elevated in those with long-term disease progression. Okay, so why not start combining all these? And we're starting to see papers where people look at the combined value. There are commercial assays where 20 proteins are combined together, and Tanuja Chitnis had a nice paper last year in Nature Communications looking at the value of some of these composite measurements. I think when you look at the data that the serum neurofilament light chain shows the strongest univariate correlation with gadolinium lesion activity, clinical relapse status, and annualized relapse rate. However, the multivariate modeling did seem to modestly outperform the univariate on all endpoints. So the question is, how much added value is there? And in my estimation, it's sort of neurofilament, GFAP with progression, and then kind of all the other ones. So we'll see as that moves forward. What else is happening? Again, there are a lot of different biomarkers that one could look at. I'm very compelled with early classical complement, and the Swiss cohort has published a number of papers in neurology and neuroinflammation, two recently that really caught my attention, that early complement C3A, C4A, and BA and BB are increased in people with MS and seem to be associated with both clinical and MRI activity. And you can see the association with EDSS, MS severity, and correlated with neurofilament to some extent. One of the ongoing questions, I think, will be how much added value does complement have from a biological standpoint? I think complement's very appealing because it's made, we know by glial cells, reactive glia, the microglia, and the neurotoxic astroglia that have been reported in a number of diseases, but especially in chronic active MS, make these complement proteins, and by measuring them, we may have a readout of the biology of reactive gliosis. And that's important because we're starting to see drugs like BTK inhibitors that we'll hear about later in this session that have the ability to get into the brain and perhaps inhibit reactive microglia. And so having readouts of the biology of reactive gliosis, I think, will be very important. And then finally, in this nice paper from Catherine La Rochelle's group, they did immune profiling of inflammatory cytokines. I know this is sort of like taking a step back, but it was a very, very recent paper. As I was making sure I covered the latest literature, I saw this pop up in January. And I think what was nice about this, as someone who cut their teeth on immunology, I won't tell you how many years ago, was that they found something that we talked about a lot, this sort of Th1, Th2 change. And basically, in a fairly large cohort, they found low levels of the anti-inflammatory neuroprotective factors. So IL-4, a canonical Th2 cytokine, was low in people with MS, as was nerve growth factor. And it's a little bit hard to see, but this is highly significant with a p-value for IL-4 being low in people with MS and the nerve growth factor here as well, whereas there were high levels of growth factors, EGF and fibroblast growth factor, which are associated with the biology of disease worsening. And so perhaps someday this will become useful in estimating what's happening in an early patient, and in terms of maybe trying to boost some of these protective factors or target the biology that underlies FGF. So to conclude, I think at this time it's hard to say that there's a single fluid biomarker that captures all aspects of MS. I mean, this is true with all of our biomarkers, but I do think that we are now able to look at certain aspects of the biology of MS, and NFL gives us that readout on inflammatory axonopathy, certainly in early relapsing MS, and starting to look at GFAP for progressive MS, perhaps in combination with SNFL, because the conversion from relapsing to progressive doesn't happen overnight. So for our folks in their 40s and 50s, seeing if either of these are elevated may be useful. Probably increasingly going back to looking at the spinal fluid in certain situations could have value for compartmentalized inflammation. I'm keeping my eye on complement because I think it makes sense to me from a biological standpoint. And moving forward, I'm hopeful that we can develop biomarkers that could identify other tissue processes. So as we move into trials for protection and repair, I think it would be nice if we had something that gave us a readout on demyelination and remyelination, but so far that's been fairly challenging. So with that, I will stop and thank you for your attention, and I think then we'll take questions all together at the end.
Peter, going to move on to the next presentation. I got lots of questions here. I want to get to them shortly, so that will be great. Okay. So I'm going to discuss the clinical courses of multiple sclerosis with the understanding that these two will be revised, at least in part, at a meeting in the springtime. We're going to take a look at how we can modify these, and you'll see why as we go through this. Here are disclosures. So clinical spectrum, and this will never change. This is what you see when you're sitting in the consultation room of a patient come in, and they're going to have one of these forms of MS, and now include the addition of radiologic isolated syndrome, but they're going to have relapsing disease, primary progressive disease, or secondary progressive disease. And again, it's what you see when you're sitting in the room. This is always going to be the case. How better to modify them will be important in determining how better to treat them. So in addition, we further characterize individuals as to whether they have active disease and or progressive disease, with the idea that worsening disease was either one of these. So active disease is someone who's had a relapse or has new MRI activity by a new T2 or a new GAD lesion. And this is kind of critical because the regulators ignored this. But it has to be framed in time. And you can pick the time frame. You could say active over the last 6 months, active over the last year. But it doesn't make much sense unless you do that. In terms of progressive disease, that's gradual worsening, that's independent of the relapse, and we'll come back to that somewhat loaded term, but also must be framed in time because progressive disease is not inexorable. It changes, it fluctuates, it flattens, and in some patients, it stops. So, what do we need to move forward? Well, we need new and broader definitions of activity, and also whether we should quantitate it. And we haven't addressed that particular issue. We just said a new lesion was evidence of activity, but that doesn't necessarily say whether it mattered or not. And so this is something we have to think about in terms of also looking at things like brain volume loss, cognitive changes, which you know are not well characterized by most of our metrics, and again, new definitions for progression, and that we are making some changes with. And so here is my colleague Stephen Krieger's depiction of what progressive disease is. And one of the issues of progressive disease is better understanding the underlying pathophysiology, which is not entirely clear yet because we don't have very good access to the tissue, meaning we can't biopsy it very well. So is progression the accumulation of multiple hits, which is what Stephen's demonstrating, in this swimming pool, some of which reach the clinical surface, some of them don't. But as time goes on and gradual neurodegeneration, comorbidities, aging, decrease brain reserve, it expresses these underlying lesions, meaning that progression is recapitulating what's happened with relapsing disease, whether it gets to be clinical threshold or not. Now, this was a paper by Tanya Kuhlman and colleagues, and it's a busy slide, but essentially it's looking at what are the potential biological underpinnings. And this is an aspirational paper in terms of trying to determine, is it mitochondrial, is it due to a change in the immune system from adaptive to innate? What are the underlying mechanisms? And there are many that are being considered, including microglial-directed therapies are trying to get to the innate immune response sequestered within the central nervous system. So how do patients worsen? Well, there's only two ways you get worse in MS. One is residual impairment after a relapse. And when you have a relapse, you recover anywhere from 0 to 100%, and everything in between. And at least 50% of relapses leave some kind of measurable residual, and actually it depends on how hard you look. And then there's the PIRA, the progression independent of relapses, which is that gradual worsening that occurs, theoretically independent of the relapse. The problem with PIRA is definitional. I'll come back to that. So here's an idea of the clinical course ontology. And so we used to start in the middle, and I saw someone use a pointer, but I don't know. Oh, maybe that's here. Or the mouse. Oh, perfect. Okay. Is it doing it? The hell with it. Anyway, so we used to think of MS started as there. Oh, okay, relapsing disease. So here. And then about 2000, we started to recognize the idea of the clinically isolated syndrome. And now, as you can see, we have radiologic isolated syndrome, which at least in some cases can now be defined as multiple sclerosis. And there's some very interesting work going on in the MS prodrome, and that's what MS patients look like before they have their first neurologic event. And there are things going on, and it's a very interesting area of exploration. But in any event, the other issue is, of course, primary progressive MS, which I think most would agree is part of the spectrum of clinical multiple sclerosis, not a separate entity. And best examples of that are the fact that about 10% of RIS patients go on to primary progressive MS, whereas 90% that do go on as first attack and then relapsing remitting. And then these can be further characterized by whether they're active or progressive. And the same thing here, relapsing remitting MS may go on to secondary progressive MS, but it may not. And it may stay as relapsing remitting or become that uncommon condition of benign MS. So is all MS progressive? This is a discussion, and I use that term loosely, with my colleagues who some think it is, and I think it's not. And that's a matter of gray hair or no hair, and that is I have people I've been taking care of for 40 years, and they don't have progressive MS. In fact, they've done just great. So as we currently define progression, it's not. And this is of some importance because I wouldn't want to sit in front of a patient at the time I diagnose them with their first attack and say, you have a progressive neurologic illness, And they're going to look up progressive neurological illness, and they're going to see ALS and Alzheimer's and Huntington's and such. It doesn't matter how one reaches a disability outcome. Well, it doesn't to the patient. It does on how we approach those patients. And then this idea of progression independent of relapse activity, which is highly dependent on how you define it and how you define the relapse. So the more stringent you are in defining a relapse, the less stringent you'll be in calling someone PIRA, and the reverse. And then there's two things. One is whether PIRA is sustained, which it should be. To be true progression, it should continue to progress. Or is it just confirmed by a change over time, but not sustained? And that raises some interesting biological questions of what that is. And so here is an attempt to harmonize a definition of PIRA that put up a European group. It's a nice paper, it's a nice definition. It just fails because it is an definition, and there is no the definition of PIRA. And since it's being based on how you look at the relapse and how much time you leave for the relapse to resolve, it's kind of confounded. And here's why. So this is a very nice paper by Marcus Koch, who looked at how long does relapse-associated worsening, or RAW, last. And it turns out that those people who measure PIRA by looking at it 30 days after, or even 90 days after the relapse, saying everything after that is PIRA, would have a problem with this because he shows that it could take up to a year before you recover fully from a relapse. And so that confounds the definitions. Samita Satyanarayan in our group took a look at how these definitions are affected by defining the relapse. And so what you see here are 3 columns. The one on the left is the most stringent definition of a relapse from a study we did. The one in the middle was a little more liberalized. And the one on the right was if the investigator said it's a relapse, whether there had been a change in EDSS or not, they called it a relapse. And what that does is that when you go from the most stringent to the least stringent, you triple your number of relapses. And when you do that, of course, you decrease your event of PIRA. And the other thing that happens is that you can look at things like PIA. PIA is progression independent of activity, smaller number than PIRA, but again, they both go down over time as the relapse rate changes. And so definitions count when you're looking at this. We did a study using a database. So Novartis, that had done dozens of clinical trials, gave all their data to the Oxford University Big Data Institute and put it in for all sorts of additional studies. On this one, we looked at what the relative rates were. And this second column is the one I want to draw your attention to, because this is from phase 3 clinical trials. The top is from a full data set, which included some observational trials and such. And it showed, and this is from multiple agents that were tested. So in those trials of relapsing remitting patients, you could see that almost 36% of patients had a relapse on the trial. Most did not. And that down here, the frequency of relapse-associated worsening and the frequency of PIRA were about the same, and it was only about 3 to 4% for each of them, because some could not be characterized. Now, you'll see all sorts of different percentages that people present. Again, it depends on how you define your events. Now, not surprisingly, when you get to secondary progressive MS and primary progressive MS, the main drivers of disability there are progression independent of relapse activity. So I talked a little bit about irreversible PIRA, which is pretty clearly progressive disease. But there is PIRA that reverses. It reverses over months. And it's hard to know what that means. Is it a slow relapse? Does it affect on repair mechanisms? Is it EDSS error, which has plagued us for decades now? And biologically, might it be related to things like pearls or slowly expanding lesions? Hard to know because they go away. And I don't know if Danny addressed that issue, but they do go away. But they usually take longer than this reversible PIRA. So here is what we're thinking about as we approach this meeting in the spring, looking at individuals who have susceptibility that is at risk, and that would be both genetic and environmental. And then there's the biological onset of disease, which we presume occurs well before the clinical expression. They may then go on to RIS, or they may have prodromal or nonspecific symptoms, and then ultimately manifest themselves as some form of multiple sclerosis. And we're also starting to think of the disease as phasic. One of the criticisms of their current classification is that it buttonholes people when it's a more dynamic disease, which is to say, once you say someone has secondary progressive MS, they never can lose that title. And that may not be reflective of the underlying biology, or at least of the clinical disease. And so we're starting to think of this more in phases of disease, relapsing phases, progressive phases. There was another paper by Marcus Koch and his colleagues showing that most of the events that were being called PIRA also occurred in close proximity to relapse activity, which confounds it, but it gives you a little idea of what's going on biologically. So stable phases, worsening phases, this is all being worked out, and we're going to have a large discussion about this in the fall. So, but this is how I like to look at this in terms of these phases. A relapsing phase, a progressive phase, these are not necessarily independent. Stable phase would be, repair phase would be, inflammatory phase gets back over here if we can get into immunophenotyping and looking at both the adaptive immune system, which is the one we're most accustomed to treating with our current agents, the innate immune system, which we're hopeful of being able to treat, and then also the degenerative phase. And that is a better understanding, we hope, of how much of MS is inflammatory, smoldering, and how much is more pure neurodegeneration. And so this is just another way of thinking of the spectrum of disease, and I just put this in because I like the picture. But the money shot is over here in terms of these different phases. Some of the work that's going on for this, and this is a paper that's in revision, also involved not only the Novartis data set, but two other clinical data sets trying to use an AI approach to, and that's the agnostic part, to staging of MS disease. So up here is very mild disease, down here is more severe disease, and the arrows point to the transitions that can happen. And the wider the arrow, the more likely a transition would be. And I just draw your attention, this is going to be it's a very dense paper, and it's interesting, but in here is inflammatory activity. And what this model showed was to get from early, somewhat inflammatory MS to the more severe degeneration, everybody went through an inflammatory phase. And that has some interesting considerations for us. There's also work being done on immunophenotyping by many, some in the audience here. This one came from a German group looking at blood immune parameters and classifying different types of MS based on a multi-omic approach to this. This is something that we hopefully can see in the future in terms of looking at the immunoprofiling of patients over time. And this is also some interesting work that came out of UCSF and some others, finding an autoantibody that was predictive of the development of multiple sclerosis. This was in patients who were going to go on and develop MS, and they had some autoantibodies to a number of different targets, some of them microbial. Interesting work, still needs to be looked at further. So next steps for us to think about are biologically based phenotype. This would fulfill the aspirations of the Kuhlman paper, using radiologic biopsies to look at things like chronic active lesions, slowly expanding lesions, paramagnetic rim lesions, focal and diffuse atrophy, and also repair. And this is going to be very important for us as we look at remyelinating repair strategies, to be able to better image first, the patients that are appropriate for a repair strategy, and then second, the success of that strategy. And then fluid biomarkers, as you heard from Dr. Calabrese, Pathologically, not biopsying, but looking at immunophenotyping, looking for markers of demyelination, degeneration, and also markers for repair. Then genetics, and I'm particularly excited about the idea of finding genes. So there are 200 plus genes for susceptibility, but just a small number, only 1, 2, or 3 genes for severity of disease, but they don't overlap. And so you not only inherit the genetic susceptibility to develop MS, but some patients will inherit severity genes, and they're the ones that are most at risk for getting worse. So I think of one MS for all these different phenotypes. I'm not going to stop for that. Things to think about, well, when we change criteria, there are unintended consequences because the clinical classifications are picked up by multiple groups: patient and patient care, regulators, clinical trials, and such. And so we've already seen where some of what we've done has been interpreted incorrectly by regulators. The phenotypes are the clinical reality, and they're baked into the system. There's definitional problems, for example, with PIRA. There's considerable overlap of activity and progression, that is inflammation, neurodegeneration, and it's going to be critical for us to be able to separate those two out. And so, for example, Peter Calabrese showed you a slide of looking at NFL as a measure of progression in an anti-CD20 study, and that's a really good way to approach it because those patients had their inflammation turned off dramatically, so it lets you look better at the underlying degeneration in part, except for whatever role the agent's playing on that. And then when we think about, we have to communicate this with the diverse MS community, and how do we do this in the absence of better biological understandings? And here are my colleagues at Mount Sinai, and I thank you all for your attention. And we have lots of questions. We're going to have the speakers come up. We may well go into your break, and I'm sorry about that, but there's really lots of questions here. So Peter and Danny and Joe's coming up, and Fiona. So the first, as they're coming up. So when is 24 going to be published? When should we start using it in practice? Well, the manuscripts, I think it went back in as a revision, or if not, it did go back in. And so it's been presented. You can start using it now. Danny, how often are CVS and pearls being reported in routine MRIs, and how can this be advanced?
I don't think that they're generally being reported in routine MRIs, except at specialized centers, perhaps. You can report them on the clinical SWI, particularly the pearls, but most of the studies that I see coming in on patients who come to our research clinic and bring with them outside MRIs from a variety of places don't actually save the phase image. It's just a checkbox on the scanner, and so if without that you can't really see the pearls. I don't routinely check the outside reports to know what other people have said about those studies. I just look at them myself, and it's not always so easy to see those. So I don't think it's being done routinely. What I can say is that as part of the effort around kind of socializing the new criteria, NAMES has been developing educational content. We'll roll that out at radiology meetings to try to help neuroradiologists understand these criteria. So I hope with the availability of the sequences and that kind of socialization that we'll start to see it more. And you guys can certainly advocate for that.
Nice. Okay, Joe, can you clarify the diagnosis of progressive MS in the setting of 2 spinal cord lesions? Does any evidence of new spinal cord lesions equal progression?
I would think so. I mean, that's dissemination in time, so I would think so.
So it's not
I didn't see
progression,
it
right?
Yeah.
In fact, I should say we do not have an MRI metric of progression, a reliable metric of progression. You heard from Dr. Reich that you could see things like pearls in RIS, for example. So there's a numerical difference.
And you can see atrophy in RAS and other, and relapsing MS. So yeah, that's right.
Okay.
But Fred, can I address you? You said I actually did not, as you said, talk about pearls disappearing. What actually happens is, so pearls are chronic. The pathology, we know this. The pearls reflect chronic inflammation around lesions. They form, this iron rim forms after a new lesion develops, and there's not a lot of data, but the half-life seems to be around 8 to 10 years of the iron rim. The lesion persists, and we don't have any data about what a pearl is, an X-pearl is pathologically. We don't know whether the inflammation persists, but the iron is gone, so we don't see the rim anymore, or it just resolves into a chronic inactive lesion. And that remains an open question for us. Yeah.
Well, thanks for the clarification. This is a tough one, Joe, but try it. Can you discuss the warning signs of when to do a deeper investigation of non-MS causes despite the MRI looking like classic MS and the right age group?
That's an impossible question. I mean, it's a bit like what Potter Stewart, the old Supreme Court justice, said about pornography. I know it when I see it, instead of trying to diagnose it. I mean, there are many instances where it just helps to be an experienced clinician. One of the things I've railed against is how cursory we've become in obtaining histories and in performing physical examinations. I just wrote a paper, I don't know if it'll get accepted, on the lost art of history taking. Too many of us sit with our nose in front of the computer screen without looking at the patient, writing down what it is that we've heard from them, recapitulating it to them before we record it to ensure that what they've told us is accurate and allowing them to expand on what it was that they've told us. And too often the examinations are cursory as well. I don't know how many of you look at prior charts, but I often end up doing this, where a 10-minute office visit is a 30-page note. How the hell does that happen? Because you've copied and pasted from prior notes. The computer allows you to do that. You've copied and pasted x-rays and laboratory reports and absolutely useless information that is often inaccurate because it was inaccurate at the time that it was obtained. It may have been obtained by a medical student, and you keep putting it back into the note, and it becomes encased in somebody's mind. So what I would say is just be careful. Be thoughtful about what you do, and be precise. And you'll generally not miss MS. I mean, we've gotten better. I know Danny showed a slide from, I forget his name, but one study that showed the frequency of misdiagnosis. The frequency of misdiagnosis was enormous at one point in time. Before MRIs, pathologic studies suggested that as many as 50% of MS patients were misdiagnosed. Now it's probably down to 5 to 10%, but it's still 5 to 10% we're misdiagnosing. So you just have to know. I mean, you just have to be well aware. And one other thing that I suggest is when the patient comes back to see you, question yourself. Don't be afraid to question yourself. Don't buy into the diagnosis. And I said this in another meeting. There have been instances where patients come in to see me, and
Lots of questions here, Joe.
all right, sorry. So go ahead. I mean,
But that last point is a key point, and it is in the McDonald paper that you ought to reconsider the diagnosis periodically, and that's very important. So, Fiona, how comfortable do you feel using the optic nerve as a fifth topography in a person without any clinical visual symptoms, but has unilateral retinal nerve fiber thinning on OCT? And then secondarily, is inter-rater reliability of the OCT a concern?
Yeah, so can I rephrase it just to make sure I understood it properly, Fred? So how confident am I using OCT of the optic nerve
Asymptomatic patient.
in an asymptomatic patient in the real world? I know you didn't add that, but I think it really makes a difference, and it goes back to Joe's point. When you're a hammer, everything's a nail. So if you're sitting in a clinic that is named for a disease, you have an inherent cognitive bias to assume people coming to you have that disease. And actually, we need to be the gatekeepers to make sure that we don't overlook people and lump them into the wrong, because you're committing them to a lifelong disease and the psychology of that, not to mention the immunotherapy of that. I'm a neuro-ophthalmologist, so I see a broad spectrum of diseases, and I make no assumptions. And I couldn't echo more, Joe, what you said, because I have had a cognitive bias to assume an acquired optic neuropathy in a young person is inflammatory, because I see a lot of MS, because 1 in every 350 to 400 people in Alberta has MS. But I have overdiagnosed MS and optic neuritis in people who present it with a young version of non-arteritic anterior ischemic optic neuropathy, and I had to go back and take the history. So I would say what I didn't have time to answer your question, Fred, is point out that simple media opacity can buy you an inter-eye asymmetry of 4 to 5 microns on the retinal nerve fiber layer, as well as ganglion layer, and so that can just be cataract. I think that OCTs, we have great quality assurance parameters in place, but I would never personally use OCT in a patient carte blanche without a really, really rigorous history and a really thoughtful contemplation of the whole body of evidence, because the very same findings can be found in a plethora of different conditions. And so my world is heterogeneous patient populations coming in with similar OCT signatures, and I have to really interpret the diagnosis with a little bit of input from the OCT, but with more input actually from the history and physical. So I would be very confident in the right context that it would be good for asymptomatic optic neuritis, probably in a patient that had 1 million flags already for MS. But I would not be confident in someone where I wasn't even sure of the rigor of the MS diagnosis, what those inter-eye asymmetries mean.
Peter?
Yeah, I just wanted to expand on what Fiona just told you. So first of all, Axel Petzold has a really beautiful paper in Lancet Neurology about the differential diagnosis of optic neuritis, and globally there are over 50 causes of optic neuritis / optic neuropathy, which is kind of what we're talking about here in the asymptomatic case. And then those inner eye differences, IEDs, and the Kenny paper, and there are posters at this meeting. Anna Becchetti has a nice poster on this, are done in a very controlled fashion where there's quality control of the data. And so if someone is looking to make sure the OCT fulfill what are called Oscar IB criteria, and if you're not doing that and you're not looking at the segmentation that comes off the machine on something like the forum where you can scroll through the 3D volume cube, you're not QCing your data. So if you just look at a printed out number that the machine gives you, that may be technically wrong. And when we parsed our cohort into fulfilling Oscar IB criteria or not, the IE differences that actually were predicting optic nerve involvement went up to like 9 or 10 rather than just 6. So those are optimal data, and I would urge caution in the clinic, and, as Fiona is saying to you.
And I think, just to say, I actually think the role of vision scientists, IMS Visual as a group, and neuro-ophthalmologists now, I think, are to provide a little bit of safe gatekeeping and talk about pitfalls of a technology, because all of the wonderful data presented, I showed you, the multiple studies, these are in cohorts that have been rigorously curated and actually don't harbor diagnoses other than multiple sclerosis. But in your everyday practice, patients don't come in, that purely because they're undifferentiated.
Danny, Any specific lesions or topography on MRIs indicative of brain volume changes and/or consequent clinical measures?
So lots of associations between lesion topography and appearance and brain volume. Dark T1 lesions, for example, tend to be more present in the setting of brain volume loss. And that you might expect, given that these lesions tend to be more destructive. The beauty of MRI is you can measure multiple things at one time, so you're not just getting an MRI for lesions to look at volume.
How about location?
I don't want to cite incorrect data on that. Yeah.
So
But
there are some data.
what about spinal cord volume, cervical spinal cord volume, and disability?
One of the stronger correlations with disability is cervical spinal cord volume. Also, thalamic volume is another one that seems to be a little bit more specific. Gray matter volume, cortical gray matter volume. None of them is really fantastic, right? Like if you look at the correlation coefficients, they're in the 0.4 range in the large studies, maybe 0.3. So there's a lot of unexplained and a variance, and part of that is that multifactorial causes of disability, and another part of that is noise in the disability measures.
There are some data that people with lesions in brainstem and spinal cord are more likely to go into secondary progressive MS.
Yeah, for example, then people with pearls are more likely to go on to secondary progressive MS. But again, these are, I think progressive MS is kind of it's like a funnel. It's the sum total of many different factors that are present in different proportions in different people.
While you're answering, why do lesions form around veins as opposed to arteries?
Oh, that's a great question. And it's obviously different from other conditions like, small vessel disease or vasculitides, et cetera. There are very few autoimmune diseases that form around veins. Now, we know something about the trafficking of immune cells in the brain and how they come out of postcapillary venules and the cell adhesion molecules and other transporters that are present at these, so probably has something to do with where brain antigens are recognized in the perivascular space in those conditions, and myelin is really immunogenic. One interesting thing to point out, so there's a lot of literature now on dilated or MRI visible perivascular spaces, and people have thought maybe that represents areas where there's inflammation. They are more visible and larger in MS compared to age-matched controls on average, but those tend to be around arteries. So there is interesting things happening around arteries rather than in addition to what's happening around veins, but the lesions form around veins. It's pretty cool.
Okay, so I think we've kept folks in the brain. Well, there's some more questions. I hope to get to them later, but I think it's time to take a 10-minute tops break. Thank you very much to you guys. These were great presentations. We want to get started again. Yes. Freeman. Yeah, we're going to get him mic'd up to make the sound a little better. While they're doing that, we have lots of people who are online, and I just want to say a welcome to them. And a special welcome to Dr. Larry Blum, who's attended the last 9 sessions in person here, but for medical reasons couldn't attend today. But he's online as best I know. But let's all take our seats. Mark Freeman's going to give us an update on anti-CD20 therapies, and this is a symposium that's supported by TG Therapeutics. So I think Mark's getting mic'd up. Keep the questions coming in. They've been great so far. It's kind of light in the eyes here, so I can't see where he is. So Dr. Freeman's from the University of Ottawa, where he's professor of medicine, and one of the places where neurology is still a division of medicine. Okay, is Mark mic'd up? Yes, no? Here he comes. Okay, thanks.
I don't know what to do with this, though. I'm the test subject here to try to get rid of the echo. So, is it on? All right, you can put that away somewhere. So you guys can feed back and see if this is any better than what we've been hearing before. Oh, okay, perfect. Excellent, thank you very much. Again, I appreciate the opportunity to speak at this symposium put together by academic CME, and as usual, they usually load me with everything and then a little bit more. So I'm going to try to quickly update you on the use of an expanding field of drugs, the anti-CD20 therapies. I have some disclosures, and these are what I hope to cover in the next 45 minutes. We'll talk about the rationale. I'm not going to get into too much immunology, but I think you have to understand a little bit of it. Some of the strategies to individualize therapy are going to also be covered by, I think, Stephen Krieger later, so I'm trying not to overlap too much with his talk. But I will review the clinical trial data and try to put this into perspective when we consider the kind of patient that we want to put on these therapies. You need to also appreciate that that person uniquely doesn't have just MS. You have to put into perspective things like their age and comorbidities and look at some of the interesting safety data. So the expanding field now is 4 drugs. I put rituximab in brackets because it's never really been tested properly in a phase 3 clinical trial, so it doesn't have that kind of approval that's seen of the other 3, but it was the prototype that was used for years, especially in other entities such as in rheumatology. So there's lots of properties of B cells that lend itself to perhaps a target for MS, and we've learned about these as time has evolved. Importantly, not only do they evolve into plasma cells that make antibodies, some that may be relevant to MS, but one of their key roles is in fact to present antigen to T cells, something that you may have ascribed mainly to cells such as macrophages. So the notion of a B cell presenting an antigen is also important because when that interaction occurs with a T cell, the T cells are seemingly more activated very specifically, and that interaction may be the key to preventing the buildup of inflammation, which has always been looked at as being driven by the T cell, but the real culprit here may be the fact that the B cell is doing that stimulus. And so the observations about the B cells have become really important to the understanding of the basic pathophysiology of MS. And these B cells have to be produced usually externally, and then they proliferate and they can travel into the brain, and you can see them in these B cell-like follicles inside. So the notion of targeting them, at least in the periphery, is to prevent their ingress into the brain, where they will then set up this chronic inflammation that's thought to underlie some of the progression that you heard about earlier. And so targeting them here may prevent their ingress to the brain, and we still are looking for ways of getting at the B cells that are trapped behind the blood-CSF barrier. And I will yield to our resident B cell expert, Amit Baror, who's going to talk to you a little bit later about another group of cells, therapies called the BTK inhibitors that may actually do that. So why do we want to do that? We want to do that to prevent the buildup of those follicles and the chronic inflammation. So just to note a little bit about the generation of these B cells. They do mature and they express different markers as they do so. And at the bottom here, since we are talking about therapies that target CD20, it's important to note where along the line of differentiation of the B cell ultimately into the plasma cell, where you see the CD20 expression in the type of cells that might be taken out. We'll come back to these guys a little bit more because they're the memory B cells and they may have a specific role that is important to MS. And here it is, and don't forget, there's no way you're going to be able to read this, but let's just put them into three broad categories. So I already told you about antigen presentation. That's a very important role to the T cell. And then we have the cytokine production, which are pro-inflammatory. And these cytokines can stimulate other types of cells to get involved, maybe the microglia and maybe other, even the astrocytes. And then there's the third component here of the differentiation into plasma cells and the types of antibodies that they're being produced. So B memory cells are extremely important. Well, let's come back to this CD20 expression, and you can see the wide window here. And the fortunate that these cells also express CD20, so as part of the way in which these drugs work, may be removing these B memory T cells. So here are the different drugs that we have, and here's the CD20 molecule, and you can see that the target epitope for each of the drugs is slightly different, right? We have the original rituximab, and then the ocrelizumab with a little bit of overlap, and then we have the ofatumumab and the ublituximab epitope. These are all slightly different molecules. And just some terminology in case you didn't know. So the old OMAB are usually pure mouse antibodies, and those are not used in humans. But as soon as you get an iximab, you are dealing with a chimeric. So you got a little bit of mouse way up top, and then mostly human. So in these cases, about 65% human. And although I've put ublituximab in here, it is really somewhat different because it's a glyco-engineered chimeric antibody designed to bind a little bit better and lead to a different way of killing, which I'll come to in a moment. Then we get to ocrelizumab. The izumabs are even getting more human, so greater than 90% of the structure is human with just a little mouse at the end and the tail. And then finally, you get the fully human molecule, which is the umumab, and that's ofatumumab. And this has important potential for immunogenicity, as you can see going down here. So the potential of your body rejecting the molecule, forming antibodies against it, is virtually zero with the human, but gradually increases with the amount of mouse that's still present. Some of the differences are the basic motifs that you see here, and this once again represents the immunogenetic way in which the drugs will stimulate anti-drug antibodies, which are sometimes relevant to the way the drugs are actually working. So now let's just talk about how they actually work. Well, they eliminate the B cells by one of two ways. One is called antibody-dependent cell cytotoxicity, whereby the Fc structure binds to a cell. In this case, it's just shown as an NK cell or K cell, in which case this is now an armed killer. Knows its target, and when it sees it, once it binds, you brought the killer cell in close apposition to the target, and the B cell then is stimulated to die, usually through released proteases and other things that these killer cells tend to do. The other is independent of a cell, is complement-dependent cytotoxicity. You remember the old complement system, when the antibodies come together and join up onto the surface of a target cell, they activate the complement cascade, leading to the formation of a membrane attack complex, which ultimately leads to the death of the cell. So you can imagine this is all happening possibly in the tissues, but also intravascularly, and that leads to some of the side effects that one sees with the various drugs that we're using here. As you release proteases, you create types of responses in the body that could be a type of sickness that we have to combat against, and that's why a lot of the pre-drugs are being used. And when you activate complement, you activate a big cascade of pro-inflammatory molecules, which also have to be looked at. So if you looked at the 4 different drugs, that's sort of in the bottom right here, you can see that they all kill by both, but some are more apt to kill differently. The glycoengineered ublituximab shown here is the one that is causing more ADCC, and it's thought that the more complement-dependent one is more associated with some of the reactions that one sees. Again, a very difficult slide to read, but let me just point out a few things. One is the different types of cell death that are occurring here. So the ADCC, CDC versus ADCC. But what difference does this make? It may make a difference in how fast the cells are the target, the B cells are destroyed. So you can see that with rituximab, ocrelizumab, ofatumumab, it takes probably a couple of weeks to deplete the cells, whereas with something like ublituximab, you can get almost 98% depletion within 24 hours. Does that make a difference in the clinical efficacy is unclear. If you stop the drugs, how fast do B cells come back? And that too is seen as a difference here between the different drugs, concentrating on ublituximab, ocrelizumab, and ofatumumab. You can see here that the B cells are expected to come back at different time periods. Ublituximab and ocrelizumab, probably the lower limit of normal within about 70 weeks, whereas it's a little bit faster with ofatumumab. Then there are differences in the clinical trials, and I'm just going to go through these and show you that they are more the same than they are different, with pointing out some of the nuances here, but you can see all these trials, they've been published. The only difference is with the rituximab, there is no phase 3. So there are some limitations. Remember that the CD20 expressing B cells are not the entire B cell population, and we don't know amongst those who the bad guys are, and that's always the story. The same truth with regards to the T cells. If we only knew which cells were the true causes of the disease, we would be able to take them out and spare the rest of the immune system. We do have some other subsets that are involved in chronic inflammation. That's important. We don't know how to distinguish pathological from not. We also know that there are some T cells, a very small segment of T cells that express CD20, and their clear role has not been defined, so that there may be some overlap with with homeostasis of the immune system if you take those cells out. We also don't know if you need to continuously remove them, and maybe just a few treatments is enough to perhaps generate an immune response and disease control. So here are just quickly the key outcomes of the various trials. And the first one tested was ocrelizumab, and it was against the interferon beta-1a 3 times weekly molecule. The others were tested against the oral drug teriflunomide. So there's differences in the way the study designed. The 2 OPERA studies, back when they were done, showed that they were adequately inducing a reduction in relapse rate. Note that the relapse rate is not 0, so there are still patients that continue to relapse while taking ocrelizumab. They are very efficient, as you've heard from earlier talks, at knocking out the inflammation as indicated by the presence of enhancing lesions, reducing enlarging T2 lesions, and importantly, slowing confirmed disability progression using either of the definitions of a 3 or 6 month confirmed disability progression. Nevertheless, as you saw from that subset analysis, I guess, of the patients who were in these studies that were looked at later, rebaselined at 48 weeks, there continues to be some progression in the ocrelizumab arm as well, but it was slower compared to the interferon arm. Here's the PIRA story. So there is definitely a reduction in PIRA compared to the interferon, which was considered statistically significant. And when we look at NIDA rates, they're increased to about 48%. And just keep that number in mind, because you'll see it again and again with the other trials. Neurofilaments, you heard a little bit from Peter earlier. Just about every effective therapy that is for MS will reduce neurofilaments from baseline, and we saw that in the OPERA study, as well as the oratorio and primary progressive MS. And in terms of the side effects, I'm just going to spend a little more time about that. Because this is an infused anti-CD20, the infusion reactions are the big ones, but also the importance are 2 other entities: the appearance of infectious problems, especially respiratory, and there is a signal, at least in these studies, with regards to malignancy and especially breast cancer. And that popped up, at least with the ocrelizumab in both studies, but not has been seen in rituximab over the years. What also occurred was when they measured the immunoglobulins over time, it was also clear that the longer you were on the drugs, that there were depressions of immunoglobulins. And this was a very hard analysis to do, but when you try to correlate the periods of low immunoglobulins with the rate of serious infections, you can see here that the rate of serious infections was probably 5 times higher in patients who were persisting with hypogammaglobulinemia. And those are some things to think about over monitoring. The ofatumumab is the human molecule, and 2 studies, very similar, Asclepios 1 and 2. The comparator was, in this case, teriflunomide. You got the reduction in relapse rate, similar to what was seen with ocrelizumab, really elimination of new lesions as measured by GAD, and or enlarging T2 lesions, similarly to what we saw with ocrelizumab, and with these pooled analyses, a reduction in confirmed disability worsening, regardless of the definition. When we looked at PIRA, there again was PIRA with or without relapse, and there was a clear indication of a signal with ofatumumab. Here's your NIDA rates. When you look at the overall study, so that months 0 to 24, you're looking at a 40% improvement in NIDA, similar number to what we saw with ocrelizumab, and a reduction in neurofilaments with any powerful drug, similar to what we saw with ocrelizumab. They looked at other things such as drain volume changes and whether or not this was significant. And it turns out it's interesting that this was not significant, But teriflunomide in its own right was shown to slow brain atrophy, so maybe it was just not a signal that was big enough to be able to see the difference. The serious event profile was better than we saw with ocrelizumab, but this is a human molecule, and you don't need to with it. There are still some infections, and they also did not see the depressions in the immunoglobulin the way it was seen with the ocrelizumab. And so we didn't see that signal necessarily increasing in the blue. This is with IgM or with IgG. And the infections that we're seeing with the times that they were below the lower limit of normal are much lower than what was seen with ocrelizumab. We finally get to the ublituximab studies, also tested against teriflunomide, slightly different infusions for these patients, and interesting study that was mostly done in the United States and in Russia, so I've just pointed that out for you. But the results are similar. A strong reduction in relapse rate, a big reduction in enhancing lesions, and the reduction in new or T2 enlarging lesions. No effect on the confirmed disability progression in either of these definitions, although interestingly, we also look at confirmed disability improvement, and in that circumstance, there was a significant effect of ublituximab over the teriflunomide. Similar numbers for NIDA, so this is the green here, in that 40% range, just like the other two molecules improving NIDA, and there were a couple of other measures that I'll just skip through. There was an effect looking at one of the brain volume changes, but not a different one. In terms of adverse events, again, it was infusion reactions that stand out as one would expect compared to teriflunomide. And in terms of serious adverse events, there were some malignancies, no big signal here like we saw with ocrelizumab, and deaths which were unrelated, and no cases of PML. The immunoglobulin drops are not what we've seen with ocrelizumab. They weren't terribly substantial. Okay, so I wanted to just take a few minutes and talk about safety issues here. Persistent hypogammaglobulinemia is a risk factor. If you're going to monitor patients, one of the suggestions is to look at IgG. It's important to get a baseline. Although the prescribing information in the drug monographs in various countries don't necessarily recommend doing this, but I can tell you in general, we do it. We monitor a CBC, we monitor IgG, we monitor neurofilaments, and I'll show you the reasons for doing that. We have seen serious infections associated with profound and prolonged hypogammaglobulinemia, especially upper respiratory types of infections. These are rare, fortunately. There have been cases of PML associated with these drugs, especially outside of MS, but also within MS and not necessarily related to pretreatment with natalizumab. And then one of the questions that I'm going to come back to in a moment is about what the B-cell population looks like after you stop the drug. After you've been treated for a while with the anti-CD20, there's good evidence to show that the B cells that reemerge are not the same, at least profiled-wise, as the B cells that started. And if that's the case, do you need to keep hammering away and depressing the B cell population? Or have you already altered the immune profile of the disease, which then may have a durable nature to it that you don't necessarily need to retreat? And I'll return to that in a moment. But it's important to also manage the patients who are long-term on these drugs because they're getting older. And as they get older, they get more risks to other conditions. And simply just by immunosenescence alone may be at risk of more problems than they had when they first started. And so early on in the trials, most of the patients were young. But after now being around for 15 years or 20 years, they're starting to get into that age group where you're going to get into some problem. The malignancy issue comes up, but the numbers are too small to really yield an important message from that. All one can say is if there is risks in the family, this is something to consider before launching an anti-CD20, at least in our center. And this has changed with regards to national screening, but if it's a young woman, we usually will get a mammogram, especially if there's a family history, even though they may be in their 30s or 40s. It's not so hard to have a mammogram, and then you at least have some assurance that there was nothing there before you started. We don't necessarily know that the anti-CD20 is inducing a malignancy, but maybe it will unmask one if it was there to begin with. Let me talk a few minutes about some other interesting aspects of anti-CD20 and one of the reasons to do routine blood tests. Time and time again now, we've seen this issue of late onset neutropenia defined as the presence of a neutrophil population less than 1.5, 4 to 6 months after a treatment that lasts. And this has been seen with both ocrelizumab and ofatumumab, certainly been seen with rituximab, and described years ago in rituximab, but now it's been seen with the two common ones, ocrelizumab, ofatumumab, not yet seen with ublituximab, but maybe it's just going to be a matter of time. This has led to an increase in the type of infections one would see with prolonged neutropenia, which are some of the bacterial infections. Some people have advocated just stopping the drug and waiting for the B cells to come back, the neutrophils to come back. Others have persisted, and I think there's enough cases now that would tell me that if that happens, probably you need to stop the drug and change your approach to the MS. There's a case now that was switched from ocrelizumab to ofatumumab, and then the same problem occurred again. So going to a different B-cell antibody may not be the answer, but it's also one of the reasons to routinely do a CBC, because you don't know who's going to get this. And it tends to happen, and it can happen early, and it can happen late. There have been now a number of cases of colitis, and the type of colitis that seems to be occurring, most reported with rituximab, but that there are at least 38 cases now reported with ocrelizumab, seems to be an immune-mediated colitis. Not clear how that occurs or why, but again necessitates the cessation of that particular therapy. And there are some more recent case reports of unusual things happening, such as this palmoplantar pustulosis. I have no idea what that is, I can tell you. And organizing pneumonia that kind of looks like COVID, but is not. So these things have been reported with prolonged anti-CD20 therapy. So this is one of the questions that then comes up. Can you stop the drug? And what would you expect to happen? So I know these studies have occurred, and unlike the anti-trafficking drugs, such as the S1P receptor agonist or natalizumab, you don't get a rebound. There's no big blossoming of the disease after you stop an anti-CD20 therapy. And even if you go way back to the original phase 2 trial of ocrelizumab, this was a phase 2 after all, so they were like using it as a preparation to a phase 3. After the phase 2 was over, they followed the patients, and there was no big rekindling of the disease, suggesting a very durable effect of a couple of years of therapy. We know that during COVID, a lot of patients were quite anxious about walking out of their house even, let alone going to an infusion center where they're going to run into other people who are going to give them COVID. They stayed home. They didn't take their infusions. And smartly, the investigators followed those patients for upwards of 2 years. And they didn't even have a relapse, and their MRIs didn't show any change. So maybe there is a durable effect of just a couple of years of therapy. In Sweden, for instance, they use flow cytometry to follow the patients. And after they've been depleted of their B-cell memory cells, which you can profile using a cytokine profile and flow cytometry, they would stopped the anti-CD20 therapy. In their case, they were using a lot of rituximab. And then only when the B-cell memories started to come back and they were able to measure them again, did they hit them with another course of therapy. So maybe they can follow it that way and not necessarily continue the anti-CD20. I already told you that the repertoire changes. So the cells that come back even after a treatment are not the same necessarily as those at the beginning, and maybe those cells are no longer the ones that are going to be pathogenic. So something akin to what has been referred to as immune reconstitution treatment that we usually use in association with therapies such as alemtuzumab or cladribine, because you only have to give a couple of courses and then allow the immune system to recover. It's also important to think about the patient, right? As they are getting older, over the age of 50, immunosenescence, increased risks of infection and other comorbidities, maybe that's a good time to, if they've been stable for several years on the therapy, to either de-escalate to a different therapy that's not going to have these problems, or maybe just discontinue it outright. Those are all possibilities. I'm just going to get into this a little bit, and then, because as I mentioned, Stephen is going to cover this in a little bit more detail. Who do you select for anti-CD20? Is this good for everybody? Should you just give it to everyone? I think we have to think about prognosis, and now there are so many tools to help us in this regard. There are not only the clinical profiles, but you've heard from others about the MRI, but biological biomarkers that might inform on someone's ability or risk for early progression that would warrant the use of a higher efficacy therapy to begin with. One of the risk factors for early progression is already failing to control somebody on a disease-modifying medication, keeping in mind that even the simple so-called platform drugs have been around for a long time, and many patients respond to those drugs very well for years. It's selecting that group out that don't respond that you want to get onto a therapy that's more effective to begin with. Keeping in mind that these drugs are not innocuous, what are the comorbidities of the patient? Are you putting them at more risk if you go that route than benefit? There's a special circumstance around the young woman who's either going to get pregnant or maybe can't practice proper contraception to think about this. There's also the patient's view on the whole idea. They read so much stuff, it's amazing. They come in with all sorts of Dr. Google stuff, and they're telling you, this is going to happen or that's going to happen. And if they're very risk averse, then you have to be careful about choosing the higher efficacy therapy. Many patients today travel, and I know this is now a dirty word here in the United States, vaccine. Is there a reason for a vaccination? Some of these drugs do not allow you to use live vaccines because there's a possibility of the vaccine actually inducing a disease. So if you need to plan ahead, you may want to get these patients immunized before you start the therapies. I already mentioned about the importance of blood monitoring. Is this a patient you can rely on that will come for their blood tests? Reliably do them in a timely manner that you can feel safe monitoring them. Do they have an aversity to coming to an infusion center versus self-injecting? Those are all things to consider. And then finally, obviously the logistical one at the bottom, which would be important in some parts of the world. Are they going to get covered for their medication over time? So who's going to get one of these? I think anybody who has demonstrated a moderate or severe early expression of the disease needs to be on to a high efficacy therapy to start. Certainly, if they've been treated for a period of time with either an injectable or an oral and have continued to have breakthrough disease, that's a group. We also may want to use them in circumstances that are planned pregnancy. There's this notion that if someone's going to get a baby or have a baby in the next couple of years, maybe suppressing the disease outright will buy them the time that then if they stop the therapy during the pregnancy, there's no rebound and you can control them for a couple of years afterwards. So those are the cases in which we'd use. In terms of switching, I just threw this up here because we have these criteria in Canada. the not yet 51st state, and not to be. I needed my Canada Not For Sale hat on here, I didn't wear it. But we do have these criteria that guide your hand should you decide that a patient is having too much disease. They would satisfy any of these major criteria, you'd want to switch them. And these are the strategies that can be evolved. So who's going to get onto these drugs? Obviously, if someone has got a limited tolerance for treatment failure, that would be your moderate to severe cases. You'd be recognizing that high efficacy therapy would be the call for this particular group. So in conclusion, there's no question these drugs are highly effective. They're beneficial. They're very well tolerated. They do have an excellent short-term safety record, but there are some limitations, especially in long-term use in an older individual. We've talked about the first or second line use and the special considerations of pregnancy, and I will stop there. And I think that Stephen will be covering some of the other things. You want me to stay here? Okay. Oh, okay. Thank you.
Questions? Can you turn this back on? Quite a few, actually. So first is, how large of a clinical difference does using a humanized versus a fully human antibody in regards to immunogenicity and drug reactions? Does removing the last piece of mouse protein make a substantial clinical difference?
Well, I think it does. You don't have to pre-treat. If you're going to use ofatumumab, there's no steroids, there's no antihistamines that you give prior to the injection. Plus, it's in that case given subcutaneously, so it's not given intravenously, which are associated with other problems. So I think it has evolved, and in that case, especially in terms of drug reaction, it's an evolution. It's important.
Okay, and someone asked for a reference for the infection risk with low IgG in ocrelizumab.
I believe it is published. I know that particular slide I showed came from a poster that I presented at ECTRIMS, but I believe it is, I'll have to come up with it for you.
And here, you highlighted B-cell repletion on your slide. How important is the time to B-cell repletion or recovery of lymphocyte counts in clinical practice? How does it affect your choice of a therapy?
It really plays a role when you think about sequencing. So if, in fact, you're going to go from an anti-CD20 to another therapy, keeping in mind that these tend to be compounding risks as you go forward, you'd like to know when things are back to normal. Now, that doesn't necessarily depend on the number per se, because I already told you that the profile of these cells have changed afterwards. But if you're going to try to keep the slate clean and back to baseline, then it is important. It also is used to tailor the frequency of the treatments or infusions.
Would you recommend treating to repletion rather than just every 6 months? Like when B cells start to return?
Well, it's like I said, it's not so much the overall number. It may be, maybe it's better to look at the B cell memories because we don't know when they replete. And it's probably much longer than the period that I showed you for overall B cell repletion. And when you're measuring them intravascularly, keep in mind that the majority of your B cells are in your tissues. They're not floating around the blood.
Which answers a different one of the questions here. Is the profile of ofatumumab safer in terms of infection compared to ocrelizumab due to less IgG depletion over time?
That is certainly one of the suggestions, that you don't get those prolonged IgG suppressions with ofatumumab.
Here's a question. Where do repopulated B cells come from when treatment is withdrawn?
Where do they come from?
Yeah.
Where do they come from? Well, most of the B cells are probably in the tissues. They are generated from bone marrow and extra bone marrow sites but there's a continuous pool of B cells. You're not certainly eliminating by any means the body's B cell population. When you're measuring, you're only measuring what's still floating around the vasculature, which is 5 to 10% of your B cell population.
Okay, this may be something you just need to clarify. You mentioned likelihood of pregnancy as a factor for selecting particular therapies. Is B cell repletion an issue with this population?
Is B cell?
Repletion an issue with this population?
Well, no, I think
it's why it's important in pregnancy.
We've seen women who've taken the B cell therapy all through pregnancy, and even they've looked at the safety in the infant. Not to say that this is necessarily an endorsement that one can do this safely, but there haven't been any concerns in women who've taken it throughout pregnancy. And even the children, although there was a transient reduction in B cells in those infants born to the mothers on the drug, the B cells repleted very quickly. But there are women who absolutely do not want to be exposed to any external agent during their pregnancy. So one of the reasons to pick for this drug is because it probably has a prolonged effect, a durable effect, and maybe they don't need anything throughout the pregnancy.
And here's a critical question. Patients with depleted IgG levels, what do you do?
Yeah, well, if you want to persist with the anti-CD20s, and we've done that, this is really, in my practice, comes out in the primary progressive population because there are no other choices for therapy in that group. They tend to be older, and so they're more sensitive to the drug, and you end up with the hypogammaglobulinemias. Rather than sit there and watch time after time that the IgG is, substantially low, in our country we can give IVIG, and it doesn't cost anything because it's supported by the Blood Services Group. I know it's very expensive here in the U.S., but you can replete the IV, you can replete immunoglobulin by giving monthly infusions.
If they're having infections.
I don't wait for the infection. If they're older than 50 and they have 2 IgG levels that are significantly low after 2 infusions, so over the course of a year, we'll start monthly IVIG for them.
Define significantly low.
50% of the lower than the lower number. Yeah,
that's low. I think our practice, correct me if I'm wrong, Aaron, is if they're not having infections and they're in the 400 to 500 range, we watch them. If they are having infections and we have no choice, we treat them concurrently.
Yeah, I'd rather be proactive than reactive.
Okay. And just, Aaron, correct me, we've had a few of these neutropenics from our colleagues. Do you recall whether they stopped the medication or not?
Most of our patients have continued on drug. This is probably much more common because we don't do monthly CBCs on patients on B-cell.
Here's a microphone.
Yeah, we don't do
What I was
monthly.
going to say is, I think that the data that shows like roughly 14% you showed in one study, I think that's underestimates because we've seen patients who coincidentally have had CBCs drawn for some other reason and they turn out to be neutropenic. Most of them have no symptoms. Most are not getting febrile neutropenia, and they get better within a couple of weeks.
Yeah, that's what I thought.
Clearly need more studies in the long term with these patients.
Okay, I think we're good. Thank you very much. Next, we're going to hear from Dr. Clyde Markowitz from the University of Pennsylvania to discuss oral therapeutics for the treatment of patients with MS. Welcome, Clyde.
All right, I just want to say thank you to Fred for putting on this great course every year. This is our 10th year, which is truly amazing. And to academic CME, who do such a great job. All right, so let's see. I'm advancing this way, correct? Yes. All right, so I'm going to talk about the oral drugs that we still have, even though many of us have migrated over to the anti-CD20s because they're super effective. But I'm going to cover why you would even consider an oral drug at this point. And I'll talk a little bit about the mechanism of action of some of these drugs, maybe some of the efficacy and the long-term safety issues that come up with that, and then how and you might want to consider when to utilize these oral drugs. So many of our patients, You know, I mean, I don't want to forget about the history because we started out with injectable therapy back in the early 90s. And at that point, that's all we had. And it wasn't until 2010 that we ended up with our first oral. And now we have a ton of them. So they come in many different flavors, right? So you've got the S1Ps that I'll talk about. And we have 4 of those compounds. You've got teriflunomide, you've got 3 fumarates that are currently available, and you have orforglipron. So all of these are options for our patients with MS. And then ultimately you have to decide between you and the patient what makes the most sense. Because some people want the latest and greatest, and some people want something that's been out for a long time. So I'm going to start with the S1Ps. So mechanistically, this sphingosine-1 phosphate receptor, it is an agonist, so it binds to the receptor. And these receptors are on most of the tissues in your body. And on immune cells, the receptor gets internalized once the agonist binds and then is no longer present on the surface of the lymphocyte. And where this is particularly important is the migration of these lymphocytes out of the lymph nodes to go into the circulation. So if these receptors are not on the surface because they've been bound and internalized, they will not migrate out. All right, now, so when you look at somebody who's on this, or any of these S1Ps, you could ask the question, well, so then are they going to get lymphadenopathy? And that does not happen because the circulating number, percentage-wise, is just a couple of percentage points. So you don't get like overwhelming lymphadenopathy from a medication like this. In terms of how it works, so you're basically preventing these cells from migrating out into the periphery. The cell populations that are, we call them memory cells, don't seem to utilize the same mechanism, so they can kind of move in and out of the lymph nodes without that same requirement. But the drug does get into the CNS, and there may be some effects in the CNS, and we don't have great data in humans. You know, we take things like brain atrophy as a metric for something like that, but it's not clear at this point direct effects in the CNS in humans. All right, so there are 5 receptor subtypes for this sphingosine-1 phosphate. And at this point, 4 of them will be bound by fingolimod. That was the first one that became available in 2010. And based on, you know, that there's many actions that this drug has, both in lymphocytes, but in cardiac tissue and lung tissue, all over the body. And depending upon how much of a effect it has on those receptors and which one of these receptors is going to be affected will depend upon what kind of concerns there are for adverse events. So just to start with the clinical data from the original clinical trials, they did 2 phase 3 studies called the Freedom Studies, Freedom 1 and 2, and then they did a comparison study with interferon in the Transforms trial, and they showed about a 50% reduction across the board with all of these studies with regards to comparing to placebo or comparing to an interferon. So that was pretty good data, and the MRI data would be supported as well, somewhere in that 70 to 80% range in preventing new lesions, new T2 lesions, et cetera. So effective, it became the first approved oral drug. I don't know if I'm making so much extra noise with this microphone here, so you tell me. All right, but the issue then comes down to side effect profile and safety concerns. And so based on the fact that this drug binds to all these receptors throughout your body, you're going to have other issues, right? So the other issues might be cardiovascular. It can cause high blood pressure. It can cause slowing of the heart rate. And that was the biggest concern when we got this drug approved, that you had to do first dose monitoring in the office, 6 hours with blood pressure and pulse every hour. And you need to have EKGs before and after, and there are a whole group of patients who have contraindications for this based on other medications, beta blockers, a variety of other things. So very important that this was something that we had to deal with. Other issues included macular edema, and the macular edema was seen primarily in the first 3 to 6 months of starting the medication. Seemed to be increased risk with patients who have diabetes or a history of uveitis. some liver toxicity issues, infection issues. There were some cases of PML, cryptococcus, et cetera. Increased airway resistance for asthmatics. So these are all things you had to kind of analyze before you even considered putting a patient on this medication. A bunch of other things, in the cardiac contraindications. But with time, there was a question, can we make it more selective and get rid of some of these issues related to first dose monitoring and safety concerns? So they came up with more selective S1P binding, so that instead of binding to all the receptors, it bound primarily to the S1P1 and the S1P5. And so that includes siponimod, ozanimod, and ponesimod. And I'll briefly go through some of this. So siponimod did a very nice clinical trial looking at secondary progressive patients only. And these are people who had to have progression over a period of 6 months. They did 1,600 patients. They randomized 2-to-1. And what they did in the study, which was very clear that was beneficial, is that they did a dose titration. Because when they saw what happened with fingolimod's bradycardia was seen in the first 6 hours of administration. But if you did a dose escalation, you could mitigate that completely. So that's what they did over a period of about a week, going from 0.25 milligrams all the way up to 2 milligrams. And the data from the clinical study showed, clearly the same effects that you saw with the relapsing population in terms of new clinical attacks, new MRI lesions. So if you look at the second half and the secondary endpoints, they had very similar results, 50-some-odd% reduction in annualized relapse rate, 80-some-odd% reduction in the new lesions. So very similar. When they asked the question for EDSS progression in this study, because this was a secondary progressive group of patients, they saw a 21% reduction in disability progression compared to placebo. Now, the FDA looked at this and they said, well, I understand that you want to do this for secondary progressive patients, but the data was not as strong as everyone had hoped. And they did additional analysis to see if patients who were more active, who were having clinical relapses prior to entry into the study or MRI activity, they seemed to get the greater benefit. So the patients who were secondary progressive without active disease did not seem to be particularly affected here beneficially. So what they ended up approving this was for patients with active secondary progressive MS. Now, they did say that there was benefit with the prior relapses if there was DMT that they were naive to, so they hadn't been treated previously, if they were younger in age, lower EDSS scores, shorter disease duration. So this is kind of like how we think about the utilization of this drug. I mean, we don't really have a lot of great drugs for secondary progressive non-active. So every single drug that got approved after this time point, if there was active disease, would be active secondary progressive as well. All right, the only other thing I want to mention about this is that they found that because of the concern for the metabolism of this drug in the liver, if you had a genotype for the CYP3A4 genotype with certain genotypes, if you had that, you would be considered a slow metabolizer. And these slow metabolizers would then potentially increase the blood levels of the drug, and then you might get into more cardiac concerns. So we have to do genotyping of patients before you start this medication. All right, next up is ozanimod. So another second generation. This is also specific for the S1P1 and S1P5. It's also administered with one pill daily. This one has a little bit of a metabolite that when it breaks down, it actually will live in the blood for a longer period of time. So I'll show you this in another slide in terms of how it shows up for comparison-wise. But they showed very nice effects. They did the studies looking at a interferon weekly, 30 micrograms. And, the data was 50% reduction in clinical relapses. They had 63% reduction in MRI activity. So, I mean, pretty similar to what you saw with the other S1Ps. Did not require first dose monitoring because of the issue related to specificity. So overall, pretty good. Safety-wise, there was no major changes in this, although there were a couple of things that came up, which I still don't fully have wrap my arms around here, which is the issue related to certain foods that you eat. Tyramine-containing foods could be problematic. So, you know, I don't know how much cheese, aged cheese, or pickled herring that you might be consuming, but in certain cultures that could be a big deal. But in any event, you need to be aware that you have to reduce the quantity of this that you might be considering. All right. So fourth in the S1Ps is the ponesimod study. And for this one, they did a comparison against oral teriflunomide. And they showed, you know, 30% reduction across the board for relapse rate, as well as the disability did not meet statistical significance, although there was a trend toward it, working in comparison to teriflunomide. 56% reduction. And, you know, when I give you these numbers, you have to keep this in the context that this is a clinical trial that is, you know, evaluating patients at a point in time, and that this is against an active comparator compared to some of the original studies that were done without an active comparator and just placebo. So keep that in mind when you're thinking about this. So this one is only S1P1, not S1P5 as well. All right, so it has even more specificity to it. And just comparing them across the board here, you can see that doses are what they are. The half-lives are important here. So you look at siponimod and ponesimod, which has very short half-lives, and that could be important when you're thinking about a washout in somebody who wants to get pregnant or things like that, where fingolimod may have a washout of 1 to 2 months. Xanamod with its metabolites, you know, goes out to maybe 2 months as well, but much shorter for siponimod and ponesimod. So I know that that's been a question that many people have asked about for the pregnancy conversation, but you can pretty much stop these medications. They wash out fairly quickly. All right, so what did we learn? We did, you know, all these clinical trials. We have 4 different agents out there. We have more specificity to it. We think that the gradual titration of the medications makes the most sense for reducing some of the cardiac manifestations. Shorter half-lives is particularly useful when you're stopping the medication for whatever reason. There is something that came up particularly during the COVID pandemic, which was the concern for getting vaccinations to adequately respond. And so when we looked at the anti-CD20s, we saw that people were not generating a particularly robust immune response to the COVID vaccine. And we saw that also for the S1Ps, definitely with fingolimod, and there was some data to suggest that ozanimod might be a little better in that regard. But regardless, either way, it does have a concern for new vaccines. All right, teriflunomide. By the way, I didn't mention this, but I'll mention this now. So all the background pictures that you're seeing here are things that I've shot when I travel the world, and this is the Faroe Islands, by the way. It's a pretty cool place. All right, so teriflunomide is going to be the next one to discuss. So that was tested in 7 milligrams and 14 milligrams. It's currently approved since 2012. It is a metabolite of leflunomide, which has been used for years for the treatment of rheumatoid arthritis. Pretty well tolerated for the most part. And now we have generics available for this particular compound, so you can get it fairly inexpensively for your patients, which is wonderful. And if you go to Mark Cuban's pharmacy, you can get it dirt cheap. How does it work? So this drug works primarily by reducing activity of activated and rapidly dividing cells. So, you know, this is why some of the adverse events you see with some of this medication, but it does not deplete cells. It is not a cell depleter like the B cell depleters or even cladribine or things like that. The clinical trials looked very nice. You had a 30% reduction in relapse rate. You had 69, 70% reduction in MRI activity. They did 2 trials. So, you know, it came in numerically like it was going to be similar to what we had when we looked at interferon therapies, but maybe not as robust when we thought about it compared to some of the other agents like the other orals, or even now, you know, Tysabri was out at the time. So a good option for somebody who wanted a pill that did not have all the cardiac concerns or some of the safety concerns with the S1Ps. But this one has some side effect issues, so GI-wise, nausea, maybe some diarrhea, and that may be in part because of the rapidly dividing cells of the gut. Alopecia, which was somewhat transient, seemed to be worse over the first couple of months and then stabilized, and then people were back on their normal hair shedding. Hepatotoxicity, this was an issue with the first several months of starting the medication. There would be elevated liver enzymes, so we'd have to do monthly LFTs, although convincing my patients to come and get that consistently has been a challenge. The pregnancy concerns, there was teratogenicity in animal models. There's slow clearance out of the body, so when somebody wants to get pregnant with this medication, you can either go get it by giving them activated charcoal. Cholestyramine is another choice, and you can wash it out of their system over a period of about almost 2 weeks, and that seems to be good enough to get them drug levels at a low enough level to consider doing pregnancy. All right, you have to screen for TB because from leflunomide data, there was some concern that it increased the risk for that. So the pros, moderate effectiveness, once a day oral medication. They did have nice benefits with 2 clinical trials showing effects on disability progression and a good safety record from leflunomide as well. But the other side is some of the pregnancy issues, mild hair loss, liver monitoring, and it's only moderately effective. Fumarates, also the Faroe Islands. All right, so how did the fumarates work? Now we have 3 of them, dimethyl, diroximel fumarate, and monomethyl fumarate. So in terms of how it works exactly, we don't really know. What we do know is that there's an aspect of this that when you give the medication, keep is a protein in there attached to this NRF2, and it dissociates and it can migrate into the nucleus and then cause a variety of different effects, some of which will be antioxidants, cytokine issues, you know, things that will modulate immune responses. The data from the clinical trials showed good effect on relapse rate reduction, and this was done in 2 clinical trials, 240 milligrams twice a day pills, so it's 1 capsule twice a day. They did the define versus placebo. They did a confirmed study, which was also against placebo, but they also put an arm in there against glatiramer acetate. And it showed roughly about a 50% reduction in relapse rate. They showed 85% reduction in new lesions on MRI scan. So pretty impressive data. Did have some side effect issues and safety concerns that came up, the main ones being GI related, caused a little abdominal discomfort, maybe some diarrhea, nausea, flushing. People would get quite red, just come whenever. And so during the initial time period, it was learned that if patients took the medication with food, that mitigated some of the GI side effects. It didn't affect the flushing. Lymphopenia was seen in a small percent, but there was a concern when they saw some cases of PML that there could be a marker of low lymphocytes that were persisting as low lymphocytes that might increase the risk for developing PML. So in the infinite wisdom of these pharmaceutical companies, they saw that the GI side effect issue was significant, so they went down the pathway of trying to come up with an alternative. Diroximel fumarate is just slightly modified and thereby did not cause as much of the GI side effects that you had seen with the others, but this one is administered in 4 capsules, so it's 2 capsules twice a day, and they can dose escalate up on that. It seems to help a little bit. But they were able, the FDA did not make them do another clinical trial with the medication because both dimethyl fumarate and diroximel fumarate get converted to monomethyl fumarate, and monomethyl fumarate is the active ingredient. So because of that, they said, well, we're not going to make you do another clinical trial for efficacy, but you need to do something on the safety and tolerability. So they did that, and it looked like it had less GI side effects, so people were happy about that, and we got that approved. Monomethyl fumarate, now this is not requiring any sort of conversion. This is now the active ingredient. Seems also became available around 2020 or 2019. The drug worked, they used the same data from the original clinical trials with dimethyl fumarate. They didn't have to do any additional studies, but showed, again, some tolerability, and it did not seem to have any of the issues that diroximel and dimethyl fumarate had in terms of alcohol consumption issues. When you take dimethyl fumarate, you take it with food. Diroximel fumarate, you take it without food. And you shouldn't be drinking alcohol to swallow these capsules, even though I don't think people think that way, but what do I know? But it didn't seem to have any issues in terms of using it, no alcohol or food restrictions for how you take the medication. They all have the same kind of side effect issues and the same issues related to risk for PML, et cetera. All right, I'm going to move. This is Iceland, by the way. I'm going to move to oral cladribine. And this will be the last of the oral medications I'm going to discuss. So mechanistically, it's a synthetic purine analog. And this, for some reason, lymphocytes have ratios of different enzymes in them. And when this drug gets into the lymphocytes, it is a DNA blocker, so to speak. It's going to create a situation where that cell will undergo apoptosis. And lymphocytes seem to be the prominent cell types that this drug works at. In any event, it seems to have a prolonged effect on T lymphocytes and transient effect on B lymphocytes, but it is dosed very conveniently. So they did the clinical trials, 3.5 milligrams. They also did a higher dose, but the 3.5 looked good and had, a fairly decent side effect profile. But the way you give it is you take 5 consecutive days of the medication. A month later, you take another 5 days. A year later, you repeat that cycle, and that's all you take. And they monitor these people for years afterwards, and it was pretty effective in terms of reducing activity, 57% reduction in annualized relapse rate compared to placebo. Good percent were relapse-free, 33% reduction in 3-month confirmed disability progression, and 87% reduction in GAD lesions. And this is just some of the graphs showing the annualized relapse rate, time to first relapse, as well as cumulative relapses and time to disability progression. So very good data. Safety-wise, lymphopenia was the significant issue that has to be monitored, although you see it drop quite significantly and then it starts to come back up by 6 months. Maybe there was an increased risk of infections, zoster, et cetera, but during the initial clinical trials, this compound showed a couple of malignancies in different, like with Ocrevus, we saw that maybe there was a high risk for, not high risk, but a higher risk of patients developing breast cancer, but it was like one part of the body, where this did not seem to have a predilection for any particular part of the body. There was some ovarian, there was other issues as well. And so when the company went to the FDA initially to get this approved prior to fingolimod's approval, the FDA said, we're going to have to do more studies. And at the time, there were a variety of issues that were going on at the company. And they said, we're not doing any more studies. And then they changed their CEO. They got a new CEO. And they said, what are we doing here? We got a great drug. So they went back to the FDA. They monitored patients who were in the original study. They did not see any additional concerns. So they put a black box warning of malignancies on the label. And the way it states now is that it is contraindicated in a patient who has a history of malignancies. That doesn't mean you can't use it just because of that. It's just that it's not recommended. It got approved for both the relapsing and for active secondary progressive. Oh, let me just go back one second. The last thing I want to say about that was that the label states that it is generally recommended for patients who've already had an inadequate response to or unable to tolerate an alternative MS therapy. So almost like a second-line therapy. But I will tell you that in our world, we use it as first-line therapy. It's a very good drug. It's very convenient for our patients who don't want to have to take medications on an ongoing basis. You just do a couple cycles of it and you're done. And you'll probably hear throughout the rest of the day that there is good data to suggest that you're altering immune function for much longer periods of time with some of these medications, particularly with the B-cell depleters and oral cladribine. So we put this in the category of a high-efficacy compound, and that gives you long-term benefit. So just in terms of how to finish up here, always consider the patients. Now, one of the things for any of us in the audience here has to think about, well, you heard from Mark on the B-cell depleting therapy, and, different practices will think differently about things. My personal opinion is I usually like to start with a high-efficacy compound for every patient. I don't necessarily make a distinguishing piece called this is somebody who's very active versus somebody who just had an optic neuritis. My opinion is I want to treat this aggressively from the beginning. Tell me why I can't use a high-efficacy compound for this patient. And they may have their own concerns. Maybe they are thinking about getting pregnant tomorrow. Maybe they're thinking about some of the side effect issues or work issues or issues that relate to why they would want to choose one over another. So it becomes a dialogue. Address any of the modifiable risk factors in terms of making sure that you look at an individual patient and you do everything in your power to be able to say, this is the best strategy going forward, which is medications, lifestyle changes, etc. Make sure they continue with the regimen. So the problem with the pills in general is that you're taking them either once or twice a day, and that can be quite significant, right? Because we know that adherence to some of these medications can be problematic. Doing an infusion every 6 months is much easier for most people. Doing oral cladribine would be very easy for many people. Make sure they buy into it, they understand the risks, we monitor them closely, and then always make adjustments as needed. All right, so that's all I'm going to say. This was also at the Faroe Islands, so I'm happy to conclude. Thank you. Did you want me up or?
Thank you, Clyde. Next, we'll again hear from the University of Pennsylvania, Professor Amit Paror, who's going to discuss with us BTK.
Hello, everyone. Thank you, Fred. Thanks for the academic CME for the invite. It's great to be here again. So we'll talk about BTK inhibition in multiple sclerosis. These are my disclosures. And what I thought I would do is start off just with an overview of a bit of the conceptual framework for why we might want to be thinking of BTK inhibition and the potential place for these agents in MS, including BTK as a target of inhibition, both in the periphery, and you've heard about peripheral immune system responses that are thought to drive relapse biology, but also potentially within the CNS as part of targeting CNS compartmentalized inflammation that we believe is an important contributor, if not driver, of non-relapsing progressive disease. And then we'll segue into an overview, a partial overview of the clinical trial programs. And there's been a fair bit of information in the last year, certainly even in the last 6 months, that has taught us, I think, some important things about the prospects of BTK inhibition in MS, whether in relapsing or progressive aspects of the disease, but also has raised some interesting and important questions for us to resolve moving forward. So we'll start with this conceptual framework, and here's a typical simplified model of the cellular immunology or neuroimmunology of MS. We have the 3 compartments. We have immune cells that are activated. They upregulate molecules that make them more efficiently able to traffic across barriers, including the blood-brain barriers. They're thought to be reactivated in the CNS and then bring to bear on the elements of the central nervous system. And as you heard, we've really evolved in our thoughts of MS being driven immunologically by T cells to them really being interactions between T cells, B cells, and myeloid cells, and that these interactions in the periphery are thought to underlie relapse biology, and that some peripheral cells that compartmentalize within the CNS, as well as cells of the central nervous system, propagate inflammatory disease. And you've heard about the contribution, we think, of chronic active lesions as one aspect of relapsing progressive disease, the paramagnetic rim lesions and slowly expanding lesions, which is another way of capturing, we think, some of these chronic active lesions, as well as the other aspect within the CNS that involves immune cell aggregates within the meninges and the subependyma, and these are thought to be relevant perhaps for the subpial cortical injury, as well as the deep gray injury involving thalami, caudates, etc., again, as pathologic substrates of non-relapsing progressive disease. And so the question for us here is going to be, what about BTK inhibition or BTKI in the context of both of these anatomic sites? So let's talk about BTK as a target. First of all, just a very brief word about protein kinase biology in general. In humans, there are over 500, about 540 protein kinases that are broken down roughly into 30 families. Of those, 90 of these belong to the tyrosine, the protein tyrosine kinases, BTK being one of them, and we'll talk a little bit more about the BTK in particular. But in general, these are enzymes. They catalyze phosphorylation of proteins and alter the activity of the proteins. And this is just a little cartoon showing an energy-dependent process of a protein becoming phosphorylated through the action of a protein kinase, and that this is an important aspect of signal transduction in many, many cells of the body, and in fact is probably the most common reversible post-translational modifier of cell function. So after gene expression, transcription, and translation, those proteins can have very different functions depending on these post-translational modifications, and protein kinase biology is an important contributor to that. The Bruton tyrosine kinase as a family and as a target, first recognized by a pediatrician, Dr. Ogden Bruton, who identified mutations in the BTK in children with XLA, which is X-linked hypo or A-gamma globulinemia. And the BTK was then recognized as an important downstream element of B-cell receptor signaling. And in the context of cancer, it was identified that BTK activity is important for cancer survival and growth. And the first BTK inhibitor, BTKI ibrutinib, was approved in 2013 for mantle cell lymphoma. It was associated with a good treatment effect and an adjunct for chemotherapies in patients with a variety of lymphomas used today in the clinic, but had a range of off-target effects. And the second and third generation iterations, if you like, of BTKIs have made them increasingly more selective and subsequently associated with a lesser profile of adverse events. In parallel to this, there was also the appreciation that BTK may be involved in aspects of immune regulation, particularly tolerance of B cells, which was studied initially, and has hence been applied for therapeutic programs in several autoimmune diseases, principally lupus and multiple sclerosis. And it's involved, the protein BTK is involved in signaling in both adaptive and innate cells of the immune system, shown here. The ones that are thought to be most relevant as targets in MS are, again, the B cells and the myeloid cells, which include peripheral cells such as monocyte, macrophage, and dendritic cells, but also CNS-resident myeloid cells, the microglia. And at the bottom, you can see for each of them the multiple functions that the BTK can contribute to in terms of activation of these different types of cells. On the B cell side, antibody production, but also pro-inflammatory cytokine production, antigen presentation capacity that you heard from Mark and others are important, we think, in MS. And on the myeloid cell side, also BTK involved in a variety of pro-inflammatory myeloid cell responses. Hence the rationale for inhibiting these, as these have been implicated in various aspects of MS. And so I won't belabor, and there's a lot of literature now on the potential roles of BTK inhibition in the periphery in the context of MS-relevant immune responses. This is initial elegant work by Martin Weber's group looking within the commonly used animal model of multiple sclerosis, EAE, at the potential for BTK inhibition to impact the immune cell responses relevant for peripheral immune cell activation and trafficking, could show very nicely in vivo that BTK inhibition particularly impacted and limited B-cell, T-cell interactions. And our group was able, just as an example, to follow on that in the context of patients with MS and MS patient samples, showing again the capacity of BTK inhibition of certain BTKIs, in vitro at least, to limit the B-cell, T-cell interactions. So that has to do with the potential role of BTK inhibition and targeting in the periphery. What about the CNS, which I think is a particularly exciting prospect for BTK inhibition? So here again, we're looking at these two different aspects that we think contribute to non-relapsing progressive disease, the chronic active lesions as well as these areas of the subpial cortex and deep gray. And one common feature to those different areas of involvement is the presence of microglia that appear to be there in a chronically activated state. So microglia are viewed as a potentially important target of therapy for non-relapsing progressive MS, and I'll spend a couple of minutes just talking about them briefly as a very interesting target. It's not a simple target. Microglia are very dynamic cells. They are very relevant for a variety of homeostatic functions. Shown here, they promote CNS health. They promote normal phagocytosis of cleaning up debris. They're involved in synaptic integrity and plasticity, and also in very interesting aspects of myelinating cell biology and myelin integrity. And they are able to respond in ways that have an appropriate and desired pro-inflammatory response to acute insults, but then they typically revert back to the homeostatic state. It's when they are chronically activated that they are thought to then adopt what has been described as a disease-associated phenotype. And this is not unique to MS. It's been described in Alzheimer's and a variety of other conditions where there's chronic ongoing injury. And these chronically activated microglia appear to be not just responding to, but very likely participating in propagating this kind of injury. And relevant, perhaps, in the context of MS in particular, is their capacity to produce these pro-inflammatory cytokines, to contribute to injurious molecules, and propagate both inflammation, degeneration, and overall injury. And then, of course, to implicate BTK in the context of microglia are very nice pathologic studies that identify, as an example on the left, the very sharply demarcated rims of demyelinated lesions that in those rims have activated myeloid cells, likely microglia, and you can stain for BTK present within those cells, and those are the same cells also that seem to accumulate iron that may contribute to the paramagnetic rim lesions, as Danny Reich and Martina Absinta have elegantly demonstrated with nice imaging pathologic correlation. And both at the RNA and the protein level, one can identify elevated levels of BTK in MS versus healthy controls, and perhaps particularly in those with clinically evident progression of disability. So what is the evidence that BTK inhibition may modulate microglial responses in a potentially useful way? Well, in vitro, it's very simple to add BTK inhibitors as you're activating microglia. And in this example, you can see at the level of RNA expression, some entities going down, some entities going up. And it's interesting to note here that those that are diminished in terms of expression levels tend to be more on the pro-inflammatory side, whereas at the same time, there may be an increase in some molecules that are associated with the homeostatic properties, potentially reparative properties of microglia. So at least in this in vitro experiment, BTK inhibition would seem to be modulating microglial cell responses in a good direction as far as the context of MS is concerned. And fast forwarding to some of the more recent, really elegant demonstration again of microglia using a variety of both in vitro and embellished multi-cell in vitro and organoid type assays, as well as in vivo in animals. On the left for tolobrutinib, on the right for fenebrutinib, two BTKIs that are recognized now as CNS penetrant, that they have the capacity to change the profile of microglial responses in vitro and in vivo, and again, in a direction that seems to be moving away from the disease-associated microglia profiles to ones that may be more homeostatic. And here more work by Martin Reber suggesting that there may in fact be some role of BTK inhibition in repair, and this is to be seen, but is a potentially very interesting prospect, whether limiting the injury allows for some endogenous repair or whether BTK inhibition somehow actively contributes to repair is an ongoing question of interest. So we'll segue now to BTK clinical trials. And I'm not going to do justice to everything that has been presented. I'll try to highlight at least those things that I think are relevant and weave together a little bit of a story in terms of our evolving understanding of the potential role for BTK inhibition in the spectrum of multiple sclerosis. So the first large phase 3 clinical trial program was published with Xavier Montalban as the lead author, with evobrutinib in Evolution 1 and Evolution 2 relapsing MS clinical trials. And I'm sure all of you are familiar with this being a rather negative study. This was an active comparator against teriflunomide, 2 very similarly designed large studies, each with over 1,000 individuals, randomized 1-to-1, and really no difference in the primary outcome measure of annualized relapse rates. Also, no difference in terms of outcome measures of confirmed disability progression, whether you look at trajectories of 12-week confirmed or 24-week confirmed disability progression. And when you looked at some of the secondary outcome measures, and this is probably a little small to see, I'll try to highlight the important parts as we go through, looking at the number of gadolinium-enhancing lesions, there's actually nominally an increase in the evobrutinib, or at least higher numbers nominally in the evobrutinib arm as compared to the teriflunomide arm in both of these studies. So an unexpected, modest to maybe even some paradoxical effect. We don't know what would happen in this trial with placebo and whether evobrutinib is just not quite as good as teriflunomide, but we think of teriflunomide overall as relatively modestly effective against relapse biology, and this was a disappointment in terms of the prospect of BTK inhibition in relapsing disease activity. This is the phase 2 study of tolebrutinib led by Danny Reich, and this was a study that basically suggested that at the higher dose of tolebrutinib, as shown here on the far right, there is a decrease in the primary outcome measure of this phase 2 trial, which is the development again of these new focal inflammatory lesions, and this indeed the 60 milligram dose carried forward into the phase 3 trials. But I want to pause or take a brief sidestep and talk about the data that supports the potential CNS penetrance of tolebrutinib, because this is probably important. And what you see here are levels measured in the plasma as total tolebrutinib concentrations, as well as plasma-free tolebrutinib, and CSF as a one-time assessment in these individuals. And what you can see in red is that there is a concentration of tolebrutinib detected within the CSF, and it lies somewhere between the plasma total and plasma free levels of tolebrutinib. And in vitro experiments where you can assess the ability of binding or the ability to functionally affect cells based on the binding of a BTK inhibitor to the BTK, here the IC90 was exceeded in terms of this particular level of tolebrutinib within the CSF, at least consistent with the prospect of it having biological effects. I think very elegantly demonstrated in Danny Reich's Break-MS study, which I like very much, is looking at the impact of tolebrutinib in a cohort of individuals who had been on anti-CD20. And this prospect of seeing NFL elevations in that context as maybe informing on injury from non-relapsing progressive disease is one that's applied here as well. What you see on the left are 2 large cohorts, each individual is a dot, of untreated MS patients, obviously NFL levels elevated as compared to healthy volunteers on the far left of the diagram. And then you can see a small number of individuals on anti-CD20 whose NFL levels in the same assay are lower than in the untreated patients, not surprisingly, but after 48 weeks of BTK inhibition, this was tolebrutinib, you can see a further decrease in the NFL levels. So this appears to be reflecting tolebrutinib having an effect of limiting abnormal elevation of NFL above and beyond whatever the ongoing pharmacodynamic effect of anti-CD20 may be. So exciting in that regard. And this sets the stage for the results that were presented recently at ECTRIMS. Bob Fox led this in terms of the tolebrutinib phase 3 clinical trial program in non-relapsing progressive MS, the Hercules trial. The Hercules trial study design was that of a multi-center randomized, double-blind, placebo-controlled, event-driven trial. It was a 2-to-1 randomization. I won't go through all of the eligibility criteria, but just to say that the diagnosis needed to be of individuals who had secondary progressive MS in terms of the clinical phenotype with absence of relapsing disease activity clinically for at least 24 months, and documented evidence of disability progression in the last year in spite of not having clinical relapses, obviously contributing to that phenotype. The baseline characteristics, again, a busy slide, but I'll just highlight that overall the characteristics between these two groups were well balanced, that about 50% of individuals were above the age of 50, about 60% had an EDSS above 5.5, 17 years from symptom onset on average, and 7 years on average from the last clinical relapse. So pretty good non-relapsing secondary progressive population with a relatively small number of gadolinium-enhancing lesions at baseline, present in 12 to 13% of individuals. The primary endpoint, time to 6-month confirmed disability progression, was hit positively with a nice p-value with a 30+% reduction in the time to 6-month confirmed disability progression. This was reinforced with a 3-month confirmed disability progression. Expectedly, the percentages are higher. It's harder to specifically comment about this as non-relapsing progressive disease, but nice to hit this as well. And interestingly, and still again to be confirmed in terms of what it may mean, the time to 6-month confirmed disability improvement was also favoring tolebrutinib versus the placebo in this trial. Interestingly, and having scratch our heads a little bit and perhaps revisiting what we think atrophy can tell us as a measure of non-relapsing progressive disease or predictor thereof, there was no impact, no significant separation of the curves when one looked at brain volume loss with tolebrutinib versus the placebo. From a safety standpoint in Hercules, the overall preliminary analysis does identify some increases in adverse events, including respiratory infections. No major surprises otherwise, and more analyses are being done. But the one that comes out and really was a recognized potential risk even from the earlier evobrutinib trials is this liver signal. And you can see that in terms of elevations of ALT above 3 times the upper limit normal, or increasingly higher levels of abnormality, that tolebrutinib had a higher proportion of individuals with those types of outcomes. The more important ones perhaps are the ones on the right, where you get a greater than 20% increase from upper limit normal, or a greater than 3 times increase in the ALT, but also an increase in bilirubin. And that combination is recognized in the liver world as one that purports potential risk for severe liver injury, drug-induced liver injury, or DILI. So it was a small proportion, but an important proportion that experienced this particularly high risk. The good news is that this seems to happen, if it's going to happen, only within the first 90 days. And as this was being recognized, there was increased frequency of monitoring, which was able to mitigate that risk. Most resolved, but not all resolved without sequela. So an important adverse event that we will need to contend with in terms of hopefully getting people on this therapy once we expect it will be approved. What about the relapsing remitting program of tolebrutinib? Well, this is the Gemini 1 and Gemini 2 study design. Again, 2 very large, very similarly designed studies that are a typical parallel arm, 1-to-1 randomization. I'll just make the point here that for this population and looking at relapsing MS, there was the usual effort of trying to include in the inclusion-exclusion criteria those who are likely to have some ongoing relapsing disease activity so that they may be informative in the clinical trial. And of course, individuals with either secondary progressive or primary progressive disease were excluded if they were non-relapsing. The baseline characteristic, another busy slide, but I'll highlight first that the baseline characteristics are generally very well balanced between the treatment arms and between the trials. Essentially, all of the individuals in these 2 studies had what we would call relapsing remitting MS. The EDSS on average was on the low side, less than 2.5, and there was approximately 1 relapse in the prior year on average. A third of individuals here had GAD lesions at baseline, and 2/3 of them were treatment naive. So those were the baseline characteristics, a decent population with what everyone would agree is a relapsing remitting MS population. This, too, was a negative study with respect to the primary outcome. So you're seeing Gemini 1 and Gemini 2, and then on the right, the pooled analysis with the primary outcome of annualized relapse rate, and really no difference between the tolebrutinib here, and this is the active comparator, of course, of teriflunomide. So no difference was seen, although one notes that the annualized relapse rate was very low in general. And sometimes when something is very low, it's a little bit more difficult, if not very difficult, to show further lowering of that. Nonetheless, a clearly negative trial in the primary outcome. And then when you look at measures of focal inflammatory activity by MRI, which we take again to represent consequences or manifestations of relapse biology, you can see here on the right that there's no particular difference, or at least not a statistical difference, between tolebrutinib and teriflunomide with respect to new enlarging T2 lesions, but there are statistically significant higher levels of new GAD lesions developing in the tolebrutinib arms compared to the teriflunomide arms in both the Gemini 1 and Gemini 2 studies. So this just essentially repeats what I had said. In spite of that, in spite of not having an effect on annualized relapse rate, and in spite of clearly not having a beneficial effect in terms of new focal lesions that are an aspect of relapsing disease, there was nonetheless a statistically significant reduction. Of course, this is not the key primary outcome, but nonetheless a key secondary endpoint, an almost 30% reduction in the time to 6-month confirmed disability worsening of tolebrutinib versus teriflunomide. So this sort of reinforces the insights from the Hercules trial that suggests that in individuals who have very little in the way of relapsed disease activity, with a drug that does not seem to have much an effect of relapsing disease activity, you're impacting across these populations progression of disability, which likely reflects, is more likely to reflect, if not all of it, progression of disability that is not driven by relapse biology, or at least to a rather little extent. The pooled safety here, generally balanced. There was a death that was assessed by the investigator to be related to the tolebrutinib, a single one in the tolebrutinib arm that had to do with post-operative complications of liver transplant. There were 2 deaths in the teriflunomide. Again, this was a 1-to-2 randomization. So no difference in the numbers, but just pointing out that particular one, people are often interested. Reiteration of the liver safety here, perhaps because it's a younger population. At the lower levels of increase, there were no differences between the tolebrutinib and the teriflunomide. But again, on the right-hand side, you've got this small 0.5% of individuals in the tolebrutinib group who experienced particularly high elevations of ALT or the combined elevation of ALT and bilirubin. All cases of ALTs above 3 times upper limit normal resolved without further sequela in Gemini. So this brings us to a point where we sort of wonder about revisiting the conceptual prospects of applying BTK inhibition in MS, and with relatively modest effects, but in the face of those modest effects on relapse biology, there appears to be a potentially quite important effect on non-relapsing progressive disease. Whether this is going to be true for all of the BTK inhibitors is an interesting question, and here I want to present data that I had the privilege of presenting at ECTRIMS on behalf of the authors listed here for the phase 2 study. So this is not yet a phase 3 study, it's just a phase 2 study, but of fenebrutinib with its open label extension that suggests that there's a rapid and sustained effect on limiting focal inflammatory disease activity in addition to CSF penetration. So the study design, again, a fairly typical parallel arm study, a relatively short 12-week period that's double-blind with fenebrutinib at 200 milligrams BID compared to placebo. And what you can see here in terms of inclusion criteria, again, an effort to concentrate people who are likely to have relapsing disease biology as part of their entry. And MRIs were done where you can see those sort of reddish or orangish triangles, depending on how it's shown there on the screens, but 2 time points of CSF on a subset of patients prior to or just before initiation and 12 weeks later. So we'll talk about initially baseline demographics, which again were very well balanced between the arms, except for prior DMT use, which did seem to be more common by chance in the placebo arm as compared to the fenebrutinib. And 100% of eligible patients did transition to the open label extension. So nice retention in this study for the duration of 48 weeks, almost 1 year. The primary outcome of this phase 2 trial was met, and what you can see, the blue trajectory represents those who started on fenebrutinib through the double-blind treatment period and then onto the extension. You can see decreases that are pretty rapid and appear to be sustained through to week 48. Those who started with a 12-week placebo and transitioned to fenebrutinib, first you see there what would be expected as a regression to the mean in the placebo arm, and then a further decrease after the initiation of fenebrutinib to very, very low levels. So the question that is raised here at this point is whether this is going to be any different when one sees phase 3 trial data, so we're certainly anticipating that, but there's kind of convergence of this impact and sustained impact on other measures of focal inflammatory disease, including T2 lesion volume, which appears initially perhaps to increase in the placebo group, but not in the fenebrutinib group, and then decreases further in both groups, especially as you go on the fenebrutinib. And the annualized rate of T2 lesions all the way through again to week 48 is decreased and maintained there at very, very low levels. With respect to the CSF penetration, here's another example of how one might assess the potential biological relevance. So in 11 individuals, one was also able to obtain CSF in the Phenopta trial. You can see the range of concentrations identified there. And one of the ways to ask, as I alluded to, about whether these concentrations may be relevant is to take the CSF or to add at the same concentrations as seen in the CSF to various culture systems of cells of potential interest. And these may include B cells, they may include myeloid cells, microglial cell lines, to activate those cells and to see whether when you add this concentration of the BTK inhibitor, you decrease the capacity of these cells to activate, and you can assess the range of effects, and you can talk about the ability to decrease by 50%, so that's the IC, the inhibitory concentration 50, or the IC 90. This is showing that all of these individuals ended up having CSF levels of fenebrutinib, which exceeded the inhibitory concentration, the 50% inhibitory concentration, or IC50, whether you're looking at the occupancy of the BTK, which is one natural question to ask, but also the ability of the BTK to inhibit the activation marker of CD69 on B cells and CD63 on the myeloid cell line. And in fact, the average of the CSF concentration in this cohort was essentially at the IC90. So these are concentrations that plausibly are going to be biologically relevant. From a safety perspective, with fenebrutinib in this short trial, essentially all AEs were grade 1 or 2, one grade 3 liver transaminase. So again, whether it was asymptomatic, but nonetheless, this is looking like it's likely to be a class effect. It raises questions as to whether there may be differences between BTK inhibitors, and time will tell. But some of the possible explanations for differences, if they indeed exist, could be some features of these molecules listed on the left, particularly the potential of different types of binding, where, for instance, tolebrutinib and evobrutinib are irreversible covalent binders of the inhibitor to the BTK, whereas the fenebrutinib is a reversible non-covalent. The significance of this, not clear at this point. One can talk about IC50s again and compare across. CSF exposure, which, as I'd mentioned, is relevant for tolebrutinib and fenebrutinib, but not for evobrutinib. And you may know that evobrutinib is not continuing being pushed through paces anymore in multiple sclerosis. So whether what I've showed you in terms of the clinical trial results of these three different agents teaches us something about the overall capacity of BTKs to inhibit relapse biology, progressive biology. Whether there are going to be differences between the agents, we don't know. This is a near final slide, just identifying the ongoing clinical trials of BTK inhibitors in the spectrum of multiple sclerosis. And ones I think that are going to be most interesting to look for in terms of results are going to be the Perseus study with tolebrutinib in primary progressive MS. So we'll see if the positive study in the Hercules trial with non-relapsing progressive MS is replicated or reinforced by an impact in primary progressive disease. Most people nowadays think that the underlying biology of non-relapsing progressive disease, secondary progressive disease, and of primary progressive disease are essentially the same biologies. They're present throughout a broad range of the MS spectrum, not only when patients reveal clinically the progression of disability that's independent of relapses. The other study, very interesting, is Fentrepid with fenebrutinib, where rather bravely they're pitting fenebrutinib against ocrelizumab in a primary progressive MS population. So very, very interesting to see what happens there. So I'm going to finish by summarizing some main takeaways. One is that BTK inhibition we still think is an attractive target in MS. It has potential effects both in the periphery and the CNS. The most exciting may be those in the CNS. And at least the trial findings to date suggest a rather modest effect through the phase 3 for evobrutinib and tolebrutinib. Too early to say about fenebrutinib on the peripheral effects underlying relapse biology. And there may be reasons, and we'll see if there's an explanation for this, if reinforced. The tolebrutinib data do point, I think, quite compellingly to the capacity of a CNS penetrant BTK inhibitor to limit progressive MS biology, even if the effect is limited on relapsing disease. And again, generally well tolerated, overall quite safe, although this liver enzyme elevation signal, though infrequent, is possibly serious and almost certainly is going to require frequent liver monitoring in the first 90 days. Whether this is a class effect or not, probably, we'll see. Some of the questions I think we may discuss: Phenopta and the relapse biology, what will happen there, Perseus and Fentrepid. The potential in repair, we'll see, and then also some teachings about revisiting things that we thought we knew, such as the utility of atrophy in predicting outcomes of clinical trials in MS, particularly of progressive disease, non-relapsing progressive disease outcomes. And I'll stop here, and thank you all for the attention.
Thank you, Amit. So our next two talks are from colleagues of mine at Mount Sinai. The first will be Stephen Krieger doing a review of overall treatment strategy with the current agents. Welcome, Stephen.
Thank you. All right, everyone. I could ask everyone to stand up and do jumping jacks and stuff, but I won't. Instead, I'm going to keep my talk short. There will be very little data and no cellular mechanisms whatsoever. This is an entirely clinical talk, and it's really meant to embody how we think clinically, so for our residents and our fellows and those in clinical practice, to try to take the way we make our decisions, the way we take all the information you've heard so far, and apply that information when you're faced with the patient. I think there's an art to it, and no one right way to do it, but I'll take you through how I think about these things. So to begin, I said there's very little data, but here's a little bit. To begin, we spend so much of our time and effort talking with our patients about disease-modifying therapies who principally prevent relapses and new lesions. And if the entire goal was just to minimize how often one of our patients had to get days of steroids and then get back to baseline, it really wouldn't be so worthwhile. It's not really the reason why we're doing what we're doing. So I put up this slide from 15 years ago from Scalafari and colleagues that looked at what happens to people with MS over the years, depending on how many relapses they had early. And this just says something we all know. People who have more relapses don't do as well. But I want to call your attention to a detail, because I think that there's something actually provocative and interesting hiding on this slide. So what this is looking at is what percentage of patients needed a cane, and when did they need that cane? 10 years, 20 years, 30 years on. And these are based on whether the patient had 1, 2, or 3 or more relapses in the first 2 years. So what you see is virtually none of those patients needed that cane in those first 2 years. Those relapses did not cause that disability early on. Those relapses caused that disability much later. That is to say, the number of relapses they had early on prefigured disability that was still a decade or two down the road. I think that's actually really interesting. And it's part of what informed my swimming pool model that Dr. Loveland put up briefly earlier. This idea that I think what progression really is a gradual unmasking of deficits, an unmasking of deficits from those lesions that are hiding under the surface, those lesions that were accumulated early when patients had their relapses. And so preventing those relapses, keeping what I call the disease topography as flat as possible, helps to minimize the likelihood that there'll be that damage to be revealed later when reserve is lost. That's my sort of provocative proposal. But it tells us a little bit about why we're doing what we're doing. How do we know that that works? I have just a couple slides here just to tell the story. I think you know all of this, that using high-efficacy therapies earlier on changes the long-term trajectory of the disease and the likelihood of progression. So if we prevent all of those relapses and lesions, we alter the likelihood of disability years later. And this was that study from the Danish and Swedish registries. So in those two countries, the populations are somewhat homogeneous compared to here. The health system is somewhat homogeneous compared to here. They have national registries of data, which we don't have in an effective way here. And so they could compare how did the folks in Sweden versus how did the folks in Denmark do with MS, noting that in Sweden, they typically use primary, highly effective therapy early, and in Denmark, they escalate to it. And the results here show if you're going to have MS, it's better to be born in Sweden. And we can take that information home with us and think to ourselves, how can we bring best practices to the people that we see before us in our fractured, diverse health system and population? So how do we do it? Well, we have these therapies, and I promise you, I'm not going to take you through every word and every line of this table, but I'm going to use it to show you how we do our thinking. So we have our medicines. Here's a list of mechanisms. Here's the list of drugs. You've already heard about the CD20s. You've already heard about the oral agents. We're not talking a whole lot about our old school injectables, but that's okay. Here's how they're given. Here's how often they're given. And then we have perception, because for the most part, efficacy, safety, and tolerability are not head-to-head compared in our trials. They are really born of an interpretation and a perception of how well these drugs work, in part driven by our own clinical experience. So don't all start taking pictures of it, because it's just an opinion. And we could quibble over which things get 1 plus sign and which things get 2 plus signs or 3 for each of these characteristics. Let's use it as a framework. Let's say, first approximation. How do we use this information? Oh, and here's how long we've had these medicines. Now, when we are aligning our plans with our patients' needs, that, I think, is where the rubber hits the road. It is not just about coming up with the best decision and telling it to our patient. And it's not just about the patient coming and saying, I saw this great TV commercial, so put me on the drug. It's about aligning what your understanding is and what the patient's understanding is and what she needs from treatment. So for the most part, we leave mechanism of action out of it when we're talking to our patients. And so I've cut the MOA column from this altogether. I'm going to pitch to you a bunch of different scenarios to think about how you would conduct this conversation. Consider you have in your office a patient who had had a brainstem relapse, a high burden of brainstem and spinal cord lesions. From everything you've heard earlier, we're worried about this patient. I said a pyramidal relapse and a high burden of brainstem lesions. So weakness, infratentorial, spinal cord lesions, in my topographical language, shallow end of the pool, has a lot of disease burden. We're worried about this patient. We're worried about their prognosis right from the beginning. So hold that in your mind. On the other hand, maybe this patient doesn't have such concerning prognostic signs, but the patient who says to you, I'll do whatever it takes to fight MS with everything you've got. It's a certain perspective. Not everyone's going to come to you with that take, with that set of desires, but some of them are. And it behooves you to ask, what kind of approach to risk and benefit, what kind of approach to treating this disease is right for you? So in both of those circumstances, either we're really worried about the patient or they really want something high efficacy, we're going to prioritize efficacy. You are not going to present 20 medicines to your patients. You can't, and they can't take it all in. You have to narrow the field. If you're going to prioritize efficacy, you're going to dynamically shuffle your options in your mind, and you're going to put the highest efficacy ones at the top of the list, and then have your conversation. Now, here I have our monoclonal antibodies at the top of the list, and they're all given 4 plus signs for efficacy. So we could quibble about the details. But alemtuzumab, high efficacy agent. Do I use it often? I don't. But the B-cell therapies, ocrelizumab, ublituximab, ofatumumab, high efficacy agents, and we use them all the time. So there at the top of the list. I hear my voice stopping, but I can't tell when. Then we have natalizumab, high efficacy monoclonal antibody as well. Mitoxantrone we don't use often, and then we go down from there. So if we're going to prioritize efficacy, we can start with these and then reason it through from there. But wasting our time and wasting our patients' time talking to them about things that are at the bottom of this list, when we're worried about their prognosis, not going to be highly useful. Let's flip the pyramid. Your next patient comes in. She has an EDSS of 0 and an MRI that barely meets McDonald criteria. And by McDonald criteria, I mean 2017, the last McDonald criteria I will ever understand. This patient, you're not worried so much about immediately hitting them hard with a high efficacy therapy. They've got no findings. You're convinced they have MS, but barely. Or, on the other hand, the patient that comes to you and they have MS, to be sure, but their MS is mild, and they have comorbidities like diabetes, hypertension, liver disease, a history of breast cancer in remission. In other words, the MS is, in some ways, the least of their problem. In both of these circumstances, the patient about whom you're less worried prognostically, or the patient around whose comorbidities you have to navigate, in both of these circumstances, you're going to prioritize the safety of what you're giving that patient, and you're going to dynamically reshuffle this deck in a totally different way. Now, you might find yourself talking about medicines we've had for a really long time, like letermovir acetate and interferons. We don't start them de novo on that many patients anymore, but we could. And sometimes it is worth thinking about the things we've had for a long time in circumstances where that might be the best fit. Now, if you're watching this slide deck closely, you'll notice that there were 2 natalizumabs on this chart the whole time, and here's where they split in 2. So natalizumab, highly effective medicine, but I really think of it as 2 different drugs. In a patient who's JC virus antibody positive, it has a certain risk-benefit ratio. In a patient who's JC antibody negative, the benefits are the same, but the risk is vastly lower. And so I really think of this as 2 completely different medicines based on whether a patient is JC positive or JC negative. And here, in the case of a JC negative patient, natalizumab is going to be pretty high on this list for safety, because that is, PML is really the safety issue to contend with when it comes to natalizumab. And someone being JC negative has 100-fold lower risk. In a sense, the JC antibody is the best biomarker we've ever had in our field. Nothing else that we have tells us that someone is 100-fold more likely to have a good or a bad outcome. More than that. So that one is incredibly useful. Okay. Consider your next patient tells you they have a history of non-adherence. They're self-proclaimed bad about taking their medications. For many years, I put on the white coat and I would talk to patients about taking medicines every day, and it didn't seem like a big deal to me. You know, having a chronic disease, that's a big deal. Treating that chronic disease, that's a big deal. Taking a medicine every day, that's not a big deal. Then I saw a doctor, which I don't recommend ever doing that. And that doctor told me, you need to take this pill every day for the rest of your life. And I thought, that's no big deal. And then every once in a while, the pharmacy calls me and says, you're due for a refill. And I look at the bottle that still has a dozen pills in it, and I think, how is that possible? There's still so many pills left in this bottle that I fail to take every day. So I have a new appreciation for how doing things every day all the time, it's not always that easy. In a circumstance where somebody is bad about taking their medicines, you really want to make sure that they get their drug. You really want to make sure it gets from your prescription into their person so that it does its work. And here, dose frequency makes a big difference. So we have medicines that are given essentially once a year, or for one cycle a year, and we have medicines that are given, I can't do math, 720 times a year, if you have to take things a couple of times a day. So shuffling this deck around what you think you can get to your patient, and you know they're going to get it, with some built-in adherence like nursing protocols, infusion center, scheduling, etc., you might sleep a little bit better at night knowing this patient's going to be treated. And thankfully, many of our infrequently dosed medicines are actually in the high efficacy category. So it's a win-win. On the other hand, for many years, when I started, every single day, people would ask us when we were going to get pills for MS because they didn't want to take these shots anymore, and I respected that. And then when we got pills, it just got more complicated and not easier. But there are plenty of people who hate shots, hate infusions, hate hospitals, hate us for that matter. They don't want to feel like a sick person. They don't want to be put into the sick role any more often than they have to be. And so for those patients, having a pill that they can take and not have to come in for infusions or do shots can be quite liberating and allow them to not feel sick while we're so busy trying to keep them well. And so you heard Dr. Markowitz's talk on all the oral medicines, and there's quite a degree of diversity from safety and efficacy and otherwise within that camp. So we have plenty of subsequent decisions to make if you're going to narrow it to the oral agents. But this makes it a much more productive decision for someone who can't bear to think about shots and infusions. Now, you've heard from Dr. Lublin about clinical course, the distinctions between relapse and progression and what constitutes worsening. And when we talk about progression independent of relapse activity, we talk about it like it's kind of obvious. It's really not that obvious. You really have to look carefully and ask the hard questions sometimes in order to suss that out. So consider the patient with MS, whose gait is a little slower. Her endurance is a little bit decreased. Maybe you can see it on your exam, maybe you can't. Maybe you have to push them harder, do more challenging tasks. Look at how many steps they're taking a day with their smartwatch or their smartphone. But you've got some reason to suspect that they're progressing. Well, then you can look where the data take us for progression. Ocrelizumab, at this point, is the only agent that's approved for primary progressive MS. And so I leave it as an open question to you. Do you take the data from ocrelizumab for PPMS and think, well, this is probably a class effect for all the B-cell depleters? Or are you a purist and you say, only ocrelizumab showed efficacy in PPMS, so only ocrelizumab is going to be potentially useful in that circumstance? People are going to vary on that, and I respect that. You could think about where there were positive trials for SPMS. Siponimod had a positive trial for SPMS, as you heard from Dr. Markowitz. Is that a class effect? Is that going to be true for ozanimod, which only has relapsing data? Again, I leave this open. I try to go where the data take me as much as possible. And then you heard about cladribine having the active SPMS indication, as do many of our other medicines now, but it helps sometimes to look back and see where was there benefit on disability and how was that disability accumulated. I will stop flipping around the pyramid over and over again. You get the idea. I have like 5 more of those, but I'll stop. When you're doing this, it helps to personalize your decisions as much as possible. I said that the JC antibody is the best biomarker we've ever had, and it is. But you also want to have a little panel of infections that you screen for before you have the disease-modifying therapy conversation. If you think or you know that at your next visit, you're going to make a treatment decision with that patient, either a first treatment or a switch treatment, send off this panel of tests so that you have that information. I refer to it to my patients as setting the table for that conversation. It helps to limit the number of choices that are going to be relevant. To date, I have not found anybody to be surprisingly HIV positive or surprisingly hepatitis B positive. I haven't found that yet. But I have found 3 patients who surprisingly have tuberculosis. And it's awfully good to know that before you put someone on a B-cell depleter or other potent immune modulators. So it is absolutely worth doing. So, in summary, I told you I was going to keep it short. I know we're behind, so I'm going to make up a couple minutes here for us. In summary, how do we align our thinking, prognosis, safety, and patient considerations to try to optimize our treatment? So consider the things we mentioned. When you're looking at your patient, think to yourself, is this someone who's prognostically concerning to me or not? And then also realize you're going to be wrong some of the time. So you always want to keep reevaluating that question. It's not just the first time you diagnose the person. Keep reevaluating prognosis. If they didn't have cord lesions when you met them, and now they do 3 years later, their prognosis has changed, and you may need to meet the moment with how you're treating them to match their disease severity commensurately. You want to try to distinguish relapsing from progressive MS. Again, sounds simple. It isn't. There's huge debate in our field as to whether MS is progressive all the time in everyone. You heard Dr. Lublin say the words earlier. Progression is not inexorable, and it's not going to happen in everyone. And I think that's true. But we need to be vigilant for it. And if somebody is starting to manifest signs of progression, we need to attend to that in how we're designing and using their disease-modifying therapies. You need to identify and navigate comorbidities. Also, sounds simple, but you don't know about the comorbidities until you ask the questions and until you list them out and until you send the labs to look for existence of infections and others in the background. So, and also people, shocking point, I'm sure, but people develop new comorbidities over the course of their lives. So I've been at this at our MS Center for close to 20 years now, so my initial cohort of patients from when I was a fellow, I've now had for 19 years. A lot happens to people in 19 years. Taking somebody from 26 to 45 over the course of, your career and their life, their health is going to be different. So you do need to continually reevaluate someone's comorbidities as they develop them and make sure that you're navigating around them. I already said screening for and mitigating infectious risks and thinking about aging. So I'm not going to talk here about stopping therapies, but I have started to change how I talk to my patients about what they can expect when they start treatment. It used to be we'd start someone on medicine and say, okay, this is a lifelong disease, you're going to be on treatment lifelong. Now, if I'm starting someone on a high-efficacy therapy, let's say a B-cell depleter, I don't tell this 32-year-old person that she's going to be on this B-cell depleter for the next 50 years. It's not true. And so we have to kind of navigate managing expectations. I tell people who are starting a high-efficacy therapy that this is a 5 to 10-year plan. And then let's see where they are, and let's see where we are as a field. That's, I think, an easier thing for people to wrap their heads around when they're young and starting a treatment. And I think it's honest. I think our field is going to change if we do things right faster than this person's disease. That's a great problem, but we have to set those expectations. Finally, taking into account our patients' preferences. And, we all have our own way of doing it. But what I would just tell you to do is when you're presenting disease-modifying therapies, don't run a script. Listen to the patient. Look at her. Think about him. Think about how this person is responding to what you're presenting. What are their questions? What are their trepidations? What are their concerns? What are they worried about? If you're just running the script, you're going to miss this huge channel of information coming at you about what's going to work for this person, what they're going to be happy with, what they're going to stick with. So pay attention to their preferences, their values, their issues with drug access. Think about their lifestyle considerations. That's not a rounding error on this. That's like their whole life. So think about their family planning. Think about the life that they want. And then structure your approach to help them reach it. Thank you, guys.
Before I call up Aaron, a couple of things. One is keep the questions coming in. I will try to get to them a little later on when we buy some time later in the day, but there's lots of good ones, so we'll get to them. Secondly, after Aaron finishes, there'll be lunch outside. Grab it and quickly and come back in because we're going to have 2 programs during lunchtime. So what's next is what's interesting in the pipeline, the here, the near, and not so near by my colleague Aaron Miller from Mount Sinai.
First, a brief digression. I had the pleasure to mentor Dr. Krieger when he was a fellow, and Fred and I have offered him remedial mentoring on the 2024 McDonald criteria. And I want to assure him and all the rest of you that anybody you diagnosed by the 2017 criteria will still be diagnosed by the 2024 criteria. And in addition, using the 2024 criteria, almost all of your patients, if you add optic neuritis, will be easily diagnosed. So it's not really a problem. It's going to be quite simple. So when Fred asked me to do this talk, I grabbed onto the word interesting, because that I took as carte blanche. I can pick out anything that I want. And so I picked anything from a panoply of ideas in the pipeline of things that tickled my little gray cells. I appreciate the opportunity to speak here and all the hard work that academic CME has done in making this program so wonderful. And I have 15 or 20 very esteemed friends and colleagues who undoubtedly could have picked different selections, but you're stuck with me. So how do we advance here? Okay, these are my disclosures. Whoops, sorry. And I just want to assure you that I do not have any financial connections to any of the companies that are involved with the ideas and drugs that I'm going to be talking about here. And I'm starting off with something that's not really in the pipeline here, which is stem cell transplantation. If your practice is anything like mine, you're commonly asked 3 questions. What diet should I eat to fix my MS? What about cannabis? And what about stem cells? So autologous hematopoietic stem cell transplantation has been around for a long time. And it's not really what the patients mean when they come in and ask about stem cell transplantation. But it is a potential option for patients who are not doing well. And we published this paper a few years ago with some recommended qualifications for somebody in whom you might want to consider hematopoietic stem cell transplantation. And that is that they have substantial breakthrough activity despite treatment with high efficacy DMTs, or they can't take high efficacy DMTs. They ought to be young. They ought to have duration of disease that's relatively short, 10 years or less in this recommendation. You should only do it at a center that knows what it's doing. Ideally, the patients that get it should be entered into a single database registry for long-term follow-up. And one of the problems in the field is that everybody does it differently. So we need research to establish standards for cell mobilization and immune conditioning regimens. And we need continuing research on comparative effectiveness of autologous hematopoietic stem cell transplantation compared to high-efficacy therapy. And Jeff Cohn will be talking to you later about some other things, has organized a trial called the BEAT-MS trial, which is a multi-center randomized trial of best available therapy versus autologous hematopoietic stem cell transplantation. I won't read all the inclusion and exclusion criteria. This has been a very, very difficult trial to enroll because the entrance criteria are extremely stringent. Nonetheless, and there's going to be a long-term follow-up because one of the potential advantages of this form of therapy is that it's presumably long-lasting. And you take all your risks up front because of the immunosuppressive regimen that you need to do to affect this therapy, but after that, you're done. whereas the high-efficacy disease-modifying therapies that we currently have available continue to garner adverse experiences, some of which are quite serious, the longer you use them. Well, the real kinds of therapy that patients are interested in when they come in and ask for stem cell therapy is they think it's a magic bullet. You take this therapy, it fixes your nervous system, and you're good for life. Of course, that's not going to be the case, probably. And in fact, these therapies actually work not by directly repairing the nervous system, but through immune mechanisms. So one active group in this field has been Dmitry Karousis's group in Jerusalem. They published a paper a few years ago with a randomized placebo-controlled double-blind trial of intrathecal versus IV mesenchymal stem cell therapy versus placebo. Most of the patients had SPMS, but many of them had activity. It was a very complicated crossover trial design, which ended up with re-randomization leading to 6 groups of only 8 patients each. There were positive results on the EDSS, better for intrathecal than IV therapy, and no significant safety issues. On a second trial of intrathecal therapy published from Dr. Sadiq's group by Dr. Harris just this year, reported another trial with 6 intrathecal administrations over the course of a year, mostly SPMS patients with a sprinkling of PPMS patients, 54 subjects randomized, and it didn't work. At least it didn't work on the primary efficacy endpoint of EDSS. Looking at a different administration, intravenous administration, the largest trial, and this is the largest multi-center randomized trial that we've seen with autologous mesenchymal stem cells, was from Antonio Uccelli in Italy. 144 patients randomized, active relapsing or progressive patients who had failed at least one therapy for a year. It was safe, but it didn't work. It failed to achieve the primary endpoint reduction in contrast-enhanced lesions at 24 weeks. This controversy led to publications in MSJ, in their series on controversies in MS, and no surprise that Dimitrios Karousis took the yes side, and Antonio Uccelli, along with Mark Friedman, who's been very involved in this field, took the nay side. There were arbiters, as there always are in these controversy series, and the arbiters came down with a resounding no. That doesn't mean it's not ever going to work, but it's not ready for prime time now, and it should be utilized only in a research setting, in my view. Okay, let's talk now, maybe getting into sort of the near category. And one agent is frexalimab. This is a monoclonal antibody directed against the CD40 ligand, and it blocks the co-stimulatory signaling pathway, which is necessary for this T-cell dependent antibody response. But we've done very well in the treatment of relapsing forms of MS. And so I think the major focus in the field now is looking at medications or treatments, they're not all medications, that we can use in progressive forms of MS. And along that line, frexalimab also suppresses the effector functions of macrophages and dendritic cells. There has been a phase 2 trial in relapsing disease, which was positive, and there are now phase 3 trials underway, both in relapsing MS, called the FREXALT trial, and the non-active SPMS population, called the FREVIVA trial. So within the next couple of years, we'll have readouts of these trials, and I'll be particularly interested in the progressive data. Vidofludimus calcium is a relative of teriflunomide in the sense that it is an inhibitor of the enzyme dihydroorotate dehydrogenase, which impacts, as we've seen earlier this morning, on the proliferation, on proliferating lymphocytes by inhibiting pyrimidine synthesis. It had a positive phase 2 trial in relapsing remitting MS, the EMPhASIS trial. And there are currently 2 identical phase 3 trials in relapsing remitting MS, ENSURE 1 and 2, which have a couple of more years to run, as well as an ongoing phase 2 trial in secondary progressive and primary progressive MS, a trial in which I'll be particularly interested because it's a progressive disease trial, albeit only a phase 2 trial. That should read out this year. And it may work because of activation of Neur1, which may have neuroprotective effects. This is the data from the phase 2 trial that Bob Fox presented or has published, showing a benefit from 2 different doses of vidofludimus on the usual MRI parameters as primary endpoints of phase 2 trials. Okay, another monoclonal antibody that's piqued my interest is faricimab. This is an agent that has almost no data, but is interesting to me because it's an intranasally administered monoclonal antibody. The first time you'll be able to take something through the nose, potentially. This has been mostly worked on by Tanuja Chitnis and colleagues at the Brigham MS Center. And they've reported an open-label study in non-active SPMS in which 70% reported decreased fatigue. I suggest you take that with a grain of salt. But the interesting thing is that in that open-label study of 6 patients with PIRA, 5 out of 6 had decreased microglial activation on PET scan at 3 and 6 months. I'll show you that in just a moment. And based on this relatively sparse data, there is now a phase 2A randomized placebo-controlled trial in non-active SPMS that is currently recruiting 2 different doses of the monoclonal antibody, which is dosed in this trial in 4 3-week cycles, giving the drug 3 days a week, Monday, Wednesday, and Friday. The other days not getting it, and then you have 1 week off before the next cycle. The primary endpoint in this trial is decreased microglial activation on PET scan. And I think you can see this is a one patient from their 6-person study. At baseline, you can see all the microglial activation, which is gradually decreasing over the next 3 to 6 months. This afternoon, Jeff Cohen is going to give you a much more detailed talk on cell-based therapies, including chimeric antigen receptor T-cell therapy, but I'll say a few words about that because this is an exciting area of research. Potential advantages of CAR T therapy is better tissue penetration, which results in better elimination of organ-resident B cells, and a potentially longer duration of benefit. So you give it once and then wait a long time, hopefully till anything comes back. Unfortunately, currently we have only very little clinical data in autoimmune disease, and this therapy has only been utilized in phase 1 trials so far, which means we're very far off still in years, hence my subtitle, Not So Near, for this therapy, but it is promising. This is a slide from Dr. Tour's work that shows that the CAR T-cell therapy depletes tissue B cells better than rituximab. So the top panel here is pre-treatment. The middle row, and this is a lymph node biopsy, the middle row shows virtual complete deletion of CD19 positive or CD20 positive cells and with CAR T therapy, whereas in the bottom panel you can see there are some residual CD19 or CD20 positive cells in patients who were given rituximab. There's only one publication from the use of this therapy in autoimmune disease that was, I think, exclusively or almost exclusively lupus patients. And there has been only one publication that I've been able to find in the use of this therapy so far in MS patients, one of whom developed cytokine release syndrome that required the use of tocilizumab to control, although it was relatively mild. 2 years at the AAN annual meeting, I got a little excited to see a presentation about gold nanocrystals. Swallowing gold sounded like a good thing to me. It was kind of an interesting idea. And this gold has a lot of effects on the body, apparently. It includes some energy-dependent phenomenon which might protect neurons, but it also has a positive effect to improve myelination. So here you can see in the Cooperzone model on your left that if you look at the second panel from the left, vehicle plus Cooperzone, you can see the demyelination on EM. And in the fourth column on your right, you can see that when the gold crystals are given along with the Cooperzone, there's been substantial remyelination. This is also recapitulated in a lysolecithin model of demyelination, where the administration of gold nanoparticles produced some significant remyelination. This was exciting to me. There was also some clinical data that showed improvement in low contrast visual acuity and on a sort of modified MSFC score. Unfortunately, for those of us who are interested in MS, the company seemed to have put its money and its emotional investment, I guess, into ALS at that point rather than MS. And just a week or two ago, there was published in JAMA Neurology the negative results of a trial of these gold nanocrystals in ALS. But ALS, of course, is not MS. And if this drug promotes remyelination, it may still have a positive effect in the disease that interests us the most. So I hope that they don't abandon the efforts in MS, but I have no insider information. All right, on your left is the green mamba snake. You might be interested in knowing why the green mamba snake snuck into my talk on MS. And it turns out that the acetylcholinergic muscarinic receptor has a negative effect on the differentiation of oligodendrocyte progenitor cells into myelin-forming oligodendrocytes. And the venom from the green mamba snake includes a toxin that specifically binds to that muscarinic receptor. And combining that with a fluorophore greatly enhanced the ability to study this potential mechanism. So our company has developed a small, oral, highly CNS penetrant molecule called PIPE 307 for the moment, which is a potent and more selective muscarinic 1 receptor inhibitor than clemastine, which was studied by the UCSF group a few years ago and did have a positive effect on improving visual evoked potentials in an optic neuritis trial, but is a very poorly tolerated medication. So PIPE 307 hopefully is better tolerated, and it is a much more potent and more selective inhibitor. And this has been found to promote remyelination in an EAE model as well. In the top panel here, you can see these are in vitro mouse slices incubated with lysolecithin, which destroys the myelin. MT7 is the green mamba viper molecule, which is the marker and shows the protection against demyelination. But you also can see very substantial remyelination or protection of myelin in in mouse slices treated with lysolecithin and pipe 307. So this preliminary data has not only resulted in the sale of the company to a more major pharmaceutical company, but has also prompted the initiation of a phase 2 randomized double-blind placebo-controlled trial using this as adjunctive therapy, meaning it's added to the patient's existing disease-modifying therapy. This is going to be 168 patients getting a 30-week treatment, not a treatment. The primary efficacy endpoint of this trial is low contrast letter acuity, which is more increasingly being used. Fiona didn't talk about that in her talk, but it's probably a relatively sensitive measure of improvement. And there is a visual evoked potential sub-study planned in this trial. Another small molecule is now gained a name from being previously called OCS05, is now called Privosegtor. And this is a peptidomimetic small molecule that promotes neurotrophic factors. And this works through the serum glucocorticoid kinase, which has a number of positive effects. Promotes neuronal survival and differentiation. It induces oligodendrocyte precursor differentiation and myelination, and also has cell protective effects. In the upper panel on your right, you can see that if you compare the administration of OCS05 to placebo, there are far more retinal ganglion cells remaining than when this population was treated with placebo. And then the lower panel on the right shows a protection from the ravages of EAE using this molecule. So there was a phase 2 acute optic neuritis clinical trial called Acuity, done in France. 36 optic neuritis patients, they got 5 days of IV treatment with OCS05 added to their high-dose steroids. And the main endpoint of this trial, of course, was safety. I'm not sure why the concerns exist about the heart, but the main safety endpoint was that these patients did not develop abnormal ECGs. But the key secondary efficacy endpoints showed a 43% difference in the ganglion cell interplexiform layer thickness and a 28% difference in the retinal nerve fiber layer thickness, as well as an 18-letter difference in low contrast visual acuity, which is a very substantial improvement. There was some acne and headache as complications. This is now going to go into an early, larger phase 2 trial, I believe. Finally, I'm going to just say a few words about the cholinergic anti-inflammatory pathway. It turns out that acetylcholine has an inhibitory effect on macrophages, which are presumably involved in progressive forms of MS, macrophages and microglia, and therefore we don't get release of negative cytokines. It turns out if you stimulate the vagus nerve via the splenic nerve, utilizing actually a neuroadrenergic pathway, you stimulate CD4 T cells to produce acetylcholine. And so an interesting new treatment possibility is restoring the immunologic set point by stimulating the vagus nerve. ignore this statement here about no pills to skip or injections to miss, because the trial that's going to be done is an adjunctive trial, so they're going to not skip that. But this is involves the surgical insertion of this very tiny vagus nerve pulse generator, and it's programmed and charged externally through an iPad application. And the vagus nerve is stimulated, interestingly, only 1 minute a day. 1 minute a day of stimulation, and hopefully we'll see some improvement. Now, this may seem a little bit far out for us people used to pushing pills and IV preparations and sub-Q injections, but there are already some data, published data, a few months ago from a rheumatoid arthritis study in which the primary endpoint was efficacy was met. So the FDA has now provided clearance to the company to proceed with a pilot study of this device in multiple sclerosis. So those are the things that excited me. I'm sure there are other things you could find that excite you, and especially lunch probably excites you. So thank you very much.
Thank you, Aaron. Okay, grab your lunches and come on back, bring them in here, and we're going to have 2 symposia coming up very shortly. Okay, we're going to resume. Everyone got their lunch and got back in. So this is the money talk. I don't usually get to say that. But here we're going to have Dr. Berger and Ben Greenberg from the University of Texas Southwestern discussing best practices in contract negotiation and knowing your worth as an MS specialist. So, gentlemen, take it away.
Thanks, Fred. I want to thank EMD Serono and Academic CME for this program. We're going to talk about what a neurologist is worth and how the first part of this is going to be educating you about your value. It is going to be more addressed to those individuals that are going to be joining academic centers or group practices. If you're going into private practice, which is, by the way, a rare breed, probably not quite as significant, but you'll learn something from this. So why don't we get started? Knowledge is power, as Hobbes said. And when you go through medical school, you do not learn the economics of medicine. This is something that took me a long time to learn. And in large measure, I learned it not when I was a junior faculty member, but I learned it when I became a department chair. And by the way, for those of you like Fiona and Mark that are from another country, this is going to be foreign language to you. We have a very Byzantine, a strange system of medical economics in the United States. Maybe one day it'll change. So data by Matt Rizzo and Bill Mobley collected 20 years ago showed that 73% of neurology departments operated at or below break even, that 83% of them were under severe or moderate financial pressure, and that 17 had severe difficulties making ends meet. Interestingly, only 15% of departments generate a profit from patient care. In fact, a third of them were losing $40 per patient per visit. Hopkins was a good example of this, by the way, from my conversations with them. And as a consequence, there was less time for research and less time for teaching. Things really haven't changed, so this was looked at again in 2019 by Robin Bray and Ralph Sacco and others. And what they found is that departments of neurology, and this is true in group practices as well, sometimes found it quite difficult to make ends meet. That 70% of the faculty salaries paid by clinical income, 20% came off grants, and the financial pressure was graded as moderate in 58% and severe in 13%, with a significant impact on resident training and student evaluation. Now, where does the money come from that supports medical schools and departments? And by the way, there's no department of neurology in the United States that exists independent financially, which means that there's always transfers of money that come from either the hospital with which you're affiliated, the medical school, or usually both, back to the department to make ends meet. And that money comes from a variety of sources, not the least of which, as you see in brown and green on this slide, from federal sources. Now, this slide ends in 2019. You'll see that the amount of federal money coming to medical schools declined in that period of time, 20-year period of time or more, but it is going to be, or is threatened to be, severely constricted under this new administration. And I think it's going to have tremendous ramifications for those individuals that are practicing academic medicine currently. Now, here's something that will surprise you. Between 1975 and 2010, the number of physicians in the United States grew by 150%. And if you kept track of the number of physicians that were added to medical staffs, by and large, it was relatively flat, and it was very flat compared to what one saw with respect to administrators. So the number of administrators in medicine between 1975 and 2010 increased 3,200%. So you wonder where all your money's going to. It's going to overhead for all these administrators. And I will tell you that some of these administrators with college educations no more are making more than junior faculty members at many of the medical schools. So what is the average pay of a neurologist in the United States? And on the bottom half of this slide, you see that the neurologist, so below that green bar. And you'll see those that have the lowest pay are those that are at academic medical centers. So the solo practitioner and those at academic medical centers have the lowest incomes. Those that are in hospital-based practice groups tend to have a higher income. And where does the MS neurologist fit into all this? And there's a paper that I published in MSARD that addressed this. But it turns out that the physician that practices neuroimmunology and multiple sclerosis is towards the lower end of the scale amongst neurologists. So top of the scale is the neurocritical care person. This, by the way, comes from AAN data. The next highest was the neurohospitalist, then surprisingly the general neurologist, and you'll see that the MS neurologist, the average salary for the MS neurologist is significantly lower. That, I think, has to do with, in large measure, because of historical factors. Because up until the availability of disease-modifying therapies, we would spend a lot of time with patients, we had very little to offer them, and we didn't generate much in the way of downstream revenue. And I'm going to talk about downstream revenue and how important it is to what you should be arguing for when you negotiate a contract. How do you get paid? Well, you get paid in most instances on the basis of what's called the relative value unit. And I'm going to tell you what the relative value unit is in a second, but about 70% of individuals or more, 70% of institutions use either relative value units alone or relative value unit in combination with something else to determine what your compensation is going to be. So you're going to have a target for your, if you're predominantly a clinician, a target for your relative value unit that you have to meet. If you exceed it, you may get a bonus. If you don't meet it, they may decrease your salary. So how was the relative value unit determined? It was determined by the Centers for Medicare and Medicaid in consultation with Specialty Society Relative Value Update Committee of the AMA, and it reflected three cost components. And these were related to the physician's work, their time, skill, and training to provide the service. So the physician's work is 52% of the total payment. The practice expense was considered 44%, and the professional liability fee 4%. And this is, as I mentioned, widely employed in determining productivity. So 75% of neurologists receive their payment from evaluation and management codes, and 20% of all neurologists receive all their payment based on these ENM codes, the evaluation and management. The RVU targets are set annually by the academic health centers, and they may be very difficult for MS neurologists to meet. And the reason they're difficult for us to meet with respect to other types of neurologists is because of how time-consuming our patients are. It's one thing to see a headache patient or a seizure patient. You can get them in and out of the office very, very quickly. For many years, I practiced general neurology, and I could tell you that amongst the more difficult patients and the most time-consuming patients are the MS patients. So here's a concept that you need to know about, and it's called contribution margin. What's your contribution margin? Does anybody in this audience know what the contribution margin is? It's the profit, your profit, what it is you bring to an institution over and above your costs. So you bring in a certain amount of money, and that's not just based on what you charge a patient, but it's on what that patient, how much monies are derived from that patient in the system. So you order an MRI for a patient. The University of Pennsylvania, it's like if you didn't have insurance, it's $10,000 for an MRI, you know? There's a certain profit margin in that. If you get lumbar puncture, if you do laboratory tests, if you send them to another doctor, there's a profit that is derived from your seeing that patient. And that's the contribution margin. Very few doctors understand this concept of the contribution margin. When it was calculated by Merritt Hawkins in 2016 for the community neurologist who was associated with a particular hospital, they found that they generated on average about $1 million. I'm going to show you that at the University of Kentucky, that for the average neurologist, it was roughly $2 million per neurologist. Now, how was that calculated? At this time, I'd been a department chair at the University of Kentucky for 16 years. We had 29 providers. Their clinical time was 60%, so on average. So some were 90% clinical time, some were 10% clinical time, but on average it was 60% for those 29 providers. The value that I'm showing you here does not include the revenues that came in when a patient paid for your services, but were the components that were derived from the ancillary things that you did. So the technical facility revenue per provider was over $1 million, and the professional net revenue per provider was close to $50,000. In the aggregate, I misstated it, was $1.8 million and 82 when you corrected for the fact that they were only 60% clinical FTE. And it was close to $2 million that every neurologist brought in to the institution from these other ancillary activities. We don't think about those things. We think about, we see a patient, we bill for a service, we get paid that amount, but there's large sums of money, and I'm going to show you, that come in from our activities. So these are some of the sources of revenue other than the E&M codes generated by MS clinicians. They include the laboratory studies we request, the MRIs. At the University of Pennsylvania, 25% of all MRIs are ordered by the MS division. Evoked potentials, optical coherence tomography, lumbar punctures, the disease-modifying therapy. So if your pharmacy is providing the drugs, there's a huge potential profit there. There's a profit regardless, but if they are operating on something called a Medicare 340B, so this is a law that was enacted that enabled hospitals that were providing a certain amount of indigent care to get, on average, 50% of the cost of a drug back as profit. So assume for the moment that the drugs you're ordering are $60, $70, $80, $100,000 a year, and the hospital is providing it, and they're getting 50% of that back. You don't need that many patients in your practice to generate large sums of money for the institution. Of course, there's the follow-up evaluations, and then the consultations, which are the professional component of it. So you see a patient, they've come to see you uniquely. They come to the Cleveland Clinic to see Jeff only because he's the MS authority, or to Mount Sinai to see Fred because he's the MS authority. They're not coming there for any other reason, but these people say, you know what, you need to see a urologist, you need physical therapy, you need these other people, professionals to see you, and it stays at the institution. They wouldn't be at that institution if it hadn't been for you. So these are data from AHC, so there's Medicare-derived data of what the profits are on average for these studies. So MRIs, $1,000, battery of evoked potentials, $250, and so on and so forth. You can see what they are. I won't belabor it, but they're not insignificant. So in 2017, I published this paper in Neurology Clinical Practice. The derivation of this paper was interesting because at the time, this is before Amit came to the University of Pennsylvania, or just about, I was the division chief, and I went to the department chair and I said, can you tell me what the contribution margin of the division is? And she said, they don't calculate that. First of all, she didn't know what it was, but when I explained it to her, she said, they don't calculate that at Penn. I said, come here. That's the hospital of the University of Pennsylvania. They operate at that time on a 9% margin, which is higher than any hospital in the United States. And that's Wharton Business School, which is the best business school in the world. Trust me, they know the contribution margin of the department, the division, and Joe Berger. And all it takes is a press of a button to get that. So I did with back of the envelope calculations, because nobody would provide me the data, what an MS neurologist would generate. There is an Excel spreadsheet, you could do it yourself. And then I said, how many patients does one clinical FTE, one full-time equivalent clinician in the MS division at Penn see? And on average, that person was seeing 325 new patients and 700 follow-up patients annually. And then I calculated how many MRIs they were doing, how many evoked potentials, how many OCTs, et cetera, and whether they were asking for, whether the drugs were being provided at the University of Pennsylvania. And it came to roughly an annual revenue for the institution of $6,310,000. And then the paper had a sensitivity analysis, because not everybody gets every study, and not everybody gets their studies at the University of Pennsylvania. They may get them at some other facility. So there was a sensitivity analysis that enabled you to sort of figure out where you would be, how much you would be generating if only 50% of the patients, for instance, had their studies and had their drugs provided at that institution. And the same thing was done with follow-up patients, and calculated that $22 million was being generated for the follow-up patients, and a sensitivity analysis was associated with it as well. And then there were some assumptions, like how many of the patients had their electrodiagnostic studies done at the institution, how many of them had their lumbar punctures done there, and so on and so forth. And what I calculated was that the amount of downstream revenue for the institution per one clinical FTE MS specialist was $1.7 million for new patients and $6.6 million for follow-up patients. So an MS neurologist who's working 100% clinically, that the aggregate downstream revenue was $8,377,000. Well, it turns out that we were almost on target. What actually happened is that the institution, after this paper was published, revealed to the department chairman, all the department chairmen, that they were indeed calculating the contribution margins, not only for divisions and departments, but also for individuals. And the numbers that I had generated were almost to the penny, and I had made them up. I mean, it was good reason to make them up, but they were just back of the envelope calculations. It turns out that the MS division at the University of Pennsylvania, and this is probably true at every institution, generates more money for the institution than all of neurology combined. More than epilepsy, neuromuscular, stroke, critical care, all of them combined cannot equal the revenue that the MS division generates for the institution. Not only that, we generate more money than spine surgery. Yet, our compensation is nowhere near that of the spine surgeon and is not as good as the neurohospitalist or the critical care or the stroke neurologist. So, on average, in 2013, I don't think the number's very different now. If you look at the monies you generate and the amount that they pay you, that's a ratio. And they look at that, that's called revenue to compensation ratio. And the revenue to compensation ratio for the average hospital-based neurologist in the United States is 2.47. How does that compare to the rest of the medical community? So this is some data that's available online. And in 2015, a neurosurgeon's revenue to compensation was 2.5. An orthopedic surgeon was 5.17 to 1. An invasive cardiologist, 4 to 1. And a hematologist oncologist, almost 5 to 1. At the University of Kentucky, using the figures that are 6.2 to 1. So we were getting screwed relative to the neurosurgeons. But to show you what it is for the MS neurologist at the University of Pennsylvania, and by the way, you can get this Excel spreadsheet and put your own numbers in. For the MS neurologist at the University of Pennsylvania, it's 44 to 1. So, I mean, it's ridiculous how much money the MS neurologist is generating for the institution. And I tell you this because when you go to negotiate your contracts and you're trying to negotiate a salary, and to demonstrate how much worth you have inherently for the institution, these are the numbers you should be showing them. So the take-home message is that the downstream revenue of the MS neurologist dwarfs that of all other disciplines. And there are certain caveats because there are certain things that I didn't include in the compensation, but you need to know these things because, as Dale Carnegie said, knowledge is power, but it's not power until it's applied. And I'll stop there because we're going to go through a bunch of other things that you need to talk about when you negotiate your contracts, and I'm going to turn it over to Ben.
Thank you, Joe, and to the organizers for today for hopefully what's going to be a slightly different set of talks that you're used to hearing at a CME event. But just by show of hands, how many people in the audience are trainees, residents, fellows, students, somebody who hasn't signed a first contract yet, just out of curiosity? Okay, so a large number. So I want you to think about Joe as your sports agent telling you how valuable you are. And you need to go in, and I almost had a picture from The Godfather. You need to make an offer that they can't refuse because you are highly valuable. And then I'm on the other shoulder saying, there are some realities you're going to have to take into account when having these conversations in order to maximize the deal you get from a holistic perspective. So how do you go about negotiating your contract? Disclosures here are not relevant. I'm going to talk about a few things. One is recognizing that the contract you negotiate is completely dependent on the practice setting. So a lot of what we're talking about today is in an academic center. I'm going to give a few comments about the private practice setting, but most of this will focus on the academic side. Recognizing there are very different payment models out there. There are no two institutions or practices that are alike. Joe talked about RVUs and the benchmarks, but I want to talk about some of the other aspects of a contract beyond dollars, beyond compensation that you need to be aware of. The first thing that's important when negotiating a contract, whether it's with the University of Texas Southwestern or a practice, is to recognize what you're selling. We are not making widgets. You are not manufacturing cars. You are not putting together circuit boards for computers. You are selling your brain. And what I mean by this is you are the sum total of your incredible training, experiences, both professionally and personally, your work, your study, those hours in organic chemistry, all the way through neurosciences, on the wards, with your patients, with your faculty, and all of that has come together to be a one-of-a-kind, not reproducible, unique asset, and that's your brain. And what you're selling when you sell your brain is where you can focus your attention. So for everyone here who's multitasking during the event and answering some emails and doing some text messages, that multitasking is taking away from attention. And in the workplace, people are vying for your brain's attention. Whether it's the patient in front of you or a person on a research project, or you can decide to spend half a day updating a Facebook page, your attention is the asset. And you have a lot of customers for that asset. So you have health systems who want your brain's attention. You have individual university departments, students who want your attention in schools, industry, they want your attention. Taxpayers may want your attention through funded grants. Foundations, nonprofits may want your attention, again, through grants. And ultimately, patrons through philanthropy may want your attention on different prospects or on different projects. And you have to decide where to put your attention, and I'm going to be frank, you have to have a way to monetize it unless you want to be a volunteer. If you want to volunteer your attention, which I encourage us all to do, there are many causes in life where we shouldn't ask for remuneration for our attention. You have to decide how far to go with that. So assuming that you want to be remunerated, you are selling that attention. So this gets to the notion of percent effort. So especially when you're talking about academic centers, we talk about percent effort all the time, but most people when they're starting out think of it as, how many days a week am I in clinic? And that is not the way to think of percent effort. Percent effort is essentially who is paying for your attention. So if you went out into the world and you decided to spend half your professional life working at McDonald's and half your professional life working at Burger King, you would get 2 paychecks. Half your salary would come from one, half from the other. In an academic center, there are multiple people paying your salary, multiple entities paying your salary. It gets aggregated into one paycheck that gets deposited every other week or monthly into your account, but essentially you have multiple employers, and that's what gets broken down into percent effort. There are entities who will pay for your clinical attention. There are entities who will pay for your educational attention and teaching, research, and administrative. And what you do is you negotiate what you're going to get for that attention. Joe just showed you the incredible value you have clinically to a health system. You're worth millions of dollars to that health system. So every half day you spend, every 10% of your time you spend seeing patients, somebody somewhere is making money. It may not be you, but somebody is making money. So you better believe a health system is going to say, I'll take all your attention. You want to give me 90% of your attention? I'll take it. You want to give me 80% of your attention? I'll take it. Because they know that is going to help them financially. That may not be best for you. You may want to decide that you want some of your attention, some of your professional time spent elsewhere. How do you monetize that? And when first starting off, a lot of people go to university departments and they go to chairs with their first negotiation and they ask for the most valuable phrase in academic neurology, protected time. And essentially it's asking for somebody in the world to say, you are such a rock star, I'm going to give you this pile of money a year, every year for some amount of time, for you to go do great things. And it sounds amazing. And it sounds great not to be in clinic 5 days a week, 8 to 5, and to have some diversity in your life. But you have to recognize that what you're asking for is extremely valuable, and the entities or individuals you are asking for it from are essentially venture capitalists. This is Shark Tank. So when you go to a department chair and you say, I would like a certain amount of startup funds for every year for 3 years to get my program in lifestyle modifications in the MS patient population, and I want to start a program on lifestyle modifications, they have to ask themselves, is it worth the investment? Because our chairs, and I'm sure Joe can attest to this, get a lot of pitches every year. There are a lot of people with great ideas coming in saying, invest in my idea, invest in my brain, invest in my time, I'm going to do great things. And you don't get these funds for being a nice person. Unfortunately, that would mean we'd have to fund all of you because you're all wonderful people. But we are looking for, and chairs are looking for, a return on investment. Now, that return on investment, if it's a clinical program, could mean growth of those downstream revenues. So a health system may invest in you to build a bigger program. On the research side, if you're invested in protected time for an academic pursuit, the person investing, the entity investing, expects you to return that investment with future grant funding. That's how they make their money back, through the indirect dollars that come with the grants that you successfully navigate. And they have to ask themselves, where are they going to place their money? They're going to place it with individuals with a proven track record. If you can invest in two wonderful human beings with great ideas, but one of them comes to you with a track record of success and one of them doesn't, where are you going to put your money? I'm assuming if you have a mutual fund, you're all looking at how the fund performed over the last 5 years and using that as a benchmark. Great ideas alone are usually not enough. Great ideas need to come with proven track records, or you have to have a very hot, timely, interesting area of unmet need that you can sell as being valuable. But it has to be something substantial. So what about private practice compensation? This is completely different. So in the academic center, there are lots of different buckets that can pay you. In private practice, it is directly related to clinical revenue for most intensive purposes. But you have to recognize if you're going to go into private practice and you're going to negotiate a contract, there are several different compensation models out there. Some of them give you a guaranteed salary. Some of them give you a salary based on revenue. So you see the funds that are brought in the aggregate and you share in that. And some of them use an RVU production model and potentially a hybrid. You have to have clarity in what you're being offered, and you always want to ask, how could this go down in the future, or how could it be prohibited or impaired from going up in the future? I'm not going to go into time on the RVUs. Joe showed you this data, but needless to say, this MGMA, the Medical Group Management Association, that publishes a 3-year rolling average of how many RVUs get generated by neurologists, goes into incredible detail. They can say a neurologist in a private practice in the southeast of the United States, the 50th percentile, will have 4,900 RVUs. And you can backtrack exactly how many patients would you need to see over the year in order to meet those benchmarks. So what about beyond salary? And this is where I'm going to end, because there's a lot to negotiate on compensation, but there are some things we don't think about. Paid time off. What are the policies and procedures for you being able to take a break and have coverage? Taking a break and answering all your my charts is not a break. So when you're trying to decide what is paid time off, what is the policy and how is coverage there? I cannot stress enough, especially in the academic side or the private practice side, beyond your compensation, what does the institution or the practice do to administratively support it? Now, Joe just told us that administrators have exploded, and there are 2 levels of administrators. There's clinical staff support, which are the people who help you get things done. That's different than the administrators I think Joe's talking to, who are doing a whole host of other things that I haven't figured out yet. But for those who are in the clinic with you, having really good partners on the healthcare team, advanced practice providers, RNs, MOAs, people in the clinic to help you shoulder the burden, who are good at what they do and are not just moving messages to you, but are actually engaging in patient care, makes a huge difference. Licensing fee reimbursement, will they pay for your license? A lot of people assume they will. Ask before you assume. It's very variable through the institutions. CME time, and is there funding? So at the University of Texas Southwestern, there's a faculty academic fund every year to pay for meetings like going to ACTRMS or the American Academy of Neurology. You want to understand the rules about that because that's tax-free dollars. That's an expense you would bear, but it's not coming as salary and can be quite helpful. Non-compete clauses. So as you're looking, particularly whether it's academic centers or private practices, just know sometimes things change and you may want to change your practice setting. Now, that's not true at UT Southwestern. Everybody who comes to us stays because we're awesome, but sometimes you may go to another center and be like, wow, this wasn't a great fit. I'm going to make a change, and there are some institutions that put non-compete clauses, meaning you cannot set up a practice within a certain number of miles of where you started. In general, a lot of lawyers, which I am not, have told me these are not really enforceable, and so there are a lot of people saying, you may sign the contract, but still set up a practice a mile away, but definitely seek out legal advice, not Ben Greenberg advice, if that's in your contract. And then finally, my favorite, parking. So when our faculty, this goes back years in Baltimore, were surveyed on their #1 dissatisfaction with the institution, parking. Was where am I going to park? How close am I to the place I'm going to work? And is somebody else going to pay for my parking? And after all we do, I always found it funny that this was the thing that people at faculty meetings would get more upset about than anything else. So if it's important to you, consider the parking. And the point that was made was there are certain things we do day in and day out, and it's the little things that add up. If I had to put on this list, even beyond paid time off, even CME funds, anything else, the one thing I wish I would ask when negotiating a contract for a new position, it would be to understand in depth what is the staffing support of the environment I'm going to work in. The biggest impact on my day-to-day professional quality of life is the team I work with. When you're in the room with the patient, whether it's for 5 minutes, 15 minutes, or an hour, that doesn't change where you work. That physician-patient interaction is going to be about you, but it's everything else that happens that changes dramatically relative to the environment where you work. So with that, I think we're at an end. I'll turn things over to Joe and Fred in terms of where we go from here, but thank you.
I'll just make a couple other comments, one of which is you should also negotiate for space. I mean, if you're a scientist, obviously you're going to need space for your laboratories. But even as a clinician, you need space. You know, some institutions, they assign you to a cubbyhole or a room where there are a large number of people. You may need your own office, so that's something else that you need to contemplate. And it depends on where you're moving. So one of my sons is currently negotiating with the University of California, San Francisco to join the surgery department out there. And they give him mortgage support because who the hell can afford a mortgage in San Francisco? So there are all sorts of things that you might want to contemplate.
Good, thank you. You're done. Done? You're done. Ben, we're going to keep busy for a couple more presentations. The next one's going to be on the potential utility of BTK therapeutics to manage patients with secondary progressive multiple sclerosis, which may answer some of the questions that came in on this topic. This particular part of the program is supported from an educational grant from Sanofi. So Ben gets to do this, but before we give him his final test of the day, which will be the most challenging.
Okay, so you're all stuck with me for a little while longer, apologies. And I will just say the mortgages in San Francisco, very difficult to get, not in Dallas, so see me after. So as I was sitting in the audience watching the spectacular presentation from Amit Bar-Or, it dawned on me, we really should have shared our slide sets. So and it dawned on me that I have excellent taste in some slides because he picked some of them too. So I'm going to be covering some similar ground as Amit did when talking about Bruton's tyrosine kinase, but I'm going to put this in a much, hopefully different lens relative to the clinical application and what are we learning about this disease in a new light through these clinical trials. So importantly, you heard that this is supported from an unrestricted grant from Sanofi. I do want to call out in my disclosures, I have done consulting with that group. They had no impact in the content of the slides, and this was all under my control and reviewed by an independent group. So in terms of the agenda, I do want to talk about the evolving conceptualization of secondary progressive MS. When I trained, the way we thought about secondary progressive MS was very different than the way we're teaching our residents and fellows now. And then I'm going to transition to the application of Bruton's tyrosine kinase inhibition to this clinical situation. So let's start with the way I was taught. I love these graphs, and they've evolved over time. So when I began, there was no green line, blue bars, or yellow line. It was just the red. So in my medical school, when I was taught with a Kodachrome slide carousel, and I know that's a really old-fashioned term for a lot of you, but when the slide came up describing multiple sclerosis, it was just the red bars, relapsing, remitting, going on to secondary progressive. And as we really dug deep into MRI-based technology and understanding what's happening below the surface, we added in the changes in brain volume, we added in enhancing lesions, and we recognized that the relapses go away, and not only does the clinical phenotype of what our patients evolve into change, but also, at least anatomically, what's going on looks very different. This has evolved through the work of many individuals in this room to a refinement of this notion of activity versus progression. And with the notion of activity being either MRI or clinical relapses, and that being distinct from worsening disability. And those two can coexist, or they can exist independent of each other. And I want to draw your attention to the notion of that green line that's in the middle there, which is not active disease, but there's progression. This is what I always assumed secondary progressive was. So when I did my training, what I had in my mind was the green line. Lo and behold, I was wrong. There's some green lines and some red lines, and there are all sorts of different ways to progress. But as we're going to sort out, it has profound implications for how we do clinical trials and how we choose therapies for our patients. So a group got together and said, you know what, the world could use a new graphic relative to this. And we talked at length about integrating the biology of the disease relative to the phenotype. And this work was done prior to the announcement of the revised McDonald criteria. And I'm with Stephen, I'm still working on it. But the notion that there's a biologic basis of diagnosis, and I agree with them that we need to integrate the biology with the phenotype, and that's what was done with this figure. The notion that there is distinct but overlapping biologies that relate to the various phenotypes we see in clinic, and that there is a biology of relapse and then what is now referred to as a smoldering associated worsening, a smoldering disease biology, which leads to the progression independent of relapses. And we can have long conversations about what's the difference between each of those biologies. But if you look at the current state of affairs relative to relapse-associated worsening and smoldering-associated worsening, at a very high level, I'm going to break it down into three parts. So if you look at this spectrum of biology and you say, well, what causes relapses? At a very superficial, basic level, it's the notion of the adaptive immune system forming these perivenual inflammatory lesions and demyelination. And as you move over into the pure, smoldering, degenerative biology that we see with MS, this is where we hear about the meningeal follicles and the microglial activation. And it's important to note that all three of these can be present in any patient early on. So what's the basis of the microglial theory relative to progressive disease? I'm not going to belabor this point, but needless to say, this has been looked at with a variety of technologies, including histopathology and PET-based imaging, as seen here in a study that looked at individuals with relapsing remitting and progressive disease and found that if you had activated microglia in certain patterns, this is what associated with worsening progression. Similarly, you can look at microglia with MRI technology, these slowly expanding lesions, and find that if you have definite evidence of slowly expanding lesions, your odds ratio of having progression independent of relapses approached 2, so it was statistically significantly associated with that progressive disease. And then there's evidence relative to meningeal follicles. I don't know if Danny's still in the room, but a lot of the imaging work has been done by him at the team in the NIH, as well as others, as well as pathologic studies showing that if you have these meningeal follicles, germinal centers of B cells and T cells, that is associated with a whole host of poor prognostic indicators and progression independent of relapses. So biologically, we have all these different processes going on with at least significant evidence suggesting that microglial activation and meningeal follicle formation are critical for the pathogenesis of progressive disease. So it behooves us to ask biologically, what could we do to alter these biologies that may lead to a benefit for our patients? And this is where Amit did a wonderful job of walking you through the Bruton's tyrosine kinase. I won't repeat this, but needless to say, the origin of Bruton's tyrosine kinase biology, or at least our understanding of it, was really focused on B-cell maturation relative to the genetic disorder, the A-gamma globulinemia, in which it was found to be mutated. Importantly, if you look at BTK and the adaptive immune system, and I just want to pause here and say, remember, it's this part that I'm associating with relapses, okay? There's reason to suspect that if you inhibit Bruton's tyrosine kinase, you would have an impact on relapsing disease. Because we've learned extensively that B-cell depletion is incredibly potent at suppressing relapses, and indeed, the Bruton's tyrosine kinase is critical for B-cell activation. It plays a role in antigen presentation, differentiation, cytokine production, antibody production, and so since we have ample evidence to say that B-cell biology and B-cell activation plays a critical role in relapses, inhibiting this critical enzyme to B-cell activation should suppress relapses. That is the hypothesis that leads to clinical trials. And if you look to the world of microglia, you would expect inhibition of Bruton's tyrosine kinase to impact progressive disease. And Amit walked you through this notion of the myeloid lineage. I won't repeat it, but needless to say, we are not killing, we are not eradicating microglia. We are trying to alter their phenotype in a way that promotes a phenotype that is not inflammatory or damaging to the central nervous system. So it was armed with these theories that a lot of preclinical work was done relative to Bruton's tyrosine kinase inhibition in multiple sclerosis. You can just look to say, is the drug target present and upregulated in tissue of progressive patients? And indeed, in this study published in 2024, you found that in IBA1 positive microglia found in the brain of MS patients, where you looked at chronic MS lesions, you saw that upregulation, that co-localization of Bruton's tyrosine kinase. The drug target was there in the tissue of interest, in the lesion of interest, suggesting that this is a druggable target that may have a benefit. I am only going to show a couple examples, fenebrutinib data and remibrutinib data. There's data for others, and Amit showed you some of this, on studies looking at the inhibition of microglia with Bruton's tyrosine kinase inhibition. And indeed, what you see is a change in profiles at the genetic level and then TNF secretion. That if you stimulate these microglia, that activation can be inhibited if you inhibit the Bruton's tyrosine kinase. So with all of this, there was a recognition that these drugs that alter enzymatic activation, are unlike 90% of the drugs we use in multiple sclerosis. We think of our drugs as hammers. Let's go kill some B cells. You know, let's inhibit migration, let's inhibit adhesion. The nuances of the pharmacology of Bruton's tyrosine kinase are very different than anything we've done before. Amit talked about the fact that the Bruton's tyrosine kinase protein is part of a larger group, family of proteins of kinases that have very unique subparts to it, including the TEC domain, the SH3 domain, the SH2 domain, and the kinase domain. And if you're adding an inhibitor to this, depending on where and how it binds, you're going to get dramatically different effects. Not all BTK inhibitors are the same, and we have to be very cautious. In fact, I would argue we should absolutely avoid lumping these as a class and assuming they will all flow together. They will have distinct differences. And Amit talked about some of those issues. Domain target selectivity, covalent versus non-covalent bonding, not something we think about on a daily basis, reversible versus irreversible inhibition, and CNS penetration, which gets a lot of attention in the literature. But I do want to just note that while on its face, CNS penetration, having a higher penetration is going to presumably be associated with a bigger benefit of the drug, it also depends on whether or not it's reversibly or irreversibly inhibiting the enzyme. So if you irreversibly inhibit the enzyme with a low penetrant drug, that might be just as good as a high penetrant drug that's irreversible. So while in general I agree more penetration is better, it doesn't automatically predict the outcome with the drugs. And the reason this becomes important is there's only so much we can learn from a dish. There's only so much we can learn from an animal model. These drugs need the human trials independent of each other in order for us to draw conclusions about efficacy and safety. So let's go through where we are relative to these trials and progressive disease. You've seen some of this data with the meat, but I want to put a different lens on it because I want to ask a fundamental question as we move from phase 2 to phase 3 trials of what did we get wrong or misunderstand from phase 2 trial data? And I'm going to start with the evobrutinib story. So the evobrutinib phase 2 study design is listed here. It involved multiple arms over different doses. There was an active control arm with dimethyl fumarate and a crossover arm from placebo to evobrutinib. Traditional endpoints of MRI activity over 24 weeks and then an extension, the open label extension, through 48 weeks. At least, I should say open label relative to crossover from placebo to drug. And what was presented in the New England Journal of Medicine article were baseline demographics across the groups. And at its basics, you look at this and you say there was a relatively even distribution of patients. It wasn't as if one arm was uniquely different than another. I will point out, if you look at the percent of patients who had GAD-enhancing lesions at baseline, there's a third, somewhere between a third and a half of the patients who come into these trials with active disease. That's not my clinic. A third of my patients do not have active enhancing lesions on MRI. These are very unique patient cohorts that are created for phase 2 trials, and we have to keep that in mind so we don't overinterpret data. What we found in the evobrutinib trial as published was if you look at the placebo and the low-dose evobrutinib arm, there was no difference. As you went up to 75 milligrams a day or twice a day, there was a statistically significant impact on a reduction of GAD-enhancing lesions. But look at the dimethyl fumarate arm over there. I'm not going to say anything. I'm just going to look at it. It really raised a question, and most of us said, well, it was 6 months, maybe it needs more time to kick in, but it really raises the question of how were these individuals behaving, this recruited population behaving. As you went out to week 48, all of a sudden, all is right with the world in a way. The dimethyl fumarate arm comes down in terms of the adjusted annualized relapse rate. But look what's happening with the placebo and the low dose. The low dose is more active than the placebo. I don't have an interpretation for that. And I want to draw attention to the annualized relapse rates that you were seeing over 48 weeks with evobrutinib, 0.11. That number is going to become critically important for the clinical trials we do because you're going to see this number around 0.1 start to pop up more and more. And what we need to recognize is ever since we got to the S1P trials, where we've been seeing annualized relapse rates below 0.2, in order to show a difference between two drugs, the effect size would either have to be massive for one drug versus another, or your sample size would have to be massive. There is an inherent floor effect when you're only having one relapse every 10 years that makes these trials very difficult to do or very difficult to interpret with relatively small numbers. There were early signs of some concern around liver safety, and we'll address this in a moment. But there were long-term extension studies that looked at the ongoing low annualized relapse rate that was maintained. So multiple trials were launched within relapsing remitting disease, and as you saw earlier today, these were negative studies. And there were a couple interpretations here. One was, wow, teriflunomide is a much better drug than I thought it was going into the trial, and there's a cautionary tale to be told if you look through years of teriflunomide data from the original registrational trials to every trial since that has used it as a comparator, the annualized relapse rate has gone down every 3 years for patients treated with teriflunomide. In the trials, it was between 0.3 and 0.4. As you go to trials with ublituximab, you see it in the 0.2 range, and then more recently, very consistently in this 0.11 range, 0.12 range. And so in order for evobrutinib to outperform this, it would have had to have a massive effect size or a very large sample size, and it had neither. It doesn't mean evobrutinib didn't prevent relapses. 0.11 for an active patient population, we interpret as a profound drug effect. But the trial is designed to show that it would outpace a comparator, and it did not. If you look at the safety, this is a chart that I've recreated for tolebrutinib, but you see in terms of a class, there are concerns around liver safety. And it is worth noting that the liver safety for these drugs is not well understood as to why. Most of the evidence suggests that there's a metabolite effect or an effect on bile acids that leads to hepatic injury, and some people may just be prone to it than others, but we don't know for sure. So let's shift gears now and talk about tolebrutinib because we have data here relative to progressive disease. So it starts with the phase 2 trial, and this trial was very different than evobrutinib's. Danny Reich and his team had a really nice design with a run-in placebo versus a washout placebo, looking at multiple dose arms, following with MRI activity. Similarly, there were baseline characteristics that were quite similar across the groups. If you look at that second to bottom line, the highly active disease, these were individuals with a relapse or multiple lesions, a relapse and multiple lesions at baseline, and this is a significant portion of this enrolled population. These were not your average, I have 2 T2 lesions and oligoclonal bands in my CSF. These were people who were highly active enrolling in the trial. And here's what was seen relative to the impact on number of lesions, a statistically significant reduction at the highest dose of tolebrutinib for the phase 2 after 12 weeks. If you looked at secondary endpoints, including looking for any adverse events, they were relatively limited. The extension study is shown here in very small print, but at the bottom, it's the same as evobrutinib, a sustained reduction in annualized relapse rate. So this led to the launch of multiple trials. So like evobrutinib, the decision was, with very good biologic reasoning, that this should work in relapsing remitting disease, and hence Gemini 1 and 2 was launched. But at the same time, unlike evobrutinib, tolebrutinib was studied in the Hercules trial, which we now have data on, and then the ongoing Perseus trial, for which we will see data on in the future, in secondary and progressive multiple sclerosis respectively. So this was the Gemini trial. So individuals, again, being compared to teriflunomide over time, and this was the data. So just like evobrutinib, with very similar annualized relapse rates, there was a lack of reduction in relapses compared to teriflunomide. Importantly, when you look at the data from Gemini, though, and you ask the question, what's the impact on disability? What you found was a reduction that achieved statistical significance of reducing confirmed disability progression in this relapsing remitting cohort. So remember, biologically, we said there is a biology of smoldering disease happening even in relapsing remitting patients. And so the question comes up, are we seeing that effect here, that independent of what teriflunomide can do? So teriflunomide evidently reduced relapses just as well as tolebrutinib, but was there an independent impact on disability progression? If you look to the Hercules trial, where now the question is asked, can tolebrutinib impact progression independent of relapses? Because the patient population is a secondary progressive, non-relapsing, secondary progressive patient population. We get to a large trial, no longer against an active comparator, but against placebo. So now the bar is different. If I were to ask those of you in the room who have clinics that have non-active secondary progressive patients in your clinic and ask how many of you don't treat your patients with anything, my guess is I wouldn't see a lot of hands. We're all trying something, whether we admit it or not, on-label or off-label, mostly B-cell depletion is my guess. But there are very few of us who are just not treating these patients. Nonetheless, compared to placebo, we were able to, at least in a population, quantify that the biologic impact we're seeing in DISH has a clinical impact in the secondary progressive population, with just over a 30% risk reduction of 6-month confirmed disability progression with the tolebrutinib arm. If you look to what we all love to see, and that's the incidence of confirmed disability improvement, there was 10% of individuals who were treated with tolobrutinib who over the course of the trial saw their disability scores go down. They saw clinical improvement, which is something we see in some other therapies that are used in relapsing remitting disease. Here's the interesting part, and if Danny were here, I'd pick on him, and I'd say, what the hell happened? Because I've been told over and over again by my radiology colleagues that brain volume is a surrogate and is associated with what we see with progression and disability. And I see a beautiful separation of the curves with the tolobrutinib data for preventing progression of disability, but I don't see a separation of the curves relative to brain volume. So the brain was shrinking just as much, whether you're on placebo or on a Bruton's tyrosine kinase inhibitor, this one tolobrutinib, and yet there was a clinical benefit. And so either our biomarker is off in general, and brain volume isn't the surrogate measure we should use in clinical trials, or there is a unique mechanism of action of BTK inhibition that may not preserve the volume of the brain, but still lead to a clinical benefit, and I don't know the answer. And then we get to the liver function side of things, which everyone's familiar with at this point, that there is a need to monitor liver function closely due to the rare risk of significant liver injury. And the presumption is if we see this drug on the market, if it does get approved, that there will be a significant monitoring program associated with this. Fenebrutinib is been studied extensively, and you saw the data that Amit showed, so I'm not going to repeat it. The multiple trials are going on with fenebrutinib in relapsing remitting, and I want to draw attention to the primary progressive trial. I think this is going to be one of the cornerstone important trials, therapeutics for these 5 years, because it's an active comparator to ocrelizumab. And so biologically, it's going to help us take apart, if you deplete a group of B cells versus inhibit this enzyme, is there a differential effect on progression? So remibrutinib is in phase 3 trials versus teriflunomide for relapsing remitting disease. Everybody can take bets. And then we have to now integrate this, and this is where I want to end. So I think we have to take the data we're getting from the BTK inhibitor trials and apply it to this notion of smoldering disease. And we have to reorient ourselves relative to outcomes. So what you see on the top left in green is this multimodal outcome we use in trials referred to as no evidence of disease activity. And it really affords itself to relapsing remitting patients. So no GAD-enhancing lesions, no relapses, no progression on EDSS, et cetera. But then there's the no evidence of smoldering disease activity. NESDA or NESDA, you can all take a vote. NESDA is really focused on that progression independent of relapse activity. And notice it says EDSS plus, because the EDSS is inherently flawed scale for measuring disability, especially early on in the disease, and we need additional tools. And so as we're determining success in progressive trials, we really need to focus on that. But it's going to force us to ask a fundamental question to our clinical practice, and that's this. So what I've done is I've taken this notion of smoldering disease and the orange bar, which is that smoldering worsening, and the green bar, which is the relapse worsening, and I have faintly superimposed the different biologies. So in the green bar are those perivenual infiltrating lymphocytes that are associated with a GAD-enhancing lesion and a clinical relapse if it occurs in the right location. And in the background, all along from day one, are activated microglia and meningeal follicles, and it might be one, the other, or both, I don't know. But over time, those perivenual lymphocytes stop doing those attacks, and the predominant pathologic event is the microglia, the meningeal follicles, at least as we understand it today. My question to us is, if this is our conceptualization of the disease, how do we take this group of patients, non-active secondary progressive MS patients who have progression, in the context of whether or not they're on a disease-modifying therapy or not? So to put this another way, if you have the patient on a B-cell depleter who's worsening in front of you, whose disability is getting worse, if you took them off that drug, would they be in the green? are we artificially uncovering their progression to be clinically evident because we have nothing else to pay attention to? And in a world where I can't prescribe combination therapy for third-party payer reasons, what would happen when I take that patient whose relapses has completely gone away with B-cell depletion and I move them to a BTK inhibitor? Will I successfully keep those microglia from being activated but start to uncover relapses? And what will we do in that scenario, and how will we interpret that scenario? So what happened in these trials, which is profoundly important for showing that BTK inhibition definitely plays a role in preventing the progression of secondary progressive MS. We can see it statistically, clinically, and through multiple biomarkers, not the imaging. We're not yet sure how to incorporate this with a large number of our patients, and I think that's where a lot of evidence is going to have to be generated. So with that, where I'd leave us is I think we're going to see, if I had to bet, these drugs come on the market with progression labels. I think we're going to see safety protocols in place that are going to need us to pay very careful attention to lab results. And I have a list of patients who I know will be interested in trying a therapy that can prevent progression, because when I started my clinic, I had a lot of 30-year-old people coming in with relapsing remitting disease. Now that I've been doing this a while, my patient population is 45 to 60 years old. They haven't had a relapse in a decade, but they're starting to come in and say, I'm worse than last year, what do you got? And biologically and now clinically, at least some of these drugs will make sense to apply to that population. So with that, I'll say thank you, and I'm going to turn things over to Fred.
Stay right there. Thank you, Ben. Okay, now for some real fun. And we're going to have a debate. We've had these several times in the past. They've been semi-polite. No promises today. In fact, many of us are hoping that it's not. The debate question is, does a virus cause MS? And so Dr. Greenberg is going to take the pro. Unfortunately for him, Dr. Coyle was going to take the con. And then, so they'll each have a little bit of time to present their case, back and forth, then a rebuttal, and then we're all going to vote. And it's not for whom you like the best, because they're both wonderful people, but rather how you feel the argument went. So, Ben, you're on.
I would like to begin by conceding. So to be fair, when an email came and said, hey, Ben, we're having this debate on virus versus MS, would you take a side? I said, sure. And only after did they say that Pat was on the other side, because I would not have agreed. I have been coming to lectures, Pat, that you've given for years, and we have a little bit of academic lineage that we share through Dick Johnson. And Dick, who passed away several years ago, I feel like I owe it to him just for any trainees in the room. Dick was, I think it's fair to say, the grandfather of neurovirology in the United States, really did an immense amount of work. And he told the story that there was an article published, I think in the New York Times now 40 years ago, leaking Epstein-Barr virus to this condition called chronic fatigue syndrome. And Dick's phone started ringing off the hook because everybody in the country with chronic fatigue syndrome wanted to see a neurovirologist. And he instructed his administrative assistant this is back when you would call a doctor and it just went directly to them, not a call center. And she was instructed when somebody would say, I need to see a neurovirologist, she would ask why. She says, I have chronic fatigue. And she says, oh, do you want to see a neurologist who believes it's caused by a virus or not? And they'd say, yes. And she'd say, well, that's not Dick Johnson. And that's how we got rid of around doing a chronic fatigue clinic. So I'm going to be taking the pro in terms of a viral cause of multiple sclerosis. None of these disclosures are relevant to this topic. But I am going to disclose that I am old enough to remember this situation. So if we're asking the question, does a virus cause MS, I want to set the ground rules for the debate up front. Semantics matter. And it was Bill Clinton during his deposition who said, and I quote, it depends on what the meaning of the word is. So I would like to define what do we mean by multiple sclerosis. I'm not taking all multiple sclerosis. I'm going to limit the field. And what do we mean by cause? And I'm going to explain each of these in turn. So let's start with multiple sclerosis. So the understanding of multiple sclerosis has changed since I've trained, and it's changing every 5 years. It was another pillar of our political leadership, Donald Rumsfeld, who famously, when discussing the Iraq War, said, well, there are the known knowns, that is, the things you know you know. There are the known unknowns, that is, the things you know you don't know. And then there are the unknown unknowns, the things you don't know that you don't know. And it's the unknowns that always get you. It's the same thing in multiple sclerosis. There's what we think we know, and then there's the stuff we learn as we go along. And we've learned over time that the pathology of multiple sclerosis is very complex. And I just got done talking about the intersection of the adaptive immune system and smoldering disease. And we can look to pathology and recognize that when we talk about multiple sclerosis, in fact, there may be multiple different diseases that have the same syndrome. And so when we're talking about MS, this is a wildly variable syndrome. And so I want to corner one portion of the market of MS when discussing cause. And within the world of relapsing remitting, secondary progressive, primary progressive, within relapsing remitting, there are some people who believe in the inside-out pathogenesis of this disease, that something happens in the periphery and then it invades the brain and you get damage versus, the outside in versus the inside out with damage happening to the brain and eliciting an immune response. I am going to focus on relapsing remitting multiple sclerosis with lymphocyte-mediated demyelination and no evidence of PIRA. That this population of patients, wherever they may be, whatever percent of the population they are, I'm going to argue there is a viral cause of this population of multiple sclerosis. Now let's talk about the definition of cause. I'm defining my terms, that's all I'm doing, and then I'll make the case. So when talking about cause, there are two terms that get used in epidemiology, the words necessary and sufficient, and they can be used in different ways. So let's take each of the four possibilities. The first is Epstein-Barr virus is necessary but not sufficient. What that means is MS as I define it, can never happen without Epstein-Barr virus. However, Epstein-Barr virus can occur without MS. If you were to say Epstein-Barr virus is sufficient but not necessary, it means multiple sclerosis always follows Epstein-Barr. However, MS may occur without it. If you go to the bottom left in the light blue, Epstein-Barr is both necessary and sufficient. It means MS will always happen after Epstein-Barr, and MS will never happen without it. And then finally in the purple, Epstein-Barr is neither necessary nor sufficient. It means sometimes when Epstein-Barr happens, you get MS. MS can occur without it. Epstein-Barr can sometimes be present, not MS or with MS. And what I'm going to do is I'm going to take out the green and the blue, and I'm going to stake my ground that I'm in the top left and Pat's in the bottom right, by my definition, and that is I'm arguing MS, as I define it, can never happen without Epstein-Barr. However, Epstein-Barr happens without MS. So let's look at the examples, just so that you can put this into a concrete form that you're all aware of. HIV is necessary but not sufficient for developing AIDS. There are HIV individuals who do not develop AIDS, but there are no AIDS patients without HIV. And that's essentially what I'm arguing relative to MS. This is different than smoking and lung cancer. Smoking is neither necessary or sufficient for lung cancer. It is a risk factor for cancer. There are cancer patients who have never smoked, and there are smokers who never get cancer. So I'm going to make the argument relative to HIV/AIDS that there's a viral cause of multiple sclerosis. So how do we go about proving causation in the world of microbiology? And this is where it really depends on the pathogen. Whether you're talking about bacteria versus viruses make a big difference. And the history of this and the root of the approach to determining causation has its basis in Heinrich Robert Koch's work back in the late 1800s. He was the individual who identified anthrax and tuberculosis. He was a clinician. He had a private practice, but he developed a oil-based microscope and was able to ultimately culture bacteria using agar and a plate. His student Petrie, developed the Petri dish, and was able to show that you could have a transmissible organism, part of germ theory, that led to a disease. And Koch's postulates have completely failed in multiple sclerosis because they're based on bacteriology and the ability to isolate an organism, reinfect, and show that you get the same disease over and over again. If you fast forward to updates to Koch's postulates, the individual pictured here receiving the Presidential Medal of Science from President Obama, Stanley Falcow, who was a first-generation American. His parents came from Ukraine and Poland. He would steal books from the library about bacteriology and ultimately wound up at Michigan after getting his degrees, and he described how he had horrible anxiety attacks and agoraphobia, had lots of difficulties with public speaking, but nonetheless went on to have a tremendous scientific career where he bridged from Koch's postulates around this culturable organism now to looking at species of an organism and virulence traits, getting into the genetics. And it allows us to start talking about viruses as genetic entities more than just an organism you culture. But even then, his postulates don't hold true for viral-mediated disease. So we get to two of his students who are pictured here, David Fredericks and David Relman. They were all at Stanford together with Stanley Falcow, who said, we need a new conceptualization of proving causation. And they really looked at this at a nucleic acid sequence level. And I'm not going to read through each of these, but basically they said, if you have a tissue that has the disease, the nucleic acid of the organism should be there. And as you get rid of the nucleic acid, the disease should go away. And you can follow the organism over time to show beyond association that there was a causation. So if we apply this to multiple sclerosis, which is the most up-to-date view of molecular pathogenesis and causation, we have a problem. What tissue is the diseased tissue of multiple sclerosis? Is it the brain or the immune system? So it gets into the notion of the outside-in versus inside-out pathology. If you're a believer that the original insult is the brain and the brain's the key, then we really need to find Epstein-Barr virus in the brain driving some sort of event. If you believe in the outside-in, then the key cellular group that we have to look at is the lymphocyte population. There have been countless studies linking Epstein-Barr virus to multiple sclerosis. There is no way for me to go through them all. Needless to say, there's a mountain of epidemiologic studies, immunologic studies, virologic studies showing a distinct, statistically significant link between Epstein-Barr. I will show just two data point summaries for the epidemiologic studies. One was a meta-analysis review published showing that overwhelmingly, when you look for an association between infectious mononucleosis from Epstein-Barr and your risk factor of multiple sclerosis, overwhelmingly the studies say that is an independent, significant risk factor for developing multiple sclerosis. Remember, risk factor is not causation. Lung cancer and smoking could be a risk factor. How do we show that it's always there? And the most meaningful paper in the last few years comes out of our colleagues out of Boston, looking at the Defense Department repository of serum samples and asking the question, let's track people who are negative for Epstein-Barr, and you don't see MS develop. But when they seroconvert, all of a sudden, they take on the risk of everybody else relative to multiple sclerosis. But you don't see that with CMV. You don't see it with other viruses. There's a unique link to the seroconversion of Epstein-Barr and multiple sclerosis in this cohort, very nicely shown. But the numbers tend to be dizzying, and I think this is where, if I had to guess, Pat may spend some time. So I thought I'd get out ahead of it with this. The blue is the US population, 330 million people in the United States, of which 313 million are infected with Epstein-Barr. Now, if on this graph you had to ask, well, where's multiple sclerosis? Down in the bottom right at about 5 o'clock, do you see a little blue dot? That is to scale. I measured in PowerPoint to scale 300 down from the volume, about 1 million people, if you say, with multiple sclerosis. And that's the dot of multiple sclerosis. It's a tick on the tail of the ass of the population, like it's the tiniest little speck. How do you get to understand the epidemiology of that dot? Well, you have to enlarge it. So I enlarged it for you. That's the dot next to the line. So that blue dot is multiple sclerosis. And overwhelmingly in all the studies you find, it all has Epstein-Barr positivity. There's, I think from what I can tell, one person somewhere in South Dakota who somebody diagnosed with multiple sclerosis and they couldn't find evidence of Epstein-Barr in them. But overwhelmingly, everybody has Epstein-Barr virus. But you have to be able to draw a link as to why. And here's where I'm going to put my quarter down, and then I'm going to turn things over to Pat. Everybody likes to wave hands around all the different theories linking Epstein-Barr. Is it activation within the CNS of B cells? Molecular mimicry, very nice work coming out of our colleagues in California on glial CAM antibodies and elsewhere. And then it's this last one, the activation of what are called forbidden memory cells. And it's this one that I believe to be the link. I do not think it's molecular mimicry or the antibodies, because if that were true, I would expect to see acute multiple sclerosis at the time of Epstein-Barr infection when your antibodies are the highest. But it's not the teenager who kissed somebody and got mono who has acute fulminant. It's 10 years later that MS presents itself. So it doesn't seem to correlate with the antibodies that supposedly have molecular mimicry. But what happens with Epstein-Barr virus infection is that once it gets into B cells, it allows the B cell to bypass a step in tolerance induction. So you get a population of memory cells that have not been checked for self-reactivity. And it's these memory cells that shouldn't exist that I'm going to argue is the link between Epstein-Barr virus and multiple sclerosis. So if you go down this line, the Epstein-Barr virus-induced autoreactive memory B cells would explain the low rate of MS relative to the infected population. Because I could infect everybody, you all get these forbidden B cells, but you had to have one that was self-reactive to a CNS antigen. So the reason it's only that small little dot from a totally at-risk population is we all don't have self-reactive B cells relative to the CNS. It would also explain why anti-CD20 drugs are so good in MS. They deplete these memory cells. They don't deplete plasma cells. If multiple sclerosis, the Epstein-Barr link to multiple sclerosis was molecular mimicry and antibodies, we need to deplete plasma cells, not memory cells, in order to get rid of the disease. So the target of the anti-CD20 overlaps with this theory. Those autoreactive memory cells can be created, but not create pathology for years after. Again, you get the infection, but it's years later that you get the disease. And then finally, as we know, there is a critical component of T cells in this disease, but those autoreactive memory cells are critical for T cell stimulation. And then finally, and this is the one that explains that one guy in South Dakota who tests negative, in a way, it's possible for you to find autoreactive memory cells without EBV genome in the cell. Because once those memory cells are created, there's a stochastic event with division. And if you don't get the virus, you can still have the autoreactive cell in a daughter cell, have the trigger be the virus, but the virus not be present in that one cell. So if we put this side by side with the modern day Koch's postulates, we actually fulfill the majority of them. And we show that when you have these autoreactive B cells, these forbidden B cells triggered by Epstein-Barr, you can have the disease reproducibly. And I'm going to end, I believe, with these two slides. One is looking at the impact of disease-modifying therapies that have worked and not worked for multiple sclerosis relative to memory B cells. And if you have an impact on memory B cells or the B cell replication, you have decreased the activity of the disease, particularly relapses. But look at atacicept. Atacicept was a fascinating drug that actually led to an increase in memory B cell populations. And we saw an increase in disease activity. And so there is a link, even from our therapies, focused on these memory B cells that can bridge the gap between Epstein-Barr and the disease. We are only going to know the truth through a pivotal trial of vaccination. And so until, and there are multiple in development, I list several here, protein-based, RNA-based, nanoparticle-based vaccine programs for Epstein-Barr, and it's only once we stop this virus from spreading in our teenagers and infectious mononucleosis will we know over about 10 or 15 years, have we rid the world of multiple sclerosis. So with that, I'll end staking my claim that if you define MS the way I did and cause the way I did, yes, Epstein-Barr causes multiple sclerosis, and I'm happy to turn things over to Dr. Coyle.
Sorry, I didn't introduce Dr. Coyle, who's a professor and vice chair and director of the MS Center at Stony Brook, and a skilled debater.
Okay. So I'm delighted to be participating in this great meeting. I felt sorry for Ben. I sort of saw him as a pathetic little lamb being led to the slaughter. But then I've heard this word salad nonsense about MS being an immune-mediated disease and memory B cells, and it's complete confusion. So I'm going to give an overview, talk briefly about MS etiology, the general role of infection in MS, and then focus on EBV with some specific considerations, and I'll summarize. And then in the rebuttal, I'm going to give what I think is the big picture. Okay, it is not proven and not accepted, and I'm willing to bet that if we polled the whole audience here, only a minority would say that MS is an infectious disease. Now, really, we know infections are intimately related on multiple levels to MS. That's not a problem. As is pointed out, EBV is the major environmental pathogen, 32-fold increased risk of MS. But a triggering event is not considered causal, and it would be a grave error to think and treat MS as though it was an infection. This would indicate MS should be contagious. It's not. Critical damage is being driven by the pathogen throughout the disease process. We don't have convincing data for that. I'll show you some data that would refute that. And treating the pathogen should treat and even cure MS. Completely unknown, and quite frankly, we're never going to get an EBV vaccine that wipes out EBV. We are just not going to get it in the current era. There are newer criteria, the Bradford-Hill criteria. There are 9 particular concepts. Particularly specificity and temporality are not met. So when we speak about the etiology of MS, it's clearly multifactorial. There's a genetic vulnerability, as we heard about, maybe less than 7.3% of the Caucasian population is at risk for MS. But then there are very important environmental factors, in particular EBV, but that's not been the only pathogen. Human herpes virus type 6, human endogenous retrovirus has been implicated as well. Epsilon toxin from the gut microbiome. These have all been implicated as potential infectious contributors to MS. But to date, everyone has been knocked down. Every single one has been knocked down. No infectious agent is proven to cause MS. EBV may be necessary. We don't know that for sure. It comes close to 100%. May or may not be necessary, but it is certainly not sufficient for MS. And in fact, it's linked to many immune-mediated diseases similar to MS. The median of 7.5 years after EBV infection, that's not really a great time link to talk about it being causal to the disease. So what do we know about infection, which is implicated in every immune-mediated disease? As part of the prodrome, you can see increase in infections, particularly in the year before the diagnosis of MS is made. We know that infections can act as triggers for onset of MS or relapses or pseudo-relapses. The common cold can be associated with a relapse. We know that there are increased infections with progressive and more disabled MS, and certainly most of our disease-modifying therapies are immunosuppressive agents, and we've had very nice reviews about risk of infections in those cases. So EBV, human herpes virus type 6, is an enveloped double-stranded DNA gamma herpes virus. The first human oncogenic virus, and that's kind of important because although it doesn't cause a lot of malignancy, that's actually what's driving the vaccines. It's not any concern about MS at all. It targets epithelial cells for its lytic infection and B cells for its latent infection. And as we've heard, over 95% of the population has been exposed to EBV. It's transmitted via saliva in particular. Most infections are absolutely asymptomatic, and that's a big problem for trying to get a universal vaccine. It's the major cause of mononucleosis, but not the only cause. So 90% to 95% of EBV infections never cause symptoms. You have the acute infection followed by the dormant state, truly in B cells, latent B cells. It's really the 1 to 2% of cancers that it can cause, with 200,000 deaths a year, and they're listed here: Burkitt's lymphoma, gastric cancer, Hodgkin's lymphoma, et cetera, that are really driving development of potential vaccines. We lack good genotype data for EBV. We have two major subvariants: type 1 EBNA2, which is globally found, type 2 EBNA3, which is from Africa. There are over 71 distinct EBV strains, and you can get infected with more than one strain, but this is not well studied at all, the genotypes of EBV. It causes no illness. It can cause infectious mono, rarely can cause chronic active EBV infection. Now, you have tightly regulated genes for the replicative, the reproductive, and the transforming persistent latent infection. We know it's quiescent in circulating memory B cells, as has been pointed out, but you don't really see brain EBV reactivation in most MS patients. You really don't see that. The meningeal follicles are not limited to MS. You can see them in non-MS individuals as well. Is infection with EBV required for adult onset MS? It's close to 100%. 100% has not been reported. There was one person in the Department of Defense study. Molecular mimicry has been commented on, and GlialCam has been noted, but GlialCam seemed to be a target in 20 to 25% of MS. That's not an overwhelming autoantigen target if it's truly critical for MS. I don't think that's proven. So some specific considerations. EBV is not uniquely associated with MS. It's considered a likely trigger for several immune-mediated diseases, including lupus, rheumatoid arthritis, Sjogren's, mixed connective tissue disease. They all have very important relationships to EBV, and we don't think EBV causes lupus, rheumatoid arthritis, Sjogren's, and mixed connective tissue disease. It's not very likely. It's considered a potentiator of immune-mediated diseases. Many potential EBV strategies are being proposed, like adoptive T-cell therapies, antiviral therapies, lytic induction therapies, get it in the epithelial lytic phase and then knock off those cells, and prophylactic EBV vaccines, again, being really pushed by the oncogenic potential. In the pediatric onset MS, no one to date has reported 100% EBV seropositive. It comes very, very close. In the Canadian series, 96% plus were EBV VCA IgG positive, 90% plus EBNA1 positive. In the US network, anti-VCA antibodies were 94.6%, 95% versus 60.7% of the control group. So it's very close to 100%. It may even be 100%, but that would not make MS an infectious disease due to EBV. If you look at the spinal fluid and you tap early on at the presentation, the first attack, et cetera, you virtually never get PCR for EBV positive. It's virtually never positive. When you look at the IgG oligoclonal bands in the spinal fluid, they're not directed against Epstein-Barr virus. When you look at IgM oligoclonal bands, they're not directed against EBV. It's much more likely myelin lipids. In a recent intrathecal antibody analysis of 11 pathogens in 50 MS individuals, 100% of them were seropositive for EBV, but only 10% showed intrathecal production of EBV antibodies, dwarfed by parvovirus, which was 70% intrathecally positive, and 40% for measles, rubella, mumps, and varicella zoster. So when we talk about targeted therapies, people are doing cytotoxic CD8 T cells autologous and allogeneic. They have proposed vaccines. They proposed antiviral agents. There's a small study that's been going on in France for a number of years that's looking at autologous CD8 T cells to treat high-risk CIS patients. It's hardly entered any patients to date, but the completion date is in 2026. There's an antiviral study that's ongoing looking at being able to reduce EBV levels in saliva and blood over a 3-month period. But the EMBOLD study is a big point against what has been argued. This was testing ATA188, which are allogeneic cytotoxic CD8 T cells against EBV in 103 primary progressive or secondary progressive patients, and it was a 12-month study looking at confirmed disability improvement rate. You didn't see it. No impact on manipulating this immune response to EBV. No impact on these MS individuals at all. In fact, the placebo arm showed 16% improvement versus 6% in the EBV-treated arm, with no impact on imaging or fluid biomarkers. A big disappointment for the whole concept that manipulating the host immune response to EBV is playing a role in MS and would be a potential treatment. With regard to therapeutic vaccines, we have none at the current time, and I have my strong doubts that we're going to get one. But it's the cancer-causing component of EBV that's driving the development of the current vaccines. I don't see this happening to wipe out EBV entirely. So to summarize, 100% seropositivity is not at this point documented for all MS. It's close. Even if it is, it's perhaps necessary, but certainly not sufficient. No MS exclusivity, a connection to multiple immune-mediated diseases. The data simply does not support MS being a neurological infection due to EBV, and the word salad doesn't change that. It's a neurologic infection due to EBV, yes or no, and I would say no. Treating MS will fail. Okay.
So I'm actually feeling a little better now, I gotta be honest. I thought I was gonna be a lamb to the slaughter, but I would actually agree with everything you just heard and say it supports my contention completely. So
You can't say that.
I can, and it gets to what is. So if we take and here's fundamentally where I think we're having difficulty with the field is, this is a very different, necessary but not sufficient causation than HIV and AIDS. Because we think of viruses as only causing problems during the lytic portion of their infection, dealing damage to the tissue they infect. And that's not the model of the forbidden memory cell. The model of the forbidden memory cell is the hit and run of the infection. If it was not for the EBV, that memory cell would not exist. And it allows for a world where EBV can be a risk factor for multiple autoimmune disorders based on the background of antigen B cells that any random person has living in them. But if they hadn't gotten a trigger to forego tolerance induction, they would have never had the autoimmune disease. So I agree that we shouldn't be trying to reduce viral loads. The horse has left the barn. The disease is there. It's like quitting smoking after the lung cancer. You've already got the mutations. It's already going. The question is, can we prevent that autoimmunity by preventing the trigger in those memory B cells? So when we're talking about the EMBOLD trial, which is a failed trial, and the 16 versus 6% is interesting. This is why we do placebo-controlled trials. Sometimes it's better to be on the placebo. But altering viral replication or having cytotoxic cells isn't going to solve the problem of those memory B cells being there. So I'm going to stand by the fact that EBV is, I agree, it is not sufficient, but it is necessary for us to have this syndrome we call relapsing remitting multiple sclerosis.
So that's really saying that getting rid of the memory B cells would be the answer and the cure for MS, and I don't think there's any real data to support that. In this rebuttal, I want to talk about the big picture briefly. This is work being done at NINDS, and what they've done is they've looked at several different diseases that are triggered by a variety of infections, no one infection, but a variety of infections, that then have persistent neurological symptoms. And they've done deep dives to these individuals. Now, if you look at what we might be listing there, we can start with a very established MS, with an infection trigger, estimated 1 million infected. Post-infectious myalgia, encephalomyelitis, chronic fatigue syndrome, estimated 1 to 3.3 million Americans affected. Long-haul COVID or post-acute sequelae of COVID, the so-called PASC syndrome, an estimated 17 million in the United States. Post-treatment Lyme disease syndrome, an estimated 2 million in the United States. And post-infectious fibromyalgia, an estimated 4 million. That's like 27 million plus. Now, in these diseases, they have pursued the concept of an ongoing infection to the original trigger, and it has not paid off. These all appear to be immune-mediated, inflammatory-mediated syndromes. This was the deep phenotyping done of chronic fatigue syndrome at the NINDS, where they kept them for several weeks. And they whittled it down. They had 17 bona fide perfect patients and 21 healthy controls. What they found was a brain dysfunction, decreased right temporal parietal junction activity that was driving the motor cortex. They found dysregulated catecholamine pathways. They found autonomic dysfunction, and they found blood changes, increased naive B cells, decreased switched memory B cells, and they found unique CSF findings, including a unique CSF metabolomics profile in these chronic fatigue patients. They also did a deep phenotyping of long-haul COVID PASC, 12 patients with healthy controls, spinal fluid and autonomic testing, mainly cognitive difficulties and fatigue, with decreased smell documented. Well, it's COVID. Positive oligoclonal bands in 25%. In the spinal fluid, a change in the cell content, decreased effector memory, CD4, CD8 T cells, increased antibody secreting B cells, increased cells expressing immune checkpoint inhibitors, and autonomic abnormalities, suggesting these diseases triggered by an external infection leading to persistent issues did not turn out to be a true persistent infection trying to go after that initiating, triggering agent, but rather had been pushed into maybe a neurologic, immunologic, inflammatory syndrome. And maybe there'll be common themes that are discovered by deep phenotyping.
Thank you both. Now we get to vote. So Patrick?
Yes.
Okay, this is how we do it. So who won the debate? And you've got
All right, we're good. Right. This is,
the Trump approach.
oh, wait, it's still going. Yeah. Can we declare after the first?
Yeah. But I'll say now, before we end, we do have to thank both debaters here. It was excellent discussion.
I feel like I'm watching the North Carolina primary on, you know. All right.
I think we're good, yes? Last chance. Let me just ask a question without these lights. How many people voted? Excellent. Dr. Greenberg, you're the winner.
By a hair. Yeah.
Hard to
Well done.
believe.
Always a pleasure.
Very good.
Have you had a scarier thing in the past? Okay, we're going to move along now after our great debate. And next up will be Dr. Jeff Cohen from the Cleveland Clinic to discuss cell therapies to treat multiple sclerosis.
Well, good afternoon, everybody. Hope you're finding this a rewarding conference. I'd like to thank Fred and Academic CME for the invitation. I always enjoy this conference each year. So I think after that successful debate, instead of just giving you a lecture, I'll just debate myself. Oh, no, you're not. Oh, yes, I am. Oh, no, you're not. Yes, I am. All right. Anyway, so what I was asked to do today was to provide some update on cell therapies for multiple sclerosis. Rather than comprehensively covering the whole topic, I'm primarily going to focus on two cell therapies that are getting a lot of airplay recently, CAR T transplantation and regulatory T cell transplantation. So my disclosures are listed here. None is directly relevant to this talk. The other disclosure I should make is that at least several people in this audience probably know more about my topic than I do. All right, so by way of background, this table lists the current therapeutic landscape in multiple sclerosis. There are more than 20 disease-modifying therapies with regulatory approval to treat MS. They represent a variety of mechanisms of action, level of efficacy, safety, tolerability. And the availability of those medications has been a major advance in the field, but none of the approved therapies is, for relapsing MS is fully effective in all patients. And in particular, there are some patients with very active disease who have continued relapses or MRI lesion activity despite treatment with the available therapies. As you've heard, a couple of these medications have efficacy in progressive disease. However, the level of efficacy is modest, and it's primarily in patients with ongoing superimposed lesion activity. And also, as you've heard, the current therapies are primarily intended to reduce the accumulation of damage. None of them directly promotes repair. And so there are a number of unmet needs in multiple sclerosis, and cellular therapies has been one of the approaches that's been proposed to address some of those unmet needs. So this slide lists how I like to categorize cell-based therapies. They can be divided into, in my mind, two main approaches: immunomodulatory approaches and strategies to promote repair. So among the immunomodulatory approaches, hematopoietic stem cell transplantation, bone marrow transplant, would be the prototype. There's fairly robust evidence now supporting the marked level of efficacy of hematopoietic stem cell transplantation, but also documenting that it's a very complicated and risky procedure. So there are several ongoing randomized trials to try to determine where to place hematopoietic stem cell transplantation in our overall treatment sequence. And then there are CAR T transplantation, egg transplantation, which is what I'm going to focus on today. And then, as you just heard, also among the strategies to treat a putative ongoing EBV infection and transplantation of anti-EBV cytotoxic T cells. And then there are a number of strategies to try to prepare, include direct transplantation of the progenitor cells, or strategies to try to support the intrinsic repair mechanisms. So I'm not really going to talk about those today. So let's turn to CAR T transplantation. So there's been a lot of interest in CAR T transplantation to treat cancer. It's revolutionized the treatment of lymphopoietic neoplasms and multiple myeloma. But as you can see here, there's also been rapidly increasing interest in pursuing this in autoimmune diseases. The bulk of the studies published to date have been in lupus, but there also are increasing numbers of studies being conducted in multiple sclerosis, NMO, myasthenia gravis, and others. So what is a CAR T cell, a chimeric antigen receptor T cell? So these are engineered effector T cells, cells that kill other cells, that have a so-called chimeric antigen receptor, which comprises an artificial antigen recognition domain. That's where the target, how the target is determined. Then there's a hinge region, and then there's a transmembrane domain which links it to the cell membrane, and then an intracellular activation domain. This is the part of the CAR that's responsible for activating the effector T cell after it engages its target antigen. And so what this construct allows is for non-MHC restricted effector T cell recognition, activation, and then cytotoxicity, not only in the blood where they're initially administered, but also potentially within tissues. And that's one of the putative advantages of CAR T. So there now are a number of CAR T products approved to treat cancers. The anti-CD19 are approved to treat B-cell neoplasms, and then the BCMA CAR Ts are approved to treat myeloma, and I'll talk about both of those a little bit later. So this is just to remind you of the surface antigen expression pattern in the B-cell lineage. To illustrate where CD19 is expressed, it's very similar to the expression of CD20, the target antigen of our B-cell depleting monoclonal antibodies. And then BCMA, or B-cell maturation antigen, is expressed later in the plasma cell part of the lineage. So to date, the CAR T therapies that have been approved are autologous. They're derived from the patient's own cells. So this figure outlines in a general way the procedure for generating and administering CAR T. So lymphocytes are harvested from the patient, typically by leukapheresis. And then in culture, the CAR T are produced by infecting them with a lentivirus vector that carries the CAR T, the CAR construct. Then the cells are propagated in culture, converted to an effector phenotype, and then reinfused into the patient following low-dose chemotherapy, a lymphodepleting regimen. So this is, for the oncologist, a relatively mild chemotherapeutic regimen, nothing like what's done for hematopoietic stem cell transplant. So in general, in cancer, there can be fairly significant adverse effects. So far in autoimmune diseases, the adverse effects have been less prominent, but occasionally occur. So what are the acute toxicities of CAR T therapy? Well, first of all, there can be sometimes, rarely, complications of leukapheresis. The lymphodepleting chemotherapy, which typically comprises relatively low-dose cyclophosphamide and fludarabine, can have side effects. There may be a reaction with the cell infusion, but the two adverse effects that we're mostly concerned about are the cytokine release syndrome and the immune effector cell-associated neurotoxicity syndrome, or ICANS. So the cytokine release syndrome occurs shortly after the infusion. It's associated with CAR T activation, target cell lysis, and the release of pro-inflammatory mediators. It has a number of potential symptoms, including, in its mildest form, fever or anorexia, headache, but it can lead to more severe dyspnea, hypoxia, hypertension, cytotoxic shock, and very rarely death. So the CRS is mediated by a number of soluble mediators. IL-1 plays an important part. So other than antipyretics and steroids, anakinra, an IL-1 blocker, is the key treatment for that. My way of thinking of the immune effector cell associated neurotoxicity syndrome is it's the CNS consequences of CRS. So it's associated with mental status changes, seizures, manifestations of breakdown of the blood-brain barrier, sometimes other cognitive issues. So it's also mediated by a variety of soluble factors, among which IL-6 is very important. So tocilizumab is a key treatment for that. The risk factors for CRS and ICANS are not well known, but they seem to be in general related to the dose of the cells that you administer and the dose of the target that's present, which determines how briskly the cells are activated and expand and how many cells are killed simultaneously. One of the questions in autoimmune disease is whether a pre-existing CNS disease, for example, multiple sclerosis, might also predispose one to CRS and ICANS, although so far, thankfully, that's not been the case. So this figure sort of illustrates the time course of these syndromes. CRS develops shortly after the infusion, sometimes within a day or two, and then that's followed at a week to 2 weeks by ICANS if it occurs. And then this also illustrates that the ICANS tends to occur simultaneous with the expansion of the CAR T population, and then as shown on the bottom, CRS and ICANS are related to a variety of mediators. And then what are the long-term toxicities? So some of these are specific to the CD19 or BCMA CAR Ts, but some of these are probably general consequences of CAR T therapy, and there's a number of other CAR T approaches that are under development. So a therapy that kills B cells can ultimately be associated with hypogammaglobulinemia. Sometimes the B cells fail to come back after the treatment, leading to B cell aplasia. There may be infections as a consequence of the immunosuppression. Interestingly, other autoimmune diseases have sometimes been seen. And then finally, there's this interesting movement in neurocognitive toxicity, so far only seen with BCMA CAR T therapy. And the mechanism for this is still somewhat unclear. So what's the rationale for anti-CD19 CAR T therapy in autoimmune diseases? Well, first of all, CAR T therapy has been shown to be helpful in a variety of animal models of systemic autoimmune and neuroinflammatory disorders, including EAE. Up until recently, there were a number of case reports of efficacy in lupus, anti-synthetase syndrome, NMO, MOGAD, myasthenia gravis, MS, and there now are an increasing number of clinical trials underway in MS and other autoimmune diseases. What are the potential advantages? Well, first of all, there are a number of CAR T, CD19 CAR T products also already available, so that expedites the development process. They lead to very potent cell depletion, not only of the circulating B cells, as occurs with B cell depleting monoclonal antibodies, but also deep depletion within the tissues, including the CNS. The other advantage is that it's potentially a single one-and-done therapy, where you administer the cells once, and then you have long-lived efficacy, both because of the longevity of the CAR T cell, but also because, as we've heard now in a couple of talks, deep B cell depletion followed by reconstitution with an altered B cell repertoire and phenotype. So what's the evidence that CAR T actually do lead to this deep tissue depletion? There have been a number of studies that have supported that, one of which is this one. So this was a study of patients with autoimmune diseases, primarily lupus, treated either with CD19 CAR T or rituximab followed by lymph node biopsy. And then in another cohort of patients, there were also biopsies of some other tissues. And I'm not going to go over this in detail, but just to show that even though both therapies led to marked B-cell depletion within the circulating blood, there was no depletion of B-cells within the lymph nodes with rituximab, but almost total elimination of CD19 B-cells within the lymph nodes and in the tissues. So up until now, there's only been a few published series of CAR-T in autoimmune diseases, one of which in MS is this study. So this was a report of 2 patients with MS treated with CD19 CAR-T. They underwent sort of the typical autologous CAR-T regimen that I described earlier. Both of them had relatively severe progressive MS. And working our way across the slide, the experience in these 2 patients, each of which represents a row, illustrates a couple of key points in terms of considerations for CAR-T and MS. So the first patient on the top row, if you look at the second column, had some circulating B cells prior to the CAR-T administration, which were very rapidly depleted. But the presence of those B cells stimulated the CAR-T. There was relatively rapid expansion, and that was associated with CRS, which was associated with transient worsening in the EDSS, if you look at the far left column. So that illustrates the point that the presence of some B cells may be associated with increased risk of CRS and ICANS. But as shown in the third column, that also was associated with a more robust expansion of the CAR-T, which then could be detected in the CSF. And then, as you see on the bottom row, this patient in the second column had no detectable CD19 B cells at the time of CAR-T transplantation. They had a much more gradual expansion of the CAR-T, which was not associated with any adverse effects, including no change in the EDSS, but they also had a much less robust CAR-T expansion and many fewer cells in the CSF. So finding the right sweet spot for activating the CAR-T but not having it excessive is going to be one of our tasks for the future. So there are a number of CAR-T trials that are either ongoing or in development. I'm contacted almost weekly by yet another company with a CAR-T product trying to convince me to get involved. One of which is that illustrates how most of these studies will be done is shown here. So this is a trial being conducted by Bristol Myers Squibb of their CD19 CAR-T. It's being done in 2 cohorts. One is an active relapsing cohort with inadequate response to disease-modifying therapy, and then a second cohort of non-active progressive MS. In fact, they're adding a third cohort of myasthenia gravis. And so all the ongoing CAR-T studies so far are phase 1, primarily safety studies, and so they're dose finding, and then there'll be an expansion cohort where what seems to be the optimal dose will then have additional participants enrolled. So what are some of the considerations for CAR-T in MS? Well, we're still trying to figure out the risk-benefit, both the acute and long-term safety issues, and the cost relative to our available disease-modifying therapies. What the most appropriate target population, whether it's going to be active, highly active relapsing MS or progressive MS or both, is unclear. What the effects of prior disease-modifying therapy will be, including B-cell depleting therapy. And then this is a very rapidly evolving field. With development in the CAR-T product itself very rapidly changing. But we still need to work out what's the optimal dose. In cancer, they try to administer the highest dose possible. It may not be necessary for autoimmune disease. What's the best target antigen? Whether there's the potential for contaminating clones that may transform and lead to cancer derived from the CAR T has been reported. And then, although the currently available products are all autologous, there are some allogeneic products under development which have some number of potential advantages. All right, so let's now turn to the other aspect of my talk, the other side of the coin. So CAR T are effector cells. Their job is to kill target cells. And then the other side of the immune system are the regulatory mechanisms which serve to downregulate immune function. Regulatory T cells are recognized as being antigen-specific cells that are traffic and activated in an antigen-specific manner, and then down-regulate immune function via a variety of antigen non-specific mechanisms. There also is some evidence that regulatory T cells may play a role in promoting tissue repair. So there have been a number of regulatory T cell products that have been investigated. Most of the studies initially were with polyclonal Tregs isolated from the peripheral blood and then expanded in culture and then administered back to the patient. Also in transplant, Tregs have been generated by isolating antigen-presenting cells from the graft donor and then administering them to the graft recipient to try to generate alloreactive T regulatory cells. But the regulatory T cells that are now getting the most attention are engineered antigen-specific T regulatory cells that are isolated from the patient, then bioengineered for a particular antigen specificity with a particular MHC restriction, expanded in culture, adapted to have a regulatory phenotype, and then administered back to the patient. So what's the rationale for T regulatory cell transplantation in MS? Well, first of all, there are a number of genetic diseases where there's a Treg deficiency which are associated with hereditary autoimmune diseases. There have been a large number of studies over the years implicating impaired Treg function as playing a role in MS immune pathogenesis. There have been a number of studies that have shown that T regulatory cell transplantation is effective in the animal model, an animal model of MS, EAE. Treg transplantation has been effective in a number of other diseases, particularly graft versus host disease, a very difficult complication of allogeneic hematopoietic stem cell transplantation. And also in liver transplantation, Treg transplantation has been shown to allow the withdrawal of chronic immune suppression. And then finally, there have been a couple of studies that have shown that following transplantation, T regulatory cells can be detected for long periods of time, up to a couple of years after transplantation. So they at least potentially could be a long-term therapy for an autoimmune disease. Treg transplantation has been explored in a number of conditions, some of which are listed here. And there also are a number of Treg products that are under development for autoimmune diseases, including as highlighted here for multiple sclerosis. So just to briefly describe this product, so this is a Treg product being developed by Abata. It's the antigen specificity is against myelin basic protein, possibly because that's a putative autoantigen in multiple sclerosis, but more importantly because it's a key antigen within the central nervous system to guide targeting of the Tregs into the central nervous system. And the artificial T cell receptor is engineered to recognize MBP in the context of HLA-DR 1501, one of the main risk factors for multiple sclerosis. That's then introduced into autologous lymphocytes from the patient that are then culture propagated to generate a regulatory T cell phenotype, and then they're administered back into the patient. So why engineer the cells in this way? Well, as I said, HLA-DR1501 is one of the key risk factors for MS. It's present in about 60% of people with MS. And the interaction of myelin basic protein with HLA-DR1501 has been well characterized. Why myelin basic protein, this particular fragment? Well, possibly because it's an autoantigen, but more importantly, it's an immunodominant epitope, and at least it will function to stimulate trafficking into the central nervous system. So the structure of the ongoing ABATA phase 1 study is similar to what I showed you. It's a small dose escalation study with dose finding and then a provision for expansion of what seems to be the optimal dose. So to wind up, there are a number of immune-targeted cell-based therapies for MS under investigation. I highlighted two of those, CAR-T and Treg. This is a very rapidly evolving field. The technology for CAR-T in particular is evolving quite quickly. There's potential advantages, a single or maybe an occasional administration, and with deep tissue depletion. The efficacy and the safety relative to our available DMTs is still not clear. And then there's a whole other category of cell-based therapies to promote repair, which are under development in parallel. So I will finish there, and thank you for your attention. So.
Continuing from Cleveland Clinic, we'll have Dan Antonato. He's going to discuss something entirely different but highly important, and that is symptom management.
Thanks so much, Fred, and also thanks for the academic CME organizers for this great morning so far and early afternoon. I know I personally really like this meeting. I always feel like I come away that I've learned something new about multiple sclerosis, and hopefully you guys have too. And now we're going to be changing gears a little bit to talk about multiple sclerosis symptom management. These are my disclosures. None of them are particularly relevant to the topics I'm going to discuss today. And we've spent a lot of time, one, establishing the diagnosis of MS, second, talking about disease-modifying therapies. The majority of the morning and early afternoon actually have been spent on DMT treatments. How do we modify the disease itself? But I think equally important to our practices, and especially for people with MS, is treating the underlying symptoms of multiple sclerosis. And probably the majority of the time that we spend in clinic, we actually spend talking to patients about their symptoms and thinking about how to address them. And I would say that although many times we see patients who we think are doing relatively well, it is rare for me to encounter even individuals who are treated with a high efficacy medication relatively early in their disease that don't have some aspect of symptom management that has to be addressed. And I think it's really important to have open discussions with patients about this. And many times it's good to just sit and listen to the patient. What is the story that they have to tell? With DMTs, many times we're thinking, when is your next MRI? When do I have to change a disease-modifying treatment? And it's very much driven by us. Versus symptom management, I think, should be really driven by the person with MS themselves. First, I'm going to discuss a couple of principles of symptomatic care. And these will kind of frame the discussion. Symptomatic care for multiple sclerosis, we could take probably the whole day to talk about each individual topic in depth. So that's going to be hard to do. But what I'm going to try to do is, one, address kind of what are the general principles we have for symptomatic care, and then talk about perhaps the most frequent symptoms and specific targeted interventions that we have for these. So it's not untrue to say that symptom management is an important and ongoing aspect of MS care that has to be brought up at every single patient visit. And importantly, one has to inquire about troublesome symptoms. All of you will recognize some patients who are very open and discuss all their symptoms with you. I think the more challenging cases are the individuals who say, everything's fine, doc, nothing to talk about. I think it requires some specific art to pull out, well, are there stuff that we can actually help with? It's important to consider what additional factors we can eliminate to improve patient symptoms. And I think it's important to also prioritize. I learned symptom care from a nurse practitioner who worked with me. I say probably I worked for the nurse practitioner at the Mellon Center. Her name was Marie Namey. She was one of the pioneers of MS nursing, and just seeing patients with her gave me this idea of things that you have to do with symptom care. One, prioritize. What are the top 3 symptoms that we need addressed at this visit? 2, use monotherapy when possible, 1 medication at a time. And also, when we're using medications, think about medications that can address more than 1 symptom at a time, because these have to be synergistic. Keep an eye on the length of patients' medication lists, because you want to minimize that as much as possible. And unless the symptom control is an urgent issue, I think it's generally good to start low and go slow with the interventions we have, and remember to just change one intervention 1 at a time. Otherwise, if you start 2 symptomatic medications concomitantly, you're going to be riling with what side effect is associated with what medication. Remember that the ultimate goal is to improve overall function and quality of life, and not just alleviate an examination finding that you might be addressing on the exam. So what symptoms need to be addressed? This is a very old study, but I think it's a relevant study, and it was a survey of 656 individuals with multiple sclerosis, and asked what are symptoms that affect your activities of daily living. And not unsurprisingly, something that we've seen in study over and over again, fatigue is the #1 issue, followed by balance, weakness, bladder, and spasticity. And in line with those, I am going to be addressing these most common symptoms with multiple sclerosis. But remember that there is also kind of what we call hidden or silent symptoms of multiple sclerosis. And these are not apparent on the neurological exam. And perhaps patients don't complain about these as much, and it's kind of our job to inquire about them. Cognitive impairment, fatigue, anxiety, depression, sleep disorders. And notice in this figure that these are present across all stages of multiple sclerosis. One important thing to do in the clinic is how to measure or how to address these symptomatic issues. I think if you have quantitative, objective measures that you're measuring in each clinical visit, it will make your job of symptom management much easier. Specifically at the Mellon Center, we use something called NeuroQual. This is an NIH-based tool that's been validated in multiple sclerosis, and basically can be used with computer adaptive testing and covers physical health, mental health, and finally social health. All of these, I think, you can target and you can actually follow over time. Remember that there is kind of next generation tools to measure MS, and many of these will hinge on patient symptoms, but this includes experience sampling, specifically patient-reported outcomes, and then active tests that we ask individuals to do that might cover cognition, upper extremity function, lower extremity function, and gait. And then finally, passive monitoring. That is, using the devices that we use on a daily basis, such as our phones or, for example, our smartwatches, and taking gait data, taking posture data from those. And these will be incorporated into clinical practice more and more, and there are additional tools for clinicians to address symptoms. And then the question is, who is in charge of symptomatic care? We have to remember that this is, by default, going to be an interdisciplinary type of intervention. That is, as a neurologist, you're not going to be able to manage patient symptoms on your own. It is team-based, it is multifaceted. There's medical care, including physicians, advanced practice providers. There's rehabilitative care, including PM&R physicians, physical therapists, occupational therapists, health psychologists and psychiatrists, neuropsychology, social work, and then collaborations with other services, for example, such as urology when there are bladder issues, or gastroenterology when there's GI issues. And remember that probably what's important here is that as neurologists, we are the natural quarterback We're the natural leaders that are meeting with the patients on a regular basis and deciding what type of care a patient needs. And true multidisciplinary care involves real good communication between neurologists and all these other services. Remember that access is not a given. Individuals might have mobility access, might have financial access issues. So these are all things that one has to consider when one is thinking about symptomatic care. And then finally, education, I think, is important with symptomatic care. You're educating people with MS, you're educating the caregivers, family members, you're actually also educating other care providers, and you're also educating trainees to have better symptom management over time. Let's start off with our perhaps most common symptom in multiple sclerosis, which is fatigue. This fatigue can be related specifically to deconditioning, but remember there's also handicap fatigue. That is, an individual with a fixed motor deficit will require more energy or more effort to complete an activity of daily life than if they did not have that handicap or that fixed deficit. There's also neurophysiological fatigue that sometimes we kind of break down into motor fatigue, which is decrement of motor performance with sustained effort. There's also heat-related intolerance, which is worsening of symptoms and the exposure to heat. And this might be related to subclinical conduction block and might be combined with abnormal temperature regulations that many of our patients have. Remember that some fatigue may also be related to neuroplasticity and the effects analogous to what we see in post-polio syndrome, that is an energetic defect in axons. And then the systemic fatigue that we kind of think more as persistent lassitude or general asthenia, which may be related to CNS effects of active inflammation. This is not uncommon to see in individuals who have gadolinium-enhancing lesions. They have this general fatigue that many times with treatment with steroids and assumption of a DMT, many times gets better. How do we measure fatigue? Well, there's several validated scales to measure fatigue, and these are used in common practice, both in clinical trials and also to an extent in clinical practice as well. The fatigue severity scale, the modified fatigue inventory scale or impact scale, MFIS, which is probably the most common one used, and then the neurological fatigue index. And you can see that internal consistencies and retest reliability are relatively high, not being perfect, but these are tests that take minutes to do and actually can give you a very objective answer on how much fatigue a patient might have. So I think the first step we take when addressing fatigue in people with MS is one, to ensure that there's no concomitant issues that need optimization prior to considering that the fatigue might be purely related to multiple sclerosis. And this is true both for patients with MS, but also in general when evaluating fatigue. Sleep, screening for insomnia and obstructive sleep apnea using validated scales is worthwhile. Screening for depression, of course, is important. And then finally, metabolic or general health abnormalities that might be related with fatigue, vitamin deficiencies, thyroid abnormalities, and anemia. I cannot state how important these are to do on a daily basis with a patient, because missing one of these actually can have really important consequences. A little bit about heat management and exercise. I talked about this a little bit already, but heat-related increase in symptoms generally is self-limited, but can be disruptive. So patients always ask us, is it okay for me to exercise? And the response is always yes, it's okay for you to exercise, but understand that you want to limit activities, for example, in hot environments, especially when there's a significant lag in the improvement. So if a person is exposed to heat and is doing some exercise and doesn't recover for another 24 to 72 hours, you might consider things to do to make that exercise better tolerated. Air conditioning, cooling vests, cool baths or shower, and finally aspirin has also been used. Remember that we do not give our patients the message that they should not exercise. Exercise is an extremely useful intervention, actually. 45 trials have studied this, 69 different exercise intervention. And these types of exercising has, across clinical trials, showed beneficial effects in patient-reported outcomes and also objective measurements. And this includes muscular conditioning, cardiovascular conditioning, production of immunomodulatory factors, neurotrophic factors, and even remyelination itself. So let's go into medication management of fatigue, and I'm going to present these medications in the order in which I typically use them. So if I've exhausted all the options for non-pharmacological treatment of fatigue, I've ruled out other conditions, Typically, the first medication that I'm going to move to is a medication called amantadine. Amantadine has been shown to be effective in randomized double-blind placebo-controlled trials. This medication is an antiviral that is a dopamine agonist and also has anti-glutamate properties. Remember, this was identified by a physician who had multiple sclerosis, who identified that when he had the flu, he felt better. Retrospectively, then, the antiviral was known to have these dopamine agonist effects. About a third of patients show a mild to moderate fatigue improvement in the short term, so it's not a huge amount of patients, but a third is not bad. The dosages we typically use as 100 milligrams twice a day. Sometimes a drug holiday can be useful for 2 days or up to a week, and that can prolong effects of the medication. And common side effects include nausea, lightheadedness, insomnia, confusion, hallucinations, dry mouth. Something particular to note is livetta reticularis. This is the rash that is actually shown in the picture there. It's important because you have to warn patients about this, because if you do not warn patients and they continue to have livetta reticularis, sometimes that can be irreversible. So important to remind patients that this is a possible side effect and discontinue the medication if they notice skin changes. Medication management 2, this is a group of CNS stimulants that are approved for narcolepsy, excessive daytime sleepiness. The 2 medications that we are talking about is modafinil and armodafinil. One is a slightly longer acting form, and that's armodafinil. These medications work by disrupting dopamine transporters and increasing the availability of dopamine. The medications do have some side effects, including headache, nausea, anorexia, constipation, and then these do give the patients a sensation of being slightly revved up. This is why I typically start with amantadine over these medications. Adverse reactions include hypersensitivity. Some patients affect the quick on effect that modafinil has, and other patients prefer this kind of more gradual, sustained effects that the armodafinil has. And of course, medication holiday can be used for these therapies. Medication management number 3 is methylphenidate, which is another CNS stimulant, norepinephrine uptake inhibitor. Approved indications include ADHD, narcolepsy, and daytime somnolence. We can use immediate release forms or ER tabs, 5 to 15 milligrams twice a day or 3 times a day, and for the ER tabs, 10 to 20 milligrams once a day or twice a day. These medications are DEA Schedule II due to dependency and abuse potential. Side effects includes that same nervousness, irritability, a little bit of anorexia, weight loss, cardia. So a little bit more with these medications, and that's why I typically reserve them to the end if I ever use them. Adverse reactions, one has to caution about psychiatric manifestations, including psychosis, mania, and aggressive behavior, which we typically don't see with the other medications, and that also makes it a medication that is slightly used less. And well, how do these medications stack up against each other? And we have really good clinical trials that have studied these medications in combination. This is the first study that I'm going to discuss, which was a study that was published by Bardia and Norbach in Lancet Neurology 2021. It was a randomized, double-blind, crossover, 4-sequence, multi-center trial. A very complex study, 141 patients. They were treated for a total of 6 weeks, separated by 2 weeks, and they were actually randomized to different sequences of these 4 different treatments: amantadine, modafinil, methylphenidate, so the 3 medication groups that we talked about, and placebo. Interestingly, there was no real benefit on the primary outcome, MFIS, or secondary outcome measures between the different groups. Amantadine, modafinil, and methylphenidate were not superior to placebo, indicating there was a strong placebo effect in improving MS-related fatigue and caused more frequent adverse events. A lot of us saw these results and said, well, is it worth even using these medications? And the reality is that in a patient who has severe fatigue, you're going to try some of these medications. And even if there is somewhat of a placebo effect, that was still a positive effect and might help. A second study that was just published this year in 2024 is a study called Combo MS. This was a multi-center randomized clinical trial that was funded by the Patient-Centered Outcomes Research Institute and conducted by Dr. Tiffany Braley at the University of Michigan. This study basically studied 3 arms: cognitive behavioral therapy specifically for fatigue, 103 patients, modafinil only 107 patients, and then a combination of modafinil and cognitive behavioral therapy. The outcome was 12-week MFIS, and as you can see in the figure, at 12 weeks, there was a statistically significant reduction in modified fatigue impact scale scores, that was sustained also at 24 weeks. Interestingly, there was no augmentation when one looked at the combination. That is, modafinil on its own was not better than modafinil plus cognitive behavioral therapy, suggesting that perhaps these medications could be used in isolation just as well as in combination. Interestingly, sleep hygiene was an effect modifier. The worse sleep hygiene patients had, if they didn't have good sleep hygiene, there was, of course, a stronger effect of cognitive behavioral therapy. If they had relatively good sleep hygiene, it was pretty clear that the patients responded better to modafinil. So one could potentially use that as a discriminator when trying to select which therapy to use with these patients. Next, let's move on to spasticity, which is a common occurrence in patients with pyramidal weakness. Once again, survey studies demonstrate that between 70 and 85% of patients do have spasticity, and the goal of treatment with spasticity is to improve mobility, improve sleep, decrease pain, and facilitate hygiene. But remember that many patients do use the spasticity that they have to assist them with gait, and therefore excessively treating spasticity sometimes can result in decreased quality of gait, something that has to be considered. It's important to measure spasticity, and I think when I started my fellowship, I had rarely, if any time, actually examined spasticity. In neurology residency, they teach us really well to examine motor power, but spasticity almost hardly at all. There's the Ashworth scale and modified Ashworth scale, which is a scale from 0, no increase in tone, all the way down to a 4, which is a limb rigid inflection or extension. And I would encourage you to examine your patients using the Ashworth scale. It does require some practice to get your numbers to be correct, but use it in clinical practice because it's useful to follow over time. General approaches for spasticity: prompt referral to physical therapy. Why? Because physical therapy rarely has any significant side effects. Remove other concomitant medical issues which may increase, including infections or concomitant medical conditions. Stretching is the basis of treatment for spasticity, especially early in the disease, but also later. The importance of stretching cannot be understated. Typically, it's best if it's done directed by a physical therapist, specifically targeting specific muscle groups. And here, frequency and consistency with stretching is really important. Remember that spasticity treatment may also have beneficial effects in gait stability as well, especially when it's related to stretching. And exhaust non-pharmacological approaches first, given the side effects, including weakness. As I said, some patients rely on their spasticity for gait. If pharmacological therapies are needed, of course, try with a monotherapy first, but many times in patients with severe spasticity, we have to use combination therapy. And then finally, for the most intense cases, surgical or interventional approaches are warranted. We will talk really quickly about these medications. Baclofen is the first one, which is a GABA-B agonist. It is active in the spinal cord at the presynaptic inhibition, and therefore it is ideal for treatment of MS-related spasticity, as hitting spasticity where it originates in multiple sclerosis. Typically, we start with a low dose, anywhere between 5, either HS or BID, up to TID. 10 milligrams TID is a more standard dose, and you can adjust this as needed up to 30 to 80 milligrams per day. Overall, it has low CNS penetrance, and therefore relatively high doses of this have to be used. Side effects are CNS side effects: fatigue, somnolence, dizziness, GI distress, increased pre-existing weakness, ataxia, imbalance, and bladder dysfunction. At very high doses, it also can produce hypotension, so one has to also monitor blood pressure. And then remember that PM dosing can help significantly when one is trying to address just night spasticity or spasticity upon awakening. Second medication is typically a medication that we add in if you are at a relatively high dose of baclofen and have not gotten adequate response to treatment. Tizanidine is an alpha-2 adrenergic agonist. Once again, we start low, approximately 2 milligrams HS, and can titrate up to anywhere from 6 to 36 milligrams per day, divided every 8 hours or every 4 hours. Side effects include dry mouth and sedation, dizziness, orthostatic hypotension, similar to baclofen, so one has to watch for that, elevated transaminations and hallucinations. It does require monitoring of CBC and LFTs, and remember this can accentuate weakness and ataxia less than baclofen, and therefore it sometimes is a useful adjunct to those therapies when the weakness is actually interfering with gait. It may also help with back pain. It can also help with headache, RSD, and neuropathic pain, so keep that in mind. Finally, some other medication management for spasticities that we sometimes use, benzodiazepines, of course, facilitate GABA, and therefore they have powerful effects. However, sedation really is dose limiting, and therefore we use this, I would say, relatively infrequently. If you're going to use it, preferably with a long-acting medication such as diazepam. Gabapentin, a GABA agonist, can also be used for its relaxation effects. Typically, in order to get an effective relaxation for gabapentin, you have to typically target relatively higher doses. Ideal scenario when to use this, when a person has concomitant neuropathic pain, including paresthesias or other pain components. Dantrolene is a medication that depresses excitation and contraction, specifically at the muscle level. The big problem with dantrolene is that it produces a significant amount of weakness, which is sometimes difficult to use. It's not a medication that I use very frequently. Finally, cannabinoids are therapies that are approved to treat spasticity in Europe. We do not have an FDA-approved medication in the United States, but CB2 effects can decrease spasticity, may help with pain, tremor, and ataxia. Sometimes when you see in a medical chart that they have treatment strategy for their spasticity management, that's code for recreational marijuana use also to treat spasticity, which I think is valid. And then we can also do specific interventions. Botulinum toxin is an effective treatment. Why? Because there is very little systemic side effects from this. And one can target very specific muscle groups. And I think one of the mistakes we make as neurologists is to think that Botox should be a treatment that we should reserve for very severe spasticity, and that's not the case. Even in relatively early cases of spasticity, early referral to physical medicine and rehabilitation, you can get really good effects with Botox with very few systemic side effects, which is good. Problems are you have to repeat this treatment every 3 months, which makes it a little bit difficult, and sometimes it can be painful. Sometimes insurances have a little bit of difficulty approving that. Intrathecal baclofen, of course, takes advantage of administering baclofen in very small doses and therefore decreasing the systemic side effects or the CNS sedation side effects. However, it does require a surgical procedure. This is best used because it has very dramatic effects on spasticity in individuals who typically no longer are walking, individuals who have gait impairment, wheelchair-bound patients. This is an ideal treatment. It does require a pump to be placed and that pump to be refilled, and that has some problems with MRI if it's not an MR-compatible device, so that has to be taken into consideration. Infection can occur as a side effect, and I think an evaluation for whether a patient is a candidate for this has to be done. Watch for withdrawal and overdose because they can be life-threatening and patients will need ICU care if that is the case. Bladder dysfunction in MS is one of the other things that we should focus on. Remember that these can occur as an effect of impaired storage with detrusor hyperreflexia, which is a spastic or overactive bladder, impaired emptying, which ranges from a little bit of hesitancy to slow stream to actual retention, and then detrusor hyperreflexia, which is the opposite, a flaccid bladder, opposite to a spastic bladder. And then finally, outlet obstruction that can be structural or related to detrusor sphincter dyssynergia. Then a combination of these often evolve to detrusor hyperreactivity and outlet obstruction, which is the final pathway for bladder dysfunction in MS. Know that there has to be a balance between detrusor contraction and sphincter contraction, then sphincter relaxation, and then finally external sphincter contraction for there to be this regular cadence of micturition. And how things are effective depending on where lesions are located. Of course, suprapontine lesions will have primarily a hyperactive detrusor versus spinal lesions will typically have an overactive detrusor with also overactive sphincteric responses. So something to consider. Bladder treatment, keep it simple at the beginning. Scheduled voiding, distraction strategies for individuals who have frequency, Kegel exercise. Avoid irritants. All the coffee that we've had during the morning and the afternoon, you should avoid that. And restriction of fluids. DDAVP can be used at night to decrease the need for frequent awakenings for bathroom use. Manage constipation, which can also decrease the sensation of frequency and outlet obstruction. Weight loss and then smoking cessation, of course, is important. Hyperactivity can be treated with anticholinergics. Oxybutynin is the most common of these. If there is impaired emptying, one can use intravesical pressure with a Valsalva maneuver. Cholinergic agonists, such as butanol, can be used. Catheterization, either intermittent versus chronic when there's impaired emptying. And then finally, when it is quite severe, urinary diversion is important. If there's outlet obstruction, alpha adrenergic agents can be used similar to how we use them in prostatic hypertrophy, intermittent cath, and then finally, deviation is all. Then interventions can also be used. Intradetrusor Botox or sacral neuromodulation are therapies that are typically done by our urology colleagues and should be considered in individuals. And then finally, these tables of other symptomatic approaches are going to be in the slides for you to review, but just remember that for mobility issues, rehabilitation, and pharmacological agents are available, such as formiminopiridine and dalfampridine. Depression and mood disorders, of course, benefit from psychology and also pharmacological therapies. We have specific treatments for pseudobulbar affect. And then for pain, don't forget the importance of psychology in management of chronic pain with MS patients, and then cognitive rehabilitation for those who have cognitive dysfunction. In conclusion, if I can go back, assess symptoms at every visit, talk to your patients and try to extract what is bothering them, target the symptoms that are most common and where you have interventions, embrace the multidisciplinary approach, prioritize the most bothersome symptoms, and try to address 1 to 2 of these at a time. Have a system and approach to each symptomatic issue. Make it methodical and go through your approach in every patient. Prioritize interventions that affect more than one symptoms, monitor effectiveness in treatment, and always try non-pharmacological approaches first. Avoid polypharmacy, and at all costs, avoid narcotics. Thank you very much for your attention.
Thank you, Daniel. Okay, we're going to take a break, but I'm going to ask you to cut it short to 15 minutes so we can get close to schedule again. So we'll restart at 20 minutes to 4. Thanks. How are you? I'm going to wait a couple seconds here. How you been?
Hello. We keeping a 30 or 45 for this one? Clock says 30.
Yeah,
I'll try to keep it moving along.
Yeah, this one's 30.
Is it 30?
30, yeah.
Okay.
Keep in mind that anytime during this talk, the Doge people might come and want to know how much.
Every other slide.
Might want to know how much your income comes from this because they're going to cut it.
Okay.
If they let you give the talk at all. So if the sound
As
goes
long
off.
as I give the top 5 things that I did this week, I think it'll be okay.
Yeah, well, only if you justify it. Okay, we're going to move along. Next, we'll have a discussion from Dr. Naismith from Washington University on healthcare disparity. Welcome, Bob.
Thanks, Fred. Hi, everybody. Great to be here. I look forward to doing this talk. This is a topic near to my heart for several reasons. One is many moons ago, as a young resident, I made an observation that Black Americans with MS who were hospitalized for steroids when I was on service seemed to have a worse prognosis. This was neither a unique or a subtle observation, and it was one that many other people made across the United States, but it sort of spawned my mentor, Ann Cross, to nurture a research project looking at prognosis and outcomes in Black Americans with multiple sclerosis. And we had found that ataxia and ambulation issues were a major problem. And as we'll get into with this discussion, many other groups across the United States have had similar observations and similar findings. Number two, it lets me kind of review the literature to see what's come up in the past year with health disparities. And number three, it just reminds me, and for me to remind you, that we have tremendous power in our practice to really help individual patients and to gather a team around us to improve patient care. So whenever I hear about a study that had something that can be improved upon, I try to translate this into my practice. So, for example, if you read in a study that Black American MS patients do not get as many ultrasounds in their early pregnancy care, I always make it a point in my practice to think counseling patients of childbearing potential about pregnancy and making sure that they're going to see their obstetricians and gynecologists in preparation for that and making sure that they have the follow-through with whomever's going to give them that care. So the notion is you take these studies and you think about, like, how can I sort of assemble a team or create some counseling or change my practice to make it better for the people that I see. Okay, so I use this thing. Okay, got it. All right, disclosures. And this all sounds, quite new, and there's been a lot of research over the last handful of years, but this goes back for a long time. For over 60 years, this whole concept of social determinants of health was sort of born out of the 60s, where Richard Wilkinson looked in Great Britain in the Whitehall Civil Service Studies and found that, among men who were in the civil service, based upon their titles and, surveys, that sort of lifestyle factors were a big determinant in terms of their health, and that also sort of this idea of locus of control, responsibility, and the stress response was determined to be a big factor. So this was sort of the birth of this whole concept of treating the whole patient and making sure that you take care of the social factors to get healthier people. And even like when I was a resident or a medical student many years ago at Case Western, they really prided themselves on social determinants of health and really making this a big factor in their educational endeavors and in their training in the clinics as well. So this has been an ongoing battle to make sure that everybody has great health care for at least the last 60 years and probably even longer than that. So It's very relevant now, but it's been relevant for a very long time too. And we all take the Hippocratic Oath, and I think essentially we need to make sure that we're providing the best care to all of our patients and thinking creatively about how we can do better for certain people who may not have the best support systems or access. And it's just interesting sort of how the oath has changed over the years from the old one to the new one that was crafted in the 60s. But the old oath was, into whatsoever houses I enter, I will enter to help the sick, and I will abstain from all intentional wrongdoing and harm. So the old oath more so spoke to, paying homage to the Greek gods of medicine, your teachers, and doing no harm, whereas the newer one in the 60s was, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. My responsibility includes these related problems. If I'm to adequately care for the sick, I will prevent disease whenever I can, for prevention is preferable to a cure. Or remember that I remain a member of society with special obligations to all my fellow human beings, those sound of mind and body, as well as the infirm. So I think this speaks to our special abilities and relationship and calling to do whatever we can to treat the patient to the best of our abilities and meet them sort of where their needs may lie. So those that have attended this in past years, I've presented this case, and I have a little bit of follow-up and maybe a question in terms of what to do at this stage, but this is a young Black American woman that I met many years ago when I was attending in the resident clinic. I don't attend there very long, but I was kind of of the mind that, I'm going to take this person out of the resident clinic, put them on natalizumab, and she's going to do wonderfully, because we kind of got her at a very early stage of the disease. But, here's someone with a very complex social history with, she's 39, she's got 5 children, 5 grandchildren, she's widowed, she was on Medicaid, got Medicare in 2014, diagnosed with MS in 2006, was on Tisabri with, pretty regular follow-up 2007 to 2014. But in 2014, she developed HIV with very intermittent follow-up, so I was forced to stop the Tisabri and switch her to an interferon. And I think at one point she was on glatiramer as well. And she underwent a number of additional stresses with her fiance dying in 2020, and she stopped taking her antiretroviral therapy with her HIV viral load going up. And we basically had to have her on Plegridy, to which she remains on to today, and she's ambulating with a walker. But in 2023, she started to get back on her treatment with good compliance, and her CD4 was 94, and HIV it was undetectable. And now she's remained therapeutic on her HIV meds, but her CD4 count's still quite low. So if anyone has any suggestions as to how to navigate someone who's been HIV undetectable for the past year, but still with a very suppressed CD4 count, I'd like to hear your thoughts on what other options that she might have aside from interference to try to treat her MS more optimally. So as I was saying, this observation that Black Americans with MS do worse than white Americans has been a very consistent finding throughout the 2000s, with many studies all across the United States, from New York to Missouri to California and everywhere in between, basically showing very similar effects. One, that the time to diagnose Black Americans with MS tends to be shorter and at a younger age. 2, that they have more disability and the progression of disease occurs more rapidly. 3, they have more inflammatory disease and tissue injury as manifested as MRI lesions, T2 lesion burden, GAD-enhancing lesions, retinal nerve fiber layer changes, and that this is consistent across adults and pediatric cases. And there's a lot of good consistency among all these studies to show that this is a very reliable finding about all these features. And I guess the question arises, like, what do we think is the cause for all this? Is it because this is a cohort of patients that are being seen by academic medical centers, or is MS worse in Black Americans? And I think it's a combination. I think that there's likely patients with more mild MS that may not have access to health care. But I also think that there's something that's more highly inflammatory in Black Americans with MS. And that's just based upon sort of my practice over the last couple decades. If I think about the patients that have had 20, 30, 40, 50, 60 GAD-enhancing lesions on their brain scans, they tend to be more Black Americans with multiple sclerosis in my experience. So I think there is something still to it that despite there being perhaps some disparity in some of these studies in terms of who is the representative sample, I also think when you're looking at sort of the worst cases of multiple sclerosis, there seems to be something very inflammatory about some individual patients and the way they manifest it with their MS. And the way this is sort of translated in practice is there is there has been and continues to be a great push for highly effective therapies in these in any patients that have high inflammatory lesion burden. So I think the studies have also shown that the uptake of monoclonal antibodies in Black Americans with MS has been very high. So I think the notion of highly inflammatory disease in this group has been noted, and I think that the therapeutic intervention by and large has been applied based upon a lot of this work that's been done by many investigators in this room and on the slide. Getting to see a neurologist is continuing to be a big issue for many people. In this, do I have a pointer? Okay, yeah. This is looking at any neurologic disease by specific diagnosis in this study that was done. This is almost 20 years now, but for example, Parkinson's disease, about 56% of patients, multiple sclerosis, 72% of patients, epilepsy, 38% of patients. That said, I mean, it's low for anybody with any of these conditions, but it's particularly low for Black and Hispanic Americans. They're about 30 to 40% less likely to see a neurologist for their neurologic conditions when looked at within different epidemiologic surveys and studies. And this is also confirming that, quite similar to the prior slide, that 72% of patients saw a neurologist for their multiple sclerosis care, about 20% in the PCP, and that this was lower in those without health insurance who were poor, rural, Black Americans, ill for more than 15 years, difficulty walking, requiring a wheelchair or scooter, or confined to bed. And we know, as I'm preaching to the choir, that seeing a neurologist and an MS specialist is going to be much better for their care because we're going to be really in keeping with the monitoring for their disease and their treatments, making sure they're on the best therapy that they need to be on, and we're going to use all the multidisciplinary care and all the tools with the symptoms that Dan was telling us about in the prior lecture. So we're just going to be much more effective at treating all the issues of their MS and making sure they're getting the best care. And this is a more recent study looking at telehealth, since that was a more recent development in the past couple of years. And again, this is lower for older individuals, Black Americans, Hispanic Americans, those who are in government insurance, non-English speaking. So again, even with telehealth, perhaps opening up some avenues for people to get some neurologic care, there seems to be some disparities in the patients that are receiving this. So this is a paper that was in JAMA Neurology 2021. I thought they had some good definitions here that we can kind of take with us. Health disparities are negative differences in health that are associated with social, economic, and environmental disadvantages. Inequities are differences in access to or availability of faculties and services that are considered modifiable and associated with social advantage. And social determinants of health are conditions in which people are born, grow, live, work, and age that are adversely affect health. And I guess the question is, how can we set up our practices and our teams to help with as many of these things as we can, while also trying to balance all the varieties of work and all the things that are going on in our homes as well. One of the things that has become apparent, perhaps in more recent years, because before the 2000s, many of the papers about Black Americans with multiple sclerosis were basically saying, like, this is rare. But in fact, it's not. And this study demonstrated that the prevalence in this epidemiologic survey was that the prevalence was pretty much equal in Black Americans and white Americans. For Black Americans, 226 per 100,000, and for white Americans, 238 8 per 100,000. So this notion that this is less common, I don't think is held up by some of these epidemiologic endeavors, and it's also not what we see in our own practice, because we have a very large proportion of Black Americans with MS that we see at Washington University in St. Louis. This is a paper looking at, addressing sort of decreased access among adults with multiple sclerosis, and they found that decreased access was found for men, older age groups, lower socioeconomic groups, those that are less educated, non-white, those with underlying mental health problems, and those coming from rural areas. I think this issue of rural areas touches a lot of us because we have, if we're at an academic medical center, we have a large catchment area. And like some of my patients come 3, 4, 5 hours away, so they're coming from rural Illinois, rural Missouri, and these patients have some issues with access and transportation and cost of gas and family being able to bring them. So that's certainly an area that we're all experiencing if we're at an academic center that is kind of in the middle of the country or have large catchment areas. This was a study looking at disparities by regions, and here at the bottom you can see that access was lower in rural areas, small towns, those that had a high proportion of Hispanic individuals, among men, the uninsured, individuals with hearing, vision, and ambulatory difficulties. And access was higher basically in cities, places where there are Black Americans, college degree holders, individuals with computers, individuals without a vehicle, those with cognitive difficulty, limited English, and children. So to me, this more is in line with the cities where the medical centers are located. This is a study looking in Canada about urban versus rural, based upon socioeconomic status compiled by zip code and census data, and they found that the rural areas had a less likely chance to be on disease-modifying therapies, and that a lot of this was attributable to disparities in socioeconomic status by zip code. The good news is, well, partly the good news. The bad news is they were less likely to be on high-efficacy therapies, but for those on high-efficacy therapies, it wasn't attributable to socioeconomic status. So if you're in a rural area, you're less likely to be on a DMT, less likely to be on a highly effective DMT, but if you're on a highly effective DMT, it's less likely to be due. It's likely to be due to being in a rural area, not due to your socioeconomic status so much. Perhaps that just speaks to sort of our willingness to use these high-efficacy therapies and those that we think are going to require them. And luckily, that's really kind of transformed our MS care in the last 10 years or so. This is a focus group. This came out in 2021. It's just interesting to hear some of the comments from these 19 Black women with multiple sclerosis. Not to say that this is how all people are going to think, but just gives you the context in the way you need to sort of educate people about the disease and the treatments, and making sure that they ask for help in terms of family members. But some of the things here I think are illustrative, perhaps, of some cultural differences or some notions that are just good to understand. So no one could believe I had MS. One person described MS as white people's disease. You just explain it away, especially as a Black woman. We're just used to doing above and beyond where we need to do it, so that's what I did. That Black female thing of just push through it all. Friends, often nurses and family, played important roles in convincing these women to seek professional care and take care of themselves and help navigate this complex healthcare system that we have, even when they're dismissed by healthcare providers. One person related the difficulty of asking other people for help, and one person noted that a lot of Black Americans think you can go to church and pray this away. They mean well. People tell me that you have enough faith in God and you could just not. So I think there may be some ideas that this is less common in Black men and women, but as we saw by that study in California, that's definitely not the case. Here's some additional comments from that focus group, which I think speak to sort of the common concerns that everybody has with this disease, and the types of things that we're very well equipped to address with our education and our listening skills. Greatest challenges include fatigue, cognition, ability to focus, the non-visible symptoms, being perceived as not sick or lazy, every day is different, feeling frustrated, mad at themselves, fearful for getting worse. These are things that I hear from all my patients regardless of where they're coming from. Independence, concern to maintain dignity and not get stressed out about everything, limited spontaneity. The family seems to minimize their symptoms and experience. They feel like they're faking it. Fighting to stay employed, access to care, difficulty finding a good neurologist who understands MS, changes in insurance plans, trouble fitting appointments in the work schedule. So I think that these are all things that we can address among all of our patients, and it's just a matter of setting up that relationship, talking with people, educating them, and listening to the symptoms and letting them know that these are just very common things that patients experience. We'll try to help wherever we can. We're a big clinical trial center. We have a lot of studies going on. We would love to have a diverse group of people in our studies. I think there are some challenges to getting Black Americans in clinical trials. We would certainly love that to happen. And I think this is a study that came out a few years ago, asking people about their perceptions and preferences in relation to research. And some of the Black patients with multiple sclerosis noted that they're less likely to agree that medical research has led to better MS treatments, less likely to trust information from a university, more likely to trust from newspapers or magazines or other people with MS, more concerned about their personal information being released, more concerned about being used or taken advantage by the research team, and concerned about receiving poor quality medical care. So I think that this speaks to the need to establish that relationship and to have that educational component so you build that trust around shared goals for health. And the good things in this study is that there's no difference in willingness to participate in a drug treatment trial, and particularly for non-drug treatments like exercise or diet, lab imaging studies or surveys, and there was no difference in concern about being fully informed. So I think that these are all things that we can address just by listening to people, educating them about the research, what's being done, and how we're going to make progress. And I think that I've found this to be successful for people that are able to do some of these research things with us. This is a collaboration I did at Johns Hopkins when Misty was a fellow over there. This is looking at 150 Black and 150 white Americans with multiple sclerosis at Hopkins and WashU over 4 visits. The good news is that there is no difference in age of diagnosis, time to diagnosis, frequency of training involvement in encounters, documentation of smoking status, and level 5 visits. In fact, Black patients were more likely to be on a treatment, 87 versus 75%. Black patients were more likely assessed on cognition, mood, and physical activity. The visits for the Black patients were slightly longer at 1.5 months between 10.3 versus 8.8. And there's no difference in the evaluation for MS relapse to have MRI findings considered in the level 5 visits. This may speak to sort of the electronic health records, that we have this templated approach so that we're always providing consistent care to everybody. But I think that this is, good news that, the EHR perhaps is standardizing the way we treat everybody, and people are kind of on these care paths, and this analysis seems to suggest that there are some similarities between centers that kind of have this type of an approach. This is evaluating how many months it takes to start a disease-modifying therapy in this top corner, and then this is looking at the initiation of highly effective disease-modifying therapy. And among Black Americans and white Americans, there really is no difference to the time to start. And then in looking at the line of initiation of first high-efficacy therapy, there's no difference between the Black Americans and the white Americans in using high-efficacy therapy. This is evaluating across the years of initiating any high-efficacy disease-modifying therapy, and the Black Americans are in this solid blue line, and the white Americans in this dashed line, and what you can see is that these overlap one another, and that there was a big increase in 2017. I think that was when we had our first approved CD20 therapy available. So I think the uptake of the highly effective therapies has been really adopted among patients who need it, including Black Americans with severe MS, and I think that this supports that. I like looking at studies from other countries just to kind of get a view of what social determinants of health is like outside of the US. So this is the OFSEP. They have a number of studies that have been published, if you're interested in this type of data, from France. And here they looked at educational levels, dividing into 4 categories, with the lowest being just primary school, and then the highest is being like graduate school. And what they found is that the least educated patients had the highest probability of achieving EDSS milestone of 4. So I think that is this solid blue line here. So here you're seeing this relationship between education level and outcomes. And then here, this is women with relapsing MS. They found that initiation of disease-modifying therapy was shorter among those that were the most highly educated. So there seemed to be a bit of an advantage there. So here, again, looking at social determinants of health in terms of treatment and outcomes. This is an interesting study that came out recently about pediatric MS and social hardships. It looked at the network of pediatric MS centers with almost 1,000 participants. They characterized social hardships as public or no insurance, maternal education of high school or less, single or no income, household income, and of the patients in the study, about 2/3 reported at least one hardship. The hardships were associated with tobacco exposure, immigration, obesity, sex, race, and ethnicity. Interestingly, though, they did not find a significant difference in the time to disease-modifying therapy initiation, perhaps speaking to sort of the commitment of this network of centers that has really prioritized pediatric MS care and making sure that people are treated regardless of sort of what disadvantages or lack of support they may have. But they did find that those that lacked private insurance had higher EDSS scores with follow-up overall. And that's what this graph shows here. These are mortality studies on socioeconomic status, one out of Canada, one out of France, and they both found that mortality was higher among those who coming from the zip codes with lowest income and socioeconomic factors in both countries. And again, looking at Canada and Wales and 3,000 patients using neighborhood socioeconomic status factors, dividing them up into quintiles, there's a shorter time to reaching EDSS milestones and secondary progressive MS with lower socioeconomic status as the variable. We were involved in this registry called MS Pass. There were over 1,200 Black Americans and 7,500 white Americans. A lot of this was done out of Hopkins with Carla and Ellen, and we were involved as well. They found things that were quite consistent with the studies that showed MS to be more severe in Black Americans in the 2000s. Black Americans were younger, with shorter disease durations, more likely to be disabled or unemployed, more likely to be on Medicare, similar numbers to being treated and more being on an infused therapy, 24% versus 17%. More disabled on patient-derived disease steps, higher walking speed, higher manual dexterity and processing speed, and worse MRIs. They found that the quality of life more so correlated with socioeconomic status and disability, but not necessarily race. So I think a lot of the things here are reckoned back to the studies that were done in the 2000s in terms of disease duration, treatments, disability, all those types of factors. And then socioeconomic status and mental health and health-seeking behaviors in MS. They did a variety of different surveys, found that those at low SES had worse scores on these quality of life surveys, that race and ethnicity were not associated with self-reported fatigue, depression, or anxiety, but there was interest in mental health care if co-located with MS services. So if you're able to incorporate mental health in your practice, this could be something of benefit. So again, kind of coming to, what do you do with this information? What kind of recommendations would I make? What do you think you would do in your practice to kind of hone your visit and your relationships and your care team and the support that you're able to provide? So I think, careful treatment selection, considering the inflammation and tissue injury burden, spending extra time discussing benefits and risks, adherence, really becoming accustomed with manufacturer assistance programs, talking about risks for rebounds with certain treatments like S1Ps and natalizumab. A lot of attention to childbearing potential and contraception and optimizing best time, making sure that they have good care through OBGYN. More frequent follow-ups in the beginning, having frequent follow-ups after a medication change. We alternate visits with our nurse practitioner, which I think gives two very good points of view about how to treat their disease. Social history should really be more than just smoking and alcohol use. I go through employment, disability, who's in the household, education, children, grandchildren. I'm going to start asking more about income sources. And I think this is all good stuff just for having nice visits with patients, just to kind of know more about them in general. So I enjoy kind of collecting some of the stuff and going through it with them. Referrals for PT, OT, cognitive testing, vocational rehab. We've incorporated social work more so in our clinic, disability application support. Particularly black men are at extremely high risk group for disability, so some extra support there, making sure that all the visits are followed. Educational things, discussing research breakthroughs. I think when you come to these meetings and patients ask you, like, what's new? It's like, well, I was just in Florida. We had our biggest American meeting about MS, and I learned a couple interesting things. And, for example, so they would love to hear from you in terms of what happened at the meeting. And sometimes I'm away at meetings, and patients are upset that I go away to meetings, so at least they could hear about what I learned. They'd probably enjoy that, and I think they do, just hearing a couple words. It doesn't have to be a long lecture. It just has to be like, oh, we found this out. And most important, enjoy the visit. Get to know your patients, ask about the family, look at the pictures that they have on their phones. Tell them when you're concerned, ask them to send you updates if you're making any changes, and just provide as much encouragement as you can when they're taking care of themselves and doing a great job at it. So that's the summary. So I think I'm on time, yeah? Good, thank you.
Heading into the home stretch, and then when we finish up with these talks, I'm going to come back with the iPad and go over a bunch of the questions because we will have some time. So the next two talks are by Amy Perrin-Ross, an advanced practice nurse from Loyola University Medical Center in Illinois. And the first is going to be on the important topic of family planning, and the second on patient education and shared decision-making and tools. So welcome, Amy.
Thanks, Dr. Lublin, and thank you, everyone, for sticking it out till this hour. I know you're all excited to hear all about family planning and sex at this hour, right? If you're as tired as the rest of us, it may not be as interesting. So we're going to look at family planning, and when we think about family planning, we think about it from a broad spectrum. It includes not only pregnancy, but also things like surrogacy, adoption, other family building methods, same-sex couples, for example, single individuals who are looking at starting a family. And as we talk about family planning, we'll realize that it's more than just the conception that we need to think about with our patients. So I know that when I started in MS, as well as some of our other faculty, Pregnancy and family planning were not terms that were used in the same sentence. For many, many years, well beyond the 50s, into the 70s and 80s even, women were advised not to think about pregnancy. That wasn't a good thing. And then we got the disease-modifying therapies, and they were told, oh, no, no, if you're going to be on these drugs, you can't possibly think about pregnancy. But obviously, attitudes have dramatically changed, and that's in large part thanks due to things like pregnancy registries and information that's collected by the pharmaceutical companies, by our pharma partners, to help further understand pregnancy and what it means, not only to the woman, but to the fetus and beyond. So today, obviously, there's much more optimism and hope for pregnancy. So we know that MS is the immune-mediated disease with the female prevalence, and we know that it tends to affect people between the ages of 20 and 40 in the female reproductive years. My practice in my institution is somewhat skewed because we're partnering with a large VA system, so I have many older men in my practice as well. But if we think about MS as a general scheme of things, we think about younger females. And the important point here is that pregnancy actually involves a state of immune modulation rather than immune suppression. Lots of misconceptions about, oh, when you're pregnant, your immune system is suppressed. Not so. I mean, that sometimes strikes fear into our patients, thinking that if their immune system is suppressed when they're pregnant, does it make them increasingly susceptible to things like infections? The answer is no. It's immune modulation rather than suppression. Obviously, multiple hormones involved during pregnancy and hormonal changes and fluctuations after delivery. I don't know about you, but I tend to be an extremely visual learner. And one of the things that I appreciated as I was going through all of the information to prepare for this talk are some of the visual tables, the tables looking at the various different disease-modifying therapies and what we know about them from a pregnancy registry stage, what we know about them from a fertility stage, what we know about them from lactation. This article that is cited here, Oreja Guevara, happens to be one of the better ones in terms of providing tables. So if you're a visual learner, that's a good option. So what about contraception? In a study done that was reported by Kelly and colleagues, about 87% of US women use contraception during their lifetime, and recent US CDC guidance considers most forms safe. However, they talk about using hormonal contraception with additional caution in people who are immobile, for example, based on their thromboembolic risk. So we need to think about that in terms of our perhaps more disabled population. Now, current disease-modifying therapies are not known to impact contraception, but there is the potentially negative hormonal contraceptive interactions with some of the various different medications that we use for symptom management. And we just had a wonderful presentation on symptom management, but we need to keep all of these things sort of spinning in the back of our head as we're looking at this. So when we think about family planning and contraception, the goal obviously is to avoid pregnancy exposures. And just like Dr. Naismith said, get to know your patients, find out about them, talk to them about who they are and their families and things of that nature. Get to know them on a level if family planning is potentially going to be in the mix, because that's something that you're going to want to be comfortable with in terms of talking to these patients. Long-acting reversible contraception actually is preferred for its high efficacy and its ease of use, so we really prefer the long-acting contraception whenever possible. So what about fertility and fertility treatments? Well, a greater proportion of women with MS have a diagnosis of infertility compared to those without MS. And you can see the differences here, 8.5% versus 8.1% in the statistical significance. A recent study, as reported here by Graham et al., reported no increase in relapses after a variety of fertility treatments, including in vitro fertilization. And if you talk about an even more recent study, something that just came out last Thursday, actually, was a study by main guy in neurology that looked at IVF in France. And the main finding for that study was that there really is no increase in relapse activity among several hundred women in a database in France. So this continues to kind of reinforce the information that we have. Now, if a patient, if a woman requires multiple cycles of fertility treatment, it's really beneficial in many situations to keep them on the disease-modifying therapies with no known oocyte effects. So again, this is a discussion that needs to be had between us and our patients, finding out what they're comfortable with, where they're comfortable. It should be discussed early on in our interactions with our patient population and periodically brought up over time. Now, there's a lot of discussion amongst MS neurologists now, and something was mentioned earlier this morning about the idea of if a person is diagnosed with MS, if a woman is diagnosed with MS now, and is considering pregnancy, but not right away, perhaps down the line, how does this factor into our initial choice of disease-modifying therapies for our patients? Perhaps with some of the discussion that Dr. Friedman led us into this morning, looking at the impact of anti-CD20s and what their role absolutely is. So many women do avoid pregnancy due to misconceptions, and some of the misconceptions and some of the truths actually are that some women do experience MS worsening during pregnancy. For the most part, and I've had a long history of caring for women who have gotten pregnant with MS, for the most part, they've done extremely well. Sometimes a little concern in the beginning, but for the most part, they've done very well. I did, however, very early on in my career, have one woman who simply had a major relapse about 6 weeks into her pregnancy and continued to have just horrific symptoms and side effects to the point where she independently decided to terminate that pregnancy. She did go on, however, 3 years later to have another pregnancy which was successful and, in fact, resulted in twins who are absolutely adorable. One of the other concerns that women sometimes experience is the ability to care for a child secondary to MS. And Kelly's article talks about this in depth, about women's concerns about what will I do if I don't have assistance, who's going to care for this baby if I can't even care for myself. And these are very legitimate and valid concerns for sure. Others are concerned about stopping disease-modifying therapies to attempt pregnancy, stopping them during pregnancy. And as I mentioned, there are some good references in these articles, some really good tables about who stops what and when. So in terms of issues for counseling, no increase in birth defects based on MS alone, really no increase in abortions or ectopic pregnancies. Other more key important point is no impact on the type of delivery. So vaginal or cesarean is fine, and again, just because a woman has a previous cesarean section does not mean that she needs to necessarily have another one. That's a discussion between her and her OB. No limitations on the type of anesthetic used for delivery, and there really doesn't seem to be a negative impact from a father with MS. So what we want to think about are some of the issues for counseling. Pregnancy does not worsen the long-term MS prognosis, and actually a few studies say that it improves the prognosis. So most patients tend to do quite well, especially during the last trimester. However, relapses can occur during pregnancy, and I think about one of my patients who is a PhD educated woman who's in early childhood education. And she's had 3 pregnancies on disease-modifying therapies, and every time she comes in, she swears to me she doesn't know how this happened. I want to know what she's doing in early childhood education, but nonetheless, her second pregnancy, we stopped. She was on S1P receptor modulator, and we stopped it when we found out she was pregnant, and she, about 8 weeks after we stopped it, had a severe relapse in her second trimester. We were able to get her through it, but nonetheless, these things can and do occur. So as I said, relapses do occur. However, they tend to be less common. Results from the pregnancy registry in MS actually showed a drop in annualized relapse rate from 0.7 to 0.2, or about a 70% decrease. If we need to treat pregnant women for relapses during pregnancy, methylprednisolone or prednisone is preferred over dexamethasone because of the impact of crossing the placenta, and the ideal time is the 10th week of gestation because of its timing in terms of organogenesis. Plasmapheresis has been shown to be safe, but we do need to monitor quite closely for rapid fluid shifts that can and sometimes do occur. Ideally, if we know a couple is doing some family planning, we might want to get a baseline MRI. That's always the ideal situation. If an MRI is needed, that's a discussion to be had with the patient, the family, and the radiologist, and it's generally done without gadolinium, looking for the presence or absence of new T2 hyperintensities. 2018 AANN practice guidelines for disease-modifying therapies in MS. I would venture to say that we really need to update these. And this, again, is from the table in the Oreja Guevara article about the various different guidances, thousands of human pregnancy exposures with GA and the interferons. No washout requirement there, can't be used during pregnancy and breastfeeding. Washout recommended with the S1P receptor modulators, as you can see here, and certainly for teriflunomide, pregnancy excluded, and the impact is not only on the female, but if the male wishes to father a child, that accelerated elimination procedure is also recommended. Cladribine, you can see the recommendations here based on the package insert. Probably acceptable to breastfeed with the monoclonal antibodies. Again, more and more discussion back and forth with that. And natalizumab is often used with no washout and continued into pregnancy. This is from a very recent article on Sue Riley-Bovey et al. Again, excellent table if you're interested in the concept of breastfeeding and the impact of disease-modifying therapies. The key issue, the take-home issue with respect to breastfeeding is exclusive breastfeeding. It doesn't mean a couple bottles a day and then one breastfeeding at night. The protective effects of breastfeeding seem to occur in women that do exclusive breastfeeding. And so thinking about, are you going to breastfeed or aren't you, it's important for us to help women understand the exclusive nature of it is the thing that's really quite protective. Postpartum issues, sometimes MS symptoms that have been extensively covered and postpartum problems aren't really easily differentiated. Postpartum depression and anxiety are a substantial concern because we see it comorbidly with our MS patients on the new compound postmortem activity and hormonal changes on top of it. You can definitely see risk factors for depression. And a final word about menopause. And again, recent studies talk about the fact that despite MS, the overall quality of life is comparable to that of healthy controls experiencing menopause. And the thing that's a challenge not only for us, but for our patients who are experiencing menopause and MS symptoms is that the symptoms listed here are the most frequent menopausal symptoms reported in a large study of women experiencing menopause with MS. So in summary then, family planning and contraception should be discussed with all appropriate newly diagnosed MS patients and their partners. And the only way to know if they're appropriate is to do what Dr. Naismith said, and that is to get to know these people as well as you possibly can. Accurate information needs to be provided, including information about disease-modifying therapies as well as breastfeeding. And all healthcare professionals who care for people with MS must be up to date on gender-based issues. So thank you. Okay, pull up the next stick on patient and family education. Great. All right, we'll move into the next talk, and that is on patient and family education. The goal for patient and family education really is to guide the patient towards self-efficacy. We aren't there all the time and can't be with those patients all the time. So what we want to do is promote maximal health potential, promote their coping and adaptation, looking at self-care and self-confidence in these patients, and empower them with hopefulness. So what we as clinicians need to do is a learning assessment. We need to look at, is this patient ready to learn? How many times have you seen people in your office who look like a deer in headlights, and literally, if I were to tell them right now to go jump into frozen Lake Michigan, they would say, okay, I'll be right back. Because they're simply not ready to learn. They're not ready to hear. They've heard the word multiple sclerosis and everything else goes out the window. So we really need to assess their readiness to learn, and not just on their first visit, but on every visit that we have with them. Find out what they know about MS or what they think they know about MS, what their style of learning is. Dr. Naismith did a wonderful job talking about cultural aspects and healthcare literacy, looking at what the role of the family is and what some of their coping mechanisms are. One of the challenges for me in terms of cultural literacy is that I have a very large population of very diverse cultures. We have a population of Italian immigrants who are fairly recent Italian immigrants. And I remember having actually a 22-year-old young man come into our clinic, and we ultimately diagnosed him with MS. And when we said, you know, we'd like you to come back with whoever's important to sit down and listen to our discussion and try to make some decisions about what we're going to do to treat this disease, 17 family members he brings with him for the next visit. Think about putting 17 people in an exam room. Okay, you adapt, you do what you need to do. But basically, we have to take into consideration the values, beliefs, norms, and practices of a particular group that are learned and shared in terms of decision making. It affects how people view their health. It affects how they respond to recommendations for lifestyle changes. And it guides their actions and decisions that facilitate their ability to get through their lives day to day. So guidelines to facilitating learning, what can we do? Obviously recognizing each individual as unique, and one of the challenges is when you have people with very different learning styles. I have a patient, Jake, who's 19 years old, who came in with his mother, who happens to be a retired nurse. She did all the talking, he did the listening. Neither one of them listened to one another, and we've gone round and round with them on several occasions. The only thing that Jake said to me on the first visit was, "I ain't taking no shots." Fine. So we spent a lot of time, subsequent visit, talking about orals and things of that nature. We really didn't want to do anything with respect to injections or infusions. So we sent him home with some literature about a recommendation that we were making, and his mom said, we want to talk to Jake's dad. We'll call you next week. Okay, fine. Week and a half goes by, and she finally calls me, and she tells me that he wants one of the injectables. And I said, wait a minute. He said he wouldn't take a shot. She said, oh, no, he won't. But he's going off to college. I'm a nurse. I can give him his shots when he's at home, and I've already set up with the school nurse that she's going to do the shots for him while he's there. So we will know he's taking stuff. He's 19 years old. He's never taken a pill in his life. He's not going to take a pill when he goes to college. So honestly, they really looked at what worked for him and what wouldn't work for him and made a decision. These are some of the learning needs, various different treatment options, symptoms, recognizing the difference between a symptom and a relapse and disease worsening. I mean, I spend a good portion of every day helping my patients try to figure out, are they having a new relapse, or is this a symptom related to the fact that they just came back from Mexico and spent 2 weeks in a hot tub? Well, maybe. Discussion. We encourage patients in to bring their family members to the appointment. As I said, do our best to assess what their educational needs are. Talk about diagnostic findings. We pull the imaging up on our computers, and if they've had previous imaging, we're going to put, the most recent one with the current one side by side and show them what's different, or in many situations, what's not different, what gives us the basis for our recommendations and things of that nature, and also the meaning of disability. What disability means to me is something very different than what it means to a number of our patients. We have a young girl who's 16 years old, and diagnosed her with MS. She came back about 3 weeks later with her mom to talk about disease-modifying therapy, and Mom had a whole handful of Social Security disability forms. I said, what is she? Oh, she's got MS, she's disabled. We need to fill these out right away. Mom was much more interested in disability than she was looking at disease-modifying therapy, and the poor young girl didn't know what she was interested in, so it presented all kinds of challenges for us. But thinking about what disability means to people, what about disease management goals? My goals for disease management sometimes are very different than my patients' goals for disease management. Things that I would not find acceptable in terms of quality of life for myself, some of these people are okay with. If there's something I can do about it to impact it, to improve it, that's great. But if not, what I need to do is provide them hope for the future. So we look at fostering realistic expectations. Realistic expectations are critical to the success of long-term management as well as adherence. Provide as much balanced information as we possibly can. Refer our patients to various different sources, the National Multiple Sclerosis Society, the Multiple Sclerosis Association of America, the Multiple Sclerosis Foundation, Can Do MS, and the CMSC. So try to work with our patients to help them critically evaluate MS educational materials. We were at a faculty dinner last night talking about commercials and how it seems as though every person who's got diabetes and is taking Jardians has uncontrollable needs to dance, right? And so we look at some of the kinds of things that are hitting us from a media perspective, not just us who are consumers of healthcare ourselves, but our patients, and try to help them tease out the reality while still offering hopeful options for them, but helping them to distinguish between what's realistic and what isn't, perhaps in each individual patient. General advice for motivating patients, trying to help them be adherent to a treatment plan. Jake and his mom figured out what would work for him, even though his idea and mine were very, very different on his first visit. Find a strong support network that includes other people with MS. Now with more virtual options, more online options, some people find this very, very helpful. Others are like, nope, no way. I don't want any part of that. Look at implement.
No new lesions, it's probably right. If the AI says there is a new lesion, you better pull that up and look. I think it's our take home, at least for this current state of the art. Another area where AI may start to play into things has to do with wearables and patient-reported outcomes. And I think we all know that we talk a lot about progression in MS, but our ways of measuring progression are incredibly incomplete and limited. I'm looking at you, EDSS score. It really doesn't encompass more than a fraction of what the patient means when they say they have progression, when they say they're getting worse. And so we've wanted for a long time to get a more comprehensive look at how the patient's doing in real time, in real world situations. Because in the clinic, you're seeing the patient for maybe 30 minutes, twice a year. And we all know that MS's symptoms fluctuate fairly wildly with time of day, with weather, with how stressed they are, with how well they slept the night before. And so what we see at that snapshot in clinic may be very inaccurate related to how they're actually doing. And so for a long time, the idea of wearables, the idea of survey-based tools where the patient kind of fills in symptoms at home has been intriguing, but nobody quite knew what to do with that massive data when they came into the office and handed you a stack of papers, like, what do I do with this? But for the first time with AI-based tools, this may become viable because this AI tools are optimally positioned to really analyze this kind of data and pull out patterns from it. So this may turn into something that becomes useful in terms of clinical monitoring in the future. Okay, other ways in which AI will be and is used in MS care is simply for patient education and engagement. I guarantee your patients are already asking ChatGPT all kinds of questions. I asked it, I said to ChatGPT, I've just been diagnosed with MS, what should I expect? It gave me a whole list, gave me a whole rundown, and it wasn't bad, I have to say. I asked it, how can I exercise if I'm an MS patient? And again, it wasn't bad advice. So your patients are going to be and have already been asking ChatGPT these questions, and so they're going to treat the chatbot as a kind of medical advisor. And there's good and there's bad there. So there's positive things, but you're definitely going to have to put perspective on those things because there is a perspective that comes from just seeing hundreds and thousands of patients that the chatbot still doesn't have. Chatbots, so there are some interesting things that chatbots can do. As I was playing with this, I said to the chatbot, I need a therapist who does pelvic floor physical therapy near Hartford, Connecticut within 20 miles. And it gave me a list. And so this is sometimes hard to find in the real world. Let's say I want someone to get pelvic floor physical therapy, or I want someone to do therapy with someone who knows MS. I don't always know the names of all the providers locally who do that or near someone's zip code. And so actually the chatbot seems to be a tool that you could try in those situations to get those resources. Similarly, the chatbot may help identify resources for patients. I asked it, give me MS support groups near a zip code, and it came up with a reasonable list of chat support groups. So this is a tool for patient education engagement, may also help us as providers to get resources that are geographically specialized to patients and identify other medical providers who have expertise that's helpful. We are, at my institution at least, being encouraged to use a virtual scribe for medical notes. There's other ways in which AI has been started to be leveraged for increased physician productivity, including organization of the EHR. It should be able to fill in forms automatically, should eventually be able to decrease data entry, although this does all require institutions to put some effort into bringing the tools on board. It should be able to optimize billing and improve reimbursements in theory. And chatbots may have a role in some of the routine administrative tasks or triaging patient phone calls, scheduling, things of that nature. On the research side of things, there's also a big area where AI is and can be involved. One of the most exciting, I think, is biomarker discovery. And we have been seeing large numbers of papers coming out talking about genomics data in MS, talking about microbiome data in MS, metabolome data, immunophenotype data, soluble biomarkers, and we're talking hundreds and thousands and tens of thousands of data points for any given patient, and we just can't wrap our heads around it, and I guarantee that you're not going to find one biomarker that predicts MS. It's not going to be that simple. But there may be patterns that we as humans can't quite wrap our heads around. There may be interactions between genomics and metabolomics, and these patterns will be better visualized using AI tools. And so stitching together these multi-omic data sets is one aspect where I think AI can be very helpful on a research and discovery basis. As you can see, others think the same. These are numbers of AI-based publications focusing on fluid biomarkers in MS over time. At the moment, these are still limited data. Our relatively small data sets will and do limit the generalizability, and this research is still in very early stages. Generally, best practices for AI and machine learning is that you have a training data set and a validation data set that are independent. And at the moment in MS, we don't yet have those big data sets built up for optimal training of models, so that's something to work towards. Medical record review is another research-based area where AI can bring help. I think if you've ever done a chart review-based project, you understand the pain of trying to abstract from medical records data in a meaningful way, and yet we all want to be able to learn and grow based on our patients' lived experiences, and I think that's been historically hard in the US system, but becomes easier as these natural language processing tools get better and can abstract from the medical record for us in a meaningful way. For those who are not data scientists, it turns out that ChatGPT and its cousins are actually quite good at generating code, and so if you cannot write in Python or JavaScript, you may be able to get the chatbot to write your code for you, and you can just tweak it. I'm looking forward to this as a non-data scientist. And then on the clinical trial front, there's a number of ways in which AI will be getting involved. I talked already about redefining MS progression. The EDSS and our historic traditional biomarkers of progression are very incomplete and artificial. And that has been a barrier to successful trials in progressive MS forever. So this gives us the opportunity to redefine progression in more real-world terms and hopefully start to generate novel outcome measures for progressive MS clinical trials that move us down the path towards getting something that can more effectively treat progressive MS. Additionally, in the clinical trial space, AI-powered tools may end up being useful for recruitment. If you have ever tried to recruit for a clinical trial, you know it's difficult to just finding the right patients, especially in MS, where You can't just search for a G35 diagnosis in the chart and expect that those patients are going to qualify. AI-powered tools may help in identifying more appropriate candidates based on electronic health records, may also help in targeted advertisement for trials. On the sponsor side, it may help them select sites for their trials that have the greatest chance of being successful given their recruitment goals. And it may help with automating tool tasks like data entry and regulatory document preparation. More on the analysis side of clinical trials, AI can help facilitate adaptive trial designs to squeeze more power out of fewer patients and provide predictive modeling that helps the trial flex while it's running so that they're not locked into what seemed right in 2019. There may be more flexibility for adaptive trial design using this AI type of tools for design, as well as what we talked about before with analysis and integration of complex data sets. In terms of medical literature, there's a lot of room for education that AI is improving. So Open Evidence is one such platform. There's a couple others that are large language models that have been specifically trained on the medical literature, on PubMed, on the medical papers. And so these are tools for synthesizing the medical literature and getting answers to specific questions with a little bit less effort than is required on doing a manual literature review and using PubMed or something like that. So this is a great starting place for learning and for literature review. These tools may not have access to full text articles, and so they are probably not going to be fully complete, but it's a great place to start. Similarly, these medical large language models, like this one, Doximity has one, there's some others, they can generate letters for prior authorizations for you. Give them the scenario, it'll write out your letter. You can make patient handouts. Again, you're going to want to check them for accuracy, but it gives you a draft. And as well as you can provide de-identified patient histories, and it might give you diagnostic suggestions or things to think about. So all of these things, it's like brainstorming, pinging ideas back and forth and iterating them. Just as an example, I asked Open Evidence what has been published about AI and multiple sclerosis, and here we have a list of starting places about what's been published. So that's a lot of stuff that sounds pretty exciting, pretty good. And I don't think we're becoming obsolete because, again, all of this AI stuff requires interpretation and perspective that we as the human doctor give. But I do want to just highlight a couple points about ethics and artificial intelligence. So I've talked a lot about ways in which it can be good, efficiency, productivity, pattern recognition that we as humans can't quite wrap our heads around, data interpretation and access to information. But on the other side of the equation, you can put things like the potential for bias, the potential for loss of privacy, the potential that we have no idea what's in the black box, like what is actually being used in that model. And then adversarial attacks are possible with this as well. So just as an example, these are earlier AI. This is not large language model stuff, but you can see that early in the development of AI, people who were Black were inaccurately labeled by the AI as gorillas. And similarly, an Asian face was identified as blinking. And so essentially, the data that the model is training on is dictating the outcomes. And so if it's training on biased data, if it's training on propaganda, the answers and the things that come out the other side of the model are going to be skewed, they're going to be biased, they're going to be also propaganda. And so this is a risk of AI. The computers only know as much as they're trained on. Additionally, the criteria used by the computer to make their classifications are usually unknown. That these are what's called unstructured learning, where the computer is just recognizing patterns within the data, and sometimes that's informative. Sometimes that actually tells us something about biology. Other times it may not. So an example was given in a book about AI that I was reading that said, they were trying to train the AI to recognize animals and separate that from landscapes. That was early in. I think the training set got really good at saying, oh, this is an animal, this is an animal, this is an animal, and this is a landscape. But it turned out that it was actually recognizing background blur, because the animal pictures tend to have kind of a blurry background and the animal was in focus in the foreground. So it wasn't recognizing the animal, it was recognizing the blurry background and classifying it as an animal. So you don't really know what criteria the computer is using to make their distinctions. Similarly, there is the possibility of external manipulation, where there is computers, there are people who want to break computers. There's always hackers. And so these are examples. In this case, these are images that were created specifically to fool the neural network. And so the neural network was quite confident, 99% certain, that this was a robin, and this was a cheetah, and this was an armadillo, and this was a panda. We don't see that, but the algorithm was tricked into thinking the same. Similar with this set of pictures, the first picture is one that it correctly identified as a school bus. The second, people manually went in and changed some pixels that we don't see any difference between those pictures, but the small pixels were changed to the extent that the AI is now confident that this is an ostrich. Same thing for a praying mantis and ostrich. And so there is the possibility of external interference and manipulation with the models. And so the security is something that needs to be considered. So final conclusions and considerations on ethical issues. AI needs to be used responsibly, and there's a lot of talk now about how it can be used responsibly in the process of scientific communication. It may be very useful if you're an editor or a grand rounds planner in finding experts on a topic who might be a good speaker. But on the other hand, you're not allowed to use AI to do your peer reviews for you. Very bad, don't do that. You don't know what goes into the algorithm, and so what you put in may come out for someone else. So if you put your grant in, well, somebody else might get that idea as coming out the other end if they ask us a question in that respect. So there may be some privacy and intellectual property concerns. We've talked about its use for brainstorming, and it can be very helpful here. And there are increasingly institutional instances of generative AI, which in theory are behind firewalls and have increased privacy metrics. So all of this is stuff that we are going to be seeing shaking out over the next few years. My final message is trust but verify. AI chatbots do hallucinate from time to time. They have been known to make up very accurate sounding data and literature, citations even, that just don't exist. The authors may be real, but the paper is totally hallucinated. So trust but verify if you are using AI in terms of medical literature and knowledge generation. So in conclusion, artificial intelligence is a very powerful technology that is reshaping many aspects of healthcare and biomedical research. It has already had a significant impact on direct care for people with MS, and it's going to get more so. And so we need to be aware of what it can do and use it as appropriate. AI-based tools have potential to make personalized MS care much more of a real possibility than I think it has been in the past. And similarly, AI-based tools can enhance many aspects of MS research. But like any tool, AI-based technology has caveats and risks, and if you're using it, you should be aware of those. And I asked AI to generate an image asking for questions to show at the end of my lecture. And I thought this is just a great picture because, is it going to take your jobs, folks? Not if this is the kind of questions it's generating. So that does it. Thank you, everyone.
Is Pat still here? Pat, can you come sit over on this side? Any other faculty that are here? Was Stephen here? Any other faculty? Oh, good, yeah. Come over there because I want to pass around the microphone, and it'll make it easier for Patrick so he doesn't have to get his exercise. And so we're going to go over some of the questions. I've been told that if we don't get to all of them, that the academic CME people will work out something so you get answers in the not too distant future to your questions. And I'm just going to triage them because not all the faculty are still here. But one of the questions has to do with the risk of infection in individuals with low IgG versus low IgM. Jeff, you have an opinion on that?
Well, so typically with the B-cell depleters, IgM goes down first, and then IgG. We tend to pay more attention to the IgG. We're not quite as proactive as Dr. Friedman said he was earlier today. We typically wait for there to be some indication of increased infection risk. And then if there are no other options for treatment, then we'll also start concomitant IVIG.
Any other thoughts? Okay, another question. This is a good one. Have there been any studies of de-escalation going from high efficacy and at some point de-escalating? So who wants to discuss de-escalation studies?
Well, there actually are several trials going on now of de-escalation. I think they're going to suffer from some of the same issues as treatment discontinuation. In a young patient, relatively young patient with relatively recent disease activity is likely to return. In older patients with only remote disease activity, you're more likely to be successful, although sometimes unexpectedly we've seen return of relapses or MRI lesion activity. So that's a good example of something for which shared decision-making becomes important.
Yeah, that latter is very important. I'm actually very interested in this because I don't think that the activity that's there when you start people is necessarily going to be activity down the road. I mean, we know the natural history of relapse rate goes down. And so I'm actually very interested. And I talk to people now saying that when I start them on one of the anti-CD20s, I don't expect to keep them on that forever. I just can't tell them when I'm going to stop them. But I do think that we need some data around that. And I think it's going to be important because as we keep them, we've heard about some of these other complications that we've seen with anti-CD20. And so de-escalation is probably a good idea. Okay. So there's another here. Any studies planned about prolonged effect of post-B cell activity? And I think you may have heard that Amit Baror is not here, but he's running a study looking at what happens when you stop. And I think Mark Friedman discussed the idea that what comes back may be more regulatory, or at least not as pathogenic. At least that's the hypothesis. I must say I've seen studies that support both, including your comment about return of activity. So that'll be interesting to see if that's the case and how long you can keep people off of the B cells, or even the idea of treating by B cell level, which is kind of out there but not been properly studied. Okay, sorry this is a very small print here. Okay, I'm going to throw this to Amy. Do you feel like general neurologists should be able to start the MS-DMTs?
Do I feel that general neurologists should be able to prescribe? Yes, I think they should. I think if they have concerns and questions, they can also always encourage their patients to seek a second opinion. But yeah, I do.
And that's why we hold meetings like this. Okay. And here's another question about potential relapses or rebound, actually, after S1Ps. And is there a difference amongst the different S1P agents? Who wants to tackle that one? Anyone know any data?
I don't know if we have a great answer to that. I mean, the concern for rebound when a trafficking agent is stopped, I think, exists for trafficking agents, for natalizumab, and for the S1Ps. Most of the S1P data in this regard came from fingolimod. I think we conceptualize that as a class effect. I think there may be some evidence that rebound is not as frequently observed with ozanimod, or at the very least, there haven't been the same degree of reports of that. So in trials where people have been switched off of ozanimod, I don't think rebound has been seen to the same degree. But I think one has to approach that whole class of medicines with caution in that respect.
Because ozanimod is a long half-life agent, like fingolimod. Here's a very interesting one, and I don't know if they saw the recent article about this. It says, Darren Nakuda and colleagues published a case of breakthrough disease in a patient placed on generic teriflunomide, and when they tested it, the medication had only 50% of the labeled dose. And just in the last I must have seen it this weekend, there was also an article, I think in the New York Times, about quality control over some generics coming from out of the country. Any experience with that?
Yeah, so actually one of my fellows forwarded me that Darren's article. So for generics and biosimilars that are approved in what are called highly regulated environments, United States, Canada, Europe, at least initially, they're approved on the basis of being comparable to the brand product, and they can be thought of as being equivalent. The issue is exactly what you alluded to, is that post-marketing surveillance that the quality is maintained is probably not 100%. And variability of follow-on products versus the brand product, and particularly between follow-on products, is probably more than we would like.
Okay, I'm going to throw this one to Stephen. How would you approach disease breakthrough for patients who have completed 2 years of cladribine therapy?
Yeah, that's a great question. Because cladribine is sort of gaining usefulness in these last couple of years, I don't think there's a large cohort of patients, at least in our neck of the woods, that have already been on it for 2 years to be in the denominator risk population to have had relapses subsequently. So I have not had that happen in anyone that I've had on cladribine as yet. Maybe that will never happen. But I do think, as you heard earlier, the idea that post the 2 rounds of oral cladribine, we don't have great guidance about what to do next, it can be somewhat unsettling. I mean, the idea is that it has a very long-term effect for preventing disease activity, but nothing's perfect in that respect. So I don't think that there's ever going to be a sort of a guideline or a standard around it, but I think, to come back to my sort of disease-modifying therapy treatment decision shuffle, you then have to see where that patient is. If they're young and have recurrent disease activity a couple of years after they've been on cladribine, then I think potentially all of the options are available to them. I don't think that cladribine precludes later treatment decisions. If, on the other hand, the reason they're on cladribine is because this was sort of a de-escalation strategy for somebody over 60, and now you're looking at them and deciding, does this person really have new inflammatory disease? Approach that with a little skepticism. Maybe what they have is progression. Maybe what they've had is a fluctuation. Do you really need to further immune suppress someone who's older in that respect? So I would just be really thoughtful, really careful about assessing whether someone actually has new disease activity and then deciding what to do next.
Okay, we didn't have a pediatric lecture today, but there's a question here. What oral meds can you prescribe to the pediatric population? Anyone want to handle that? All right, fingolimod is approved for kids here, and I believe teriflunomide is approved in Europe from the Terry kids, but not in the U.S. Pat, go ahead.
I would just say that there's not any reason not to use what you think is the best therapy. There is some data with B-cell lytic agents, and you may have very active disease and active relapsing component in pediatric MS. There's no reason not to use the optimal treatment early on.
Okay, thanks. There was a question here about BTKs in progressive disease, and you saw the data for that, so very likely to get a approval for non-active, and I think the FDA is going to use that term rather than non-relapsing, non-active progressive disease. And you heard the arguments about why it may well have an effect in relapsing disease. In terms of combination, which is in this question, That's going to be tougher to do for a variety of reasons, not just cost, but the potential for double immunosuppression. Here's a good one. How do you go about deciding the disease-modifying therapy in a patient who is prioritizing cost? We heard a little bit about this earlier. Stephen, you want to try that one?
Well, I guess that's the flip side of there's concerns with generics and you don't know what you're getting and the quality control could suffer versus we want to prioritize cost containment. We try to not let cost issues profoundly affect what we're prescribing. It's hard not to. But what I would say is if you're going to be in an MS practice or you're going to have a substantial number of patients with MS in your practice, to get really familiar with the ways of using pharmaceutical company support programs, National MS Society programs, MSAA programs, other foundation support, et cetera, to try to get costs covered and paid down and decrease someone's out-of-pocket. There are a lot of ways to do it, but we're in a very fractured system, and it's a constantly moving target. So you do have to sort of stay abreast of some of those things. I don't know that generics are always the answer. Just earlier today, you said you saw something in the Times about generics causing problems. Just earlier today, I had seen an article. I have not validated this by looking at source information yet, but an article about how in the UK, patients on branded Tysabri are being switched to the biosimilar, which is being called Tyruko, and there's apparently been a whole bunch of adverse events and relapses and problems that they're now trying to get a handle on in the UK. We don't have that in practice in the US yet. But I think all of these are consequences of attempts at cost containment. And we need to prioritize the person in front of us to see what resources can be used to keep their costs down, but not compromise their treatment.
Okay.
Could I add something, Dr. Levlin? I think one of the things that it's incumbent upon us to recognize is the difference between a compounded therapy and a generic therapy. My concern these days is my patients who are going to compounding pharmacies to get their drugs, whether that's US, Canada, or wherever it happens to be. We had a situation a number of years ago in Chicago where we had a 23-year-old young woman who was taking compounded formiminopiridine and was found dead in the swimming pool. She'd had a seizure and died before her care partner could get to her. That prompted the people at Rush University Medical Center to ask their patients to bring in different compounded capsules of formiminopiridine. So they got 5 different capsules from 5 different compounding pharmacies. And in a 5 milligram capsule, there was anywhere between 2.2 milligrams of active 4AP up to 20 milligrams of active ingredient. So you think about somebody who thinks they're taking a 5 milligram capsule 4 times a day, and what they're really doing is taking 20 milligram capsules. And the reason that I point this out now is because there's so much out there about these compounding pharmacies, particularly with the GLP-1s. I don't think it's going to be very long before they start moving into some of these other potentially more expensive therapies.
And for Jeff Cohen, there's a question here as to whether the remyelination therapies might cause hypermyelination in unaffected areas.
I guess that's possible, although it's not been seen in the animal models of the putative agents.
Fair enough. Okay, and here's a question about, again, pregnancy planning. So how many months after you stop, say, an anti-CD20, can you tell people to go ahead and start to try and conceive? Amy?
I mean, basically what we need to do right now is follow the package inserts for these various different therapies. Some are as long as 6 months, others are as short as 10 days or something of that nature, looking at washout and whatnot. Personally, I find that what goes in the package insert tends to come from what was recommended for the clinical trials, and those recommendations from the clinical trials tend to err on the very conservative side. So these are discussions that I have one-on-one with my patients about what their thoughts are, what their plans are, if you will, how they would like to plan. And again, for each DMT, it's different. And in some situations, I tell my patients to continue to stay on those therapies because the risk of relapse and the risk of worsening of their disease is worse than the risk that might be affected in terms of pregnancy.
Yeah, so people have talked about, Pat, go ahead.
I just say that with regard to the B-cell lytic agents, the anti-CD20s, at least ocrelizumab and ofatumumab, I'm counseling now no pregnancy washout, that they continue it until they get pregnant and then stop the drug. I explained that it's not following the label, but the UK Neurological Society supported that concept. You can use anti-CD20s in pregnancy. There hasn't been any bad effect if you lump together the whole group. Now, ublituximab, I have trouble with just because of that weird maternal primate study that they have that influenced the label. So I'm not doing that for ublituximab, but for ocrelizumab and ofatumumab, yes. I don't think they need a pregnancy washout.
Interesting. Okay, others have recommended 2 to 3 months. And on the other end, I follow B-cell counts when it's time for the next infusion. If they're still at 0, then I just wait monthly and hope for the best. And then I'm going to finish up with a question for Dr. Lombrick. So do you know of any neurology-specific AI medical literature review tools that are currently available?
I don't think I've seen anything that's neurology specific. There's a couple that are medicine specific with open evidence, and there's one with Doximity, and so I think that those are the closest that I've seen.
Okay, it's time to call it a day. So you've been through this for a long time, so thank you all for staying around. Thank you to the faculty who've done their usual spectacular job. Thank you to EMD Serono, Novartis, Sanofi, and TG for providing the educational grants to support this. Many thanks to the academic CME people, Dr. Hayes, Patrick Hayes, Chelsea, and Nicole for the arrangements. I hope you all have a wonderful time for the rest of this meeting, and we'll see some of you tomorrow at the forum. And enjoy your evenings. Thanks so much, everyone.